the front tables which are vacant over there. So last table, they can please come up front. So within 2 minutes, we are going to start.
Yeah, one request to please oblige us, the back seaters, please come and occupy the front seats, please. We will see it better on the bigger screen and it will be more interactive. Nobody is going to ask questions or give you ranks, marks, scores. You need not sit in the back. Please come. Once these front rows are finished, then only you go back. Please come and occupy this. Front 2-3 seats are okay for faculty. The rest all can be occupied by you people. Please come front. We'll start in 5 minutes. Request all those doctors who are sitting in the back tables to come and occupy in the front. That way, the people who join late also becomes convenient for them to join from the back. Thank you.
I hope all are in, so let's start. So, good morning all senior faculties. I am Dr. Deepak, I am from Lupin Medical. So, it's a great pleasure to welcome you all. So, all senior faculty as well as the bright future of Indian cardiology, our postgraduate residents. As young physicians preparing to shape the next several decades of Indian healthcare, your role is quite very important to shaping the Indian cardiology. So I welcome you all on this Upgradio 2026 program. This is the 4th edition that we are conducting, brought to you by ACVS India and FACTS Foundation, where day 1 will be covering the coronary intervention, and day 2, it will be focused on guidelines and structural intervention. So before starting Upgradio 2026, I would like to request Mr. Sandeep Sharma, who is the Senior General Manager, Sales and Marketing Head of Lupin. I request him to take us through this corporate presentation. Please, sir.
Hello. Thank you, Dr. Deepak. The slide is not visible there. Neeraj. Okay, my name is Sandeep Sharma, and I am the Senior General Manager in Lupin, taking care of sales and marketing. Privileged to welcome each one of you for this 2-day scientific feast of Upgradio. Lupin is a purpose-led growth through people, performance, and possibilities. Lupin was started by Dr. Deshbandhu Gupta, we call him DBG, with aspiration to build quality healthcare. His inspiration is pushing us towards solving complex problems and dare to innovate towards unmet needs, delivering quality, affordable medicine. About Lupin, global pharma leader across 100+ markets with strong US and Indian presence. Diverse portfolio present in generics, specialty, biosimilars, strong therapy leadership. We hold strong market leadership across key therapeutic areas like cardiovascular, diabetes, respiratory, and GI therapy. Lupin's mission is to ensure no one is left without quality care that they deserve. We believe that building a company that delivers lasting value to all stakeholders. When it comes to the global footprint, extensive footprint across India, US, LATAM, Europe with strong infra. Integrated model which combines manufacturing, R&D, and global distribution capabilities throughout the globe. Indian market, when it comes to the Indian market, Lupin is ranked 8th, which with 34% contribution to the global revenue. Leadership in cardiology, diabetes, respiratory, and GI therapies. Strategy for value creation, if you see, we believe in 4 pillars. The number 1 pillar being enriching ecosystem by fostering strong collaboration with diverse stakeholders. Second being patient centricity. Our patients are at the center of everything we do. We catalyze meaningful healthcare outcomes. Third being operational excellence. We are focused on efficiency and productivity to streamline processes to deliver value. Holistic growth is the 4th one. In key focus therapeutic areas through value creation. Overall, focus on workforce, partnership, and efficacy-led growth. Our businesses, we are into 4 major businesses, core businesses like generic, complex generics, biotech, and APIs. We have a balanced portfolio driving innovation and revenue stability. We are strongly present in diagnostic, digital health, consumer, and APIs too, strengthening the ecosystem for holistic healthcare delivery. Thanks to your support, Lupin is 3rd largest in cardiology and diabetology organization in India. When it comes to cardiology, we were established in the year 2000, and here we are amongst the top 3 organizations in the cardiology and diabetology segment. Dedicated 14 business units in cardio and metabolic space with 4,000 plus Lupinites, which is the highest field force in India in cardiology. Patient centricity. There are large-scale patient engagement programs like Hamrahi and Jai, which focuses on adherence, outcomes, and holistic care. Lupin has strong ESG, sustainability, and operational excellence recognition, reinforces brand credibility and global leadership positioning. I hereby once again welcome each one of you for this 2-day scientific event, which is Upgradio 4.0. Thank you.
Thank you, Mr. Sandeep. Now it's my great pleasure and honor to introduce our today's program's course coordinator, Dr. A. Srinivas Kumar. Introduction slide, please. Dr. A. Srinivas Kumar, he is a senior consultant cardiologist at Apollo Hospital, Jubilee Hills, Hyderabad. He is having a lot of experience. You can see on screen also, 25 plus years of experience in cardiology. Specialized in TAVI, TAVR, and complex coronary intervention. To date, the doctor has performed more than 15,000 angioplasties and over 150 TAVIs, TAVRs. Held the 2nd rank in MBBS entrance exam and winner of many auspicious or programs and other recognition he is having. So if you see from 2014, he was there in Director Clinical Research Care Group of Hospitals. Then currently he is a senior consultant cardiologist at the Apollo Hospital. So now every good work, it has to be start with the good vibes. So lamp lighting. So for lamp lighting, I request all the senior faculties, Dr. Srinivas, Dr. Kamal Sharma, Dr. Kajal Ganguly, Dr. Please come on the stage for the lamp lighting. I also request all the GMs of Lupin to please come on the stage.
द्वेषबुद्धि विनाशाय आत्मज्योति नमोऽस्तुते आत्मज्योति प्रदीप्ताय ब्रह्मज्योति नमोऽस्तुते ब्रह्मज्योति प्रदीप्ताय गुरुज्योति नमोऽस्तुते।
So thank you very much to all senior faculties as well as GMs from Lupin. So I request Dr. Srinivas Kumar to please set the context for today's meeting. Yes, sir, over to you.
Yeah, good afternoon, friends, and all the doctors who have joined from all across the country, and all the senior faculty friends who agreed to participate and spare their valuable time. And I'm extremely thankful to Lupin for making this possible for all of us. And their commitment, I think Dr. Sandeep sir told about what all they're doing in the business front and manufacturing front, I think. But another thing which I should like to place it on record is there an uninhibited or unrestricted support to any academic event we plan. I think that's a great thing. I think they do various types of meetings, both in interventions as well as non-interventions, senior faculty, and they help in our ACVS meeting also, that Advanced Cardiovascular Solutions India, which is done last month itself. And it was our dream to do something even for younger generation doctors and DNB, DM students, fellows. That's how this Upgradio concept came. We used to also call it the FCCs before, and now it is a 4th edition of Upgradio. And thank you all the staff of Lupin for making this possible. And all the doctors enthusiastically participate in this meeting. That's how it gives us a lot of impetus to take more pains to do such programs. And again, in this era of multiple meetings, I thank all the doctors and the faculty who spared the time to join here. I think before we go on to this meeting proper, some of them were asking what is ACVS. Some of them has known this is 17th edition we did, and recently we finished it. And to make some music and noise for the other doctors also to come and join, I request all of you to watch this video for 2 minutes, a highlights video of our recent Advanced Cardiovascular Solutions India conference. Can you play that AV, please? Hope you like the video, and there's a lot of important things happened in this. I think first time we demonstrated a aortic regurgitation TAVI procedure done, and with other 23, 24 live cases coming from across the country as well as from US. And the faculty was also very good, and it was appreciated by about 1,000 plus cardiologists from our country, and some Russia, Myanmar, Sri Lanka, neighboring countries also. For 50 to 60 doctors attended. I request all of you to block your dates and be there for next year, CVS India. With this, I come back to this editions of Upgradio, and there's a slight change. We have to do this. The basics is the one which we thought we'll start and go to advances. But nowadays, I think faculty has to leave for some work, and then advances also have now come into the part of basics. So we start the second session first, and the first session will be next. So Dr. Kamal Sharma and Dr. Ramakrishna had to leave for their to catch their flights, but we didn't want to miss their lectures, and we want them to be comfortable. That's why I think the other senior faculty, Kajal Ganguly, others, we should be thankful for agreeing to shift a little later. So we'll have the first session. We'll invite the faculty. Doctor Deepak, you want to call them? Okay. So we want this to be also interactive. All of you can stop the faculty and ask anything in questions in between if you want, or feel free to interact to make it more interactive, because basically learning is the motto for our meeting. So please don't inhibit yourself, and anything you want to ask, you can pass on to the Lupin colleagues in between, or you can directly ask. With this, I request you to invite the first set of faculty.
Thank you very much, sir, for setting the context and tone of this event. I request you please be on the stage. I request Mr. Sandeep Sharma to felicitate Dr. Please, sir. I request Mr. Sandeep Sharma to please felicitate Dr. Srinivas Kumar. Thank you, Sandeep ji. So I request for this next session, as sir has already mentioned, because of some flights and everything, there is shuffling into the presentations. So I request Dr. Srinivas to please be a chairperson for this meeting. I also request Mr. Kajal Ganguly, Dr. Kajal Ganguly to please come on the stage. Dr. Ramakrishnan, please come on the stage. Dr. Sabasivam, please come on the stage. And Dr. MP Sambal, please come on the stage. They will be the chairperson for this meeting. So I request introduction slide of Dr. Kamal Sharma, please. So Dr. Kamal Sharma, he is a consultant interventional cardiologist from Ahmedabad, practicing at SL Hospital, UN Mehta Institute and Cardiology in Ahmedabad, has more than 28 years of experience, has a rare combination of double degree in both medicine and cardiology, that is DNB degrees in both medicine as well as cardiology, apart from MD and DM. So awarded 22 gold medals, has more than 300 research publications and many awards in his kitty, and only cardiologist to have cleared civil services, IS, IPS in a first attempt. So that's a great achievement. Author of 8 books and many chapters. So with this, I request Dr. Kamal Sharma to please come on the stage to have a presentation.
Can I have a slide changer? Slide changer. Slide changer. Good afternoon. Thank you, Upgradio, and especially Dr. Srinivas Kumar. I've disappointed in many occasions. I've not been able to come a lot of times because of prior commitments, and I'm so glad that I'm here this time. And thank you again for giving this opportunity. PG teaching is always something so close to my heart. And It's something that always gets time irrespective of what practice we are doing or not doing. For the sake of interest of time, because I was supposed to be talking only about the approach to calcified lesion, and then Dr. Srinivas Kumar told me that you cannot leave Hyderabad without speaking on AI in cardiology. So, thank you. So it all started from, can you have this mic? So it all started of talking of AI in medicine at the 100th centenary meeting for the Indian Medical Association when it was happening, IMA Con. And that's when then I end up speaking about it in the Endocrine Society, and then somehow Dr. Srinivas Kumar, as you know, has his very sharp senses. He picked it out that I need to be speaking on AI in cardiology as well. So, but I'll talk you through first the calcified lesion. And in the interest of time, I'll try to restrict both the talks so that I don't do injustice to the rest of the speakers who are to follow me and who have been gracious enough to allow me to take this session at the beginning of the same. So this is the first question. So if it is the PGs are around and there is no question answer, then it won't make. So what is the estimated prevalence of calcified lesions that require to be addressed? Which means you need to address the plaque which is calcified enough and you would require intervention. How many of you can do a raise of hands because we don't have a voting meter? How many of you think it is less than 10%? Raise of hands. Just a few. How many of you think it's 10 to 20%? Okay. How many of you think it is 20 to 30% of the lesions? How many of you think it's more than 30%? Wow. So everybody is very well oriented as to when you need to address. It is more than 30%. It is 31.1% in one of the big studies which was published. What are the problems with it? Why you need to address them? You deploy a stent and you don't end up optimizing it. You actually end up with more MACE rates. It's more likely to come, and you can see, of course, how the AI has come in my presentation. You can see the notebook LM on the bottom side. I could have cropped it out, and I could maybe make out some of you reading it out and seeing that how AI has been used. That is one application that you can all learn to use. So I gave a feed to the AI, the notebook LM tool, that this is the kind of slide I want in my presentation, and you can see how it has created this slide showing an unexpanded stent, the malopposition, the polymer damage, the problems with the plaque modification, why it needs to be addressed. Because in the end, what it leads to is occurrence of higher target lesion revas requirement, MACE, and stent thrombosis. So we know this, it goes on increasing as the patient's age, and it also occurs not only in the media, but it can histologically progress to cause lesions, to cause decreasing compliance when you're doing an angioplasty. This would lead to suboptimal expansion, and more importantly, there will be decrease in the arc length, and it would in turn lead to increase in the ischemic event rates at 1 year. So we now know that from various studies as well that the cumulative effect in the real world impacts in the presence of an calcified lesion, the event rates are more than double. And when you're looking at cumulative incidence of death or MI, these are 11% versus 23% for an interventionalist perspective. Also, when you look at in terms of procedure failures, complication, TLF, MACE, they also go up drastically. So how you can modify them? What are the methodologies? So people used to do cutting balloons, scoring balloons, before the era of plaque modification. Of course, rotablation has been there for many, many decades. We saw it in our residency days. It's only the fear of complications that actually prevented us from adopting it till the technology got so refined and smoothened out that now it's much easier to adopt to and improve the outcome. So what is the problem with an eccentric calcium? If you look at the Disrupt CAD4 registry, which looked at the angiographic coronary artery calcification, OCT core lab analysis revealed that 22% and 28% respectively had 270 plus or 300, 360 degree kind of calcium, which is like 50% of the patient. Anything from 31.1% that I showed you to 50% of the patient have calcium that needs to be addressed, which is a huge number. And because of this reason, the problem is that when you don't open it up adequately, this is the kind of stent deployment that you probably end up achieving without a modification, versus the risk when the plaque is eccentric. You can actually, with a shock wave, when you drill it like a balloon, just balloon is going to push the lumen away from the calcium plate and will cause dissection in the wall rather than break the calcium per se. It's like asking somebody, can you break a wall with an inflated balloon? You would not be able to crack a brick with a plastic balloon. And that's something that you're trying to look into. This is how the calcium arc holds a calcified lesion. You try to burst it, it may open it, but what happens when it's an eccentric one? The balloon inflates on the other edge. When you look at the atherectomy devices, what it does, it opens up, drills it on the top of it. It's like chopping off of the mountain top rather than breaking the mountain at the bases. So when you actually drill it, you are cutting it out across the top, but you're not going through the deeper part of the calcified nodule that you're dealing with. So what ultimately needs to be done is first to visualize this. Unless you see them, you don't know how to treat them. And hence you have three modalities. Now there are AI algorithms that can pick it up right from CT. A lot of centers that don't do a lot of imaging also actually do a CT calcium and then do a coronary angiogram, especially in West. While in patients where you can image, you need to look at IVUS or OCT as the two modalities that can pick whether it's a thick one or not, and what's the length of the lesion. So that brings us to the next question. Which of the following is not the criteria of plaque modification? Arc of equal to 360 degree, length more than 5 mm, thickness more than 0.5 millimeter, or none of them is a criteria. So what do you think is the answer? How many of you think it's one? So the question, this is like your entrance trick, right? Answer is, it's not always 360. Anything above 270 would also qualify. So 3/4, that was the whole idea of asking. Otherwise, length and thickness are correct. If you find a calcified lesion, which is more than 5 millimeters of length, or a thickness of more than 0.5 millimeter, or an arc of more than 270 degrees, it qualifies as a lesion that needs to be addressed. Again, you can see what kind of slides AI tools can help you prepare as compared to what I would have otherwise borrowed from industry compared to the previous slides that you were looking at. So this is the length, thickness, and arc are the three important determinants how you can actually look into it. Rotational atherectomy, we know is the gentle pecking motion. It decelerates at 5 bar. That's when you stop. Start with the half. That's the ratio that you start with. Start with 140K or 180K RPM. More the calcified, the diamond chip which rotates through it and cuts through and drills. That's the technique that we use. It's driven primarily by the rotational atherectomy mechanism. In the interest of time, I'll rush through this. Orbital atherectomy, it's an eccentric crown which generates both centrifugal as well as bidirectional force. And here again, you need to look at the speed, 80K RPPMs to escalate to 120K for a larger luminal gain, less risk of perforation and stucking of the burr. The mechanism is that it is eccentric in orbital motion, so it widens as it speeds up because it's drilling on both the sides. It's targeted specially for the severely calcific large vessels. Its continuous orbital motion allows constant blood flow, washes away the micro debris in these conditions, and egg allergy is one where, because of the rota solution that we use, can be allergic, but a lot of times we don't use any rota solution. The simple saline with nitroglycerin often does the work. IVL, on the other hand, is something that we have borrowed from urology guys. Urology people have been using it for so long. You just use sound waves or the sonic pressure waves to crack the calcium with an inflated balloon. What's important is that you have to use the balloon which is optimally sized for the artery. Unless the balloon touches the lesion, touches the wall, it's not going to transmit it adequately. Second, it should not have any whatsoever air bubble inside, because that is going to dampen the shock wave transmission, the sonic wave pressure transmission across. And this is what actually helps to crack the calcium with the sonic waves. You inflate it 4 to 6 atmospheres. A lot of times, once we have given a lot of pulses, we again give a higher pressure inflation to crack it even further and then deflate it gradually. This is the technique, which is the basic theory of IVL. Now, where to use these three techniques, where to use which one, there are a lot of algorithms, but before that, you should know the advantage and disadvantage of each of them. Rotational atherectomy is like shaving off. You just shave off the top, like I showed you the video. The guide wire has to cross. Unless you have a wire across, including the rota wire, you cannot actually be able to get through it. And hence, there is always a wire bias involved. Your wire is always going to be hanging around away from the calcium, and it's going to go more towards the wall. This is the advantage that you have in orbital atherectomy, because there is no wire bias. It is cutting across the center of the lumen. Though both of them will generate microparticles, but very important with IVL is it's not just cutting the lumen hanging stuff, but it is sending waves across into the media as well, and it's cracking a nodule which is extending right from the media. So it's doing both across superficial as well as deep part of the tissue. There's no micro debris generation, and it is proven therapy of choice for patients with in-stent restenosis. So with that summary, now we know that you need IVL for a deep calcified undilatable lesion. All you need is deliverability of that balloon. Side branch protection is something that we probably can look into. Complication risks are minimal except balloon wall rupture, etc. But perforation and slow flow and dissection are complications that rota heads into. So this is a proposed algorithm which a lot of institutes do follow. If you have severe calcium, assess the crossability. If the path is crossable with the balloon, you prioritize with the rotational atherectomy. If you cannot, then cross but undilatable, then find what is actually preventing it, cross it, prepare and push a IVL balloon in. And then there are methodologies of actually getting rid of it with a combination of both of them, which they call the rota shock or shock rota approach as well. So low profile balloon or imaging catheter, if it is not crossing, you'll have to do atherectomy. At extreme subtotal occlusion, rotational is preferred. Severe stenosis, but large vessel, orbital is preferred. Lesion is modified, and then you push in your imaging catheter and treat it accordingly. So we need to prioritize according to the calcification, eccentricity, length, and whether you can do a bailout as if required with suboptimal IVL or balloon fails to cross, you can do a rota first or what is called orbital tripsy in that fashion. However, in certain scenarios where it's in-stent restenosis, you would prefer an IVL. Same would be the case with an osteal lesion, severe tortuosity, but in calcified nodules, it's always the rotational atherectomy that will come into play. So the problems which you can have to think of are burr entrapment, crown entrapment, dissections, rupture of balloon failure to cross. However, you have certain solutions, which for the interest of time is there in the slide. We can discuss it one and on, maybe in discussion later on. Valvuloplasty, balloon preparation, again with an IVL you can do bidirectionality, which is because it cannot be easily re-advanced once inflated. You should always make sure that you cross the lesion first, and the first inflation is at the lesion. Also, atherectomy pacing, sometimes you will have to have light pecking motion, which may be required with rotational atherectomy, while this may not be the case for the IVL once you have put it into the so rota shock protocol and orbital shock protocols are the other two methodologies, which is combining the two strategies. And then once you have done that, modified it with first a rota and then an IVL, you always finish it up with an NC balloon to open it up and crack the micro debris that you've created in the wall to be crushed completely before you deploy a stent. No flow phenomena, burr entrapment and perforation are some of the other complications. A lot of trials have come into Orbit 2, Eclipse, Disrupt CAD, and Rotaxis, which have all yielded good outcomes of these procedures, especially in terms of the intermediate as well as immediate results. Imaging in such cases is non-negotiable. Match the tool for morphology, prepare for the complications, and very importantly, learn from others' complication. If you are learning from your own complication, you're too late a learner. Listen to what others present, and that's why I see in CSIs or any conferences, the complication sessions are always full. The dialect talks are the one that are poorly attended. So 5 rules of calcium: image first, uncrossable, do atherectomy, crossable, do IVL, large vessel, do orbital atherectomy, but never compromise. Do not deploy a stent until you have achieved 1:1 Bernoulli expansion, visually confirmed into orthogonal planes, and hence calcium modification is no more an optional strategy, especially with imaging. You need to be in a situation where you have addressed each of them. Thank you very much. I think I'll skip, in the interest of time, the videos that I had for the procedures showing it. I think I can open it to a discussion, and then maybe I can carry on with the talk on AI. Thank you. Over to Chair.
I think as you understand, more and more interest is coming up because more incidents, our patients are aging and more of them require such therapies. And it's important for us to prepare the bed well so that you have good results. You want to show one or two cases or you'll go on?
I'll go to the AI talk.
Okay.
Yeah.
Okay, please proceed then.
So those were some of the cases, but I think this one lesion was where we had already had a stent from the LED, LM to LED, and then we IVUSed. We did rota, then we did IVL, and then we did cutting balloon, and then we did a drug-eluting balloon. But for the interest of time, I'll skip it. Can I have my second presentation? Can I have the slides? Can I have the slides, please? Right, so these are my disclosures, and this is again an AI-generated video. This is probably what a fellow, the AI tools are so smart that they probably imagine not only the professor but also the student to be of Chinese descent rather than an Indian. So this is an AI-generated video. Probably this is how an interventional cardiology fellow is going to look like because he'll not be in cath lab. Unfortunately, it's still probably a decade away, but this is where the AI evolution is headed. Every year, by numbers, and this is 1 year back, almost 1,200 plus algorithms are approved by FDA. 75% growth annually. That's where the science is headed. Where it's coming to us, it's coming to diagnostics, it's coming to imaging. It's already integrated in your ACO machine, you may not be aware. It's already integrated in your IVUS tool, you may not be aware. It's already integrated in your cath labs. Most of the new machines are actually using you as a data source provider, and data is being generated for training their models how to differentiate the structured summaries, patient ambient listening, history taking, lab interpretation, triaging the patient, imaging and identifying a calcified lesion. Recently, I was approached by one of the companies based in US to discuss about, can we develop an algorithm of predicting stenosis severity of coronary artery disease based on CTs done for lung, not even gated CTs for the chest, for the coronary artery calcium. And they have data sets of patients undergoing COVID scans or scans for pneumonia, where they just want to pick up and train their models based on coronary artery calcification, though that was not the idea, to pick whether this can actually predict what amount of stenosis is there in already pre-existing coronary artery disease. So practically, diagnostic angiograms are anyway half replaced by CT coronary angiograms. The rest of them are also going to be replaced by predictive modeling. That's where we are headed. The evidence globally is going up in a big way. The journey is the foundations, the clinical application, the challenges, and the future where the generative AI and the drug discovery is going to be very quick. You already know therapies on lipids have changed so drastically over the last 5 years. In next 3 years, even more drugs are going to be there. Right now, what is happening, a lot of India-based companies are actually doing this. I'm sure one of the HMIS systems that a lot of you guys must be using actually trains your model, and I know that one of the company which is looking at the hospital management software is using vernacular language. So when you're discussing with history taking with your patient in Tamil, Telugu or Malayalam, the history is being captured by the tool, converted into its English translation, and is produced to you to give you a pre-written history capture in that format. All you need to do is, no, this was not right, I'll train it, I'll tell you what to do. You do it for free, you think that you're doing it because you are actually making your life easy. No, you're training that model, and that model is smarter enough now to capture it even when the language is a dialect and not a proper, maybe it's Bhojpuri, not even in Hindi, even then the model is able to grab that language and convert it into proper notes. So that's where ambient listening is already there. I have already highlighted name of some of the tools which are internationally US FDA approved. AI Scripts, Phenopod, and Tally are some of them. The problem is when radiologist or somebody who doesn't know AI starts putting images of CT scans and ChatGPT and ask him to tell me the diagnosis. That's the most illiterate format of AI information that you can learn. Don't do that, because there are tools that are, it's like asking me to recite some poem in Latin. I would not be able to do it because that's not my forte. Same is the case with the models in which they are trained it. Am I telling you that this is where it is headed in just form of history taking? No. ECG interpretations and model training are already so advanced that there are some of the sites like Scale AI where you need to go and try to stump the model. They pay you only if you can stump the model. So they will give you an ECG, there'll be a history that is already provided, and there is a diagnosis. Try to tell AI model that a differential of 10 things, and you try to create a history, and can you actually convince AI that the diagnosis is wrong? Believe me, I tried it for 10 times, I would fail on 5, because despite giving 10 differentials with 5 different histories, it was still correctly picking up the diagnosis on ECG. That's how good it has become. The most of the current ACO labs right now, I'm sure you guys are also doing, are interpreting GLS-based RWMAs on the models in a fashion and interpretation of ejection fraction so accurately that it is much better, because in terms of interpersonal observer variability or intrapersonal observer variability, it comes out that every time the machine measures your ejection fraction, it is the same. So the expertise is getting democratized. You may not be the best of the echocardiographer. You just need to be average to getting 3 views, and that's where the machine does and takeovers and does the rest of the thing. What about the platforms in terms of AI which are being used currently for the imaging? There is Analyze AI, Zebra AI, Google Health Imaging AI models, which do 30 to 40% reduction in reporting time, and these models are again US FDA approved models. So now you must be wondering what happens to us. There are 7 pillars in AI in cardiology. 1, ECG detection. It detects AFib, it detects STEMI. But more important than STEMI, the concept is moving to occlusive MI and non-occlusive MI, which means you may have non-ST elevation MI, but an acutely closed 100% coronary artery, versus you have NST MI like of a picture, but patient has an occluded artery, or the other way around. Patient has an ST MI, but still an open artery. ECG models are better than humans in predicting whether it's an occlusive MI or non-occlusive MI, to help us prioritize as to who gets into the cath lab first compared to the other one who has probably an open artery. Echo, CT, MR, SPECT, IVUS, ejection fraction estimation, valvular estimation, TAVI procedure implementation, all are actually now being trained by AI models. Some of the machines have already integrated them. Very importantly, risk prediction model. The new score, which came out for risk prediction model, is an AI tool. It was also the case with QRIS 3, where it was looking into racial differences between Indians and Pakistanis and Bangladeshis. Can anybody tell me between these 3 countries who has the highest risk? Anyone? Pakistanis, Bangladeshis, or Indians? QRIS 3 score-based data sets. Bangladeshis, followed by Indians, followed by Pakistanis. So this again was based on data sets of people residing in UK of these lineages. And based on their PIN code, the postal codes, the models were trained to pick up if you are in this area, this is your risk, this area. And that's how, if you'll go through QRIS 3, it will ask you a couple of stupid questions that you otherwise thought of, like, do you have a history of migraine? Do you know that history of migraine is also a predictor of higher ASCVD risk? QRIS 3 already integrates it. It also has PIN code. It also had some other parameters like inflammatory disorders, which we still are thinking and debating how much to contribute for it. But the model has already integrated into risk predictive modeling. Procedural success, including EP and RFA, localizing the pathways, not just based on ECG, but not also the electrical activity and depolarization, and also to look at the structural and coronary wise to optimize it. The cardiologist would still be the last person standing in the room because he'll be the human to be blamed when everything goes wrong. So you'll be the ultimate deployer, but the machine is going to tell you that 3.5 millimeter by 28 millimeter stent starting from X point ending at B point deployed at 16 atmosphere is what is optimal for this patient. Do a post dilatation with 3.75 at 20 atmosphere at the middle part of the artery. That's how the algorithms are going to be. And this is how far I'm talking about, maybe a couple of years, not even a decade. Because if you have gone through a paper which was published of end of world called 2027 by an AI technologist, he predicts that AGI is going to be here by early 2027. What is an AGI? AGI is like intelligence of Eugene Brunwald's level in cardiology. So if it's not Eugene Brunwald as a person, but the whole Brunwald integrated into that tool, that kind of a knowledge. So he has mastery in cardiology of 100%, but he also has Panini's Sanskrit level of 100%. He also has, you think of William Shakespeare's English at 100%. So that AI tool is 100% of the best of the humans in all the domains. So where are we right now? We are right now at 68 or 83% depending on what modality you're looking at. How fast is this acceleration? It's logarithmic. It's rising exponentially. Our decline and the rise is exponential and log. You stop using it, your brains, because you rely more on AI tools, you're declining logarithmically, and AI is learning exponentially. When does that happen? Probably in 6 months. What happens after it? Then comes a state, what is called a superintelligence. That's where most of the labs of Meta or Facebook or AI in Google are actually investing now in. What does it do? It accelerates and individualizes and integrates therapies at a speed which exceeds human understanding capacity. What does it mean? At a point of time, somewhere, if it's going to be very slow, and I'm very optimistic, would happen probably in 2032, would be a point called point of unity, or what they call as singularity, like you have in a black hole. The point of singularity is a point where you will not understand what is happening next in the technology. So when humans fall out of place, that's the whole context that what the AI scientists are right now talking about. So what does it make for us cardiologists to adopt and learn? What we need to adjust and adopt is to stay as the human in the loop. Now there is a sub-science in technology which they call human in the loop, as probably we'll be the last humans involved when the AI takes over administrating the science or the STEM, as we call this, the technological aspect. And for that, because we'll be the final deployer, we need to tweak AI at this moment, including us cardiologists who are actually adopting it completely naively, to tweak it in a fashion that we don't get thrown out of the loop. We already are wearing a lot of watches, rings, Gabit, or whatever you call the chains. What it is doing, it's picking not only your heart rate variability, perspiration, touch, temperature. There are models that are picking your blood pressure based on pulsatility of your retinal vessels, based on your photograph that you take from your picture. There are tools that pick up flashing or the pulsatility of capillaries in your ear lobules to predict your systolic blood pressure. You will soon have your digital twin somewhere stored in the digital system. And you'll be warned a couple of years in advance that this is the time that probably you're going to end up with acute myocardial infarction. Better get yourself tested. This is where the cardiologist will need to fine-tune to be part of. And decision-making, of course, is something that patients are adopting more than you. So ECG-based learning, interpretations, mammograms were giving accuracy of 85%. Currently, ejection fraction by ECG is being picked up with an accuracy of 93% in a published paper. When we're working in 2019, I think the paper was published in probably 22 or 23, when we published about the heuristic models, when we were looking at that you cannot pick up atrial fibrillation purely based on the tachograms or variability of 6 beats, you actually need to look at the context, because if you're sleeping versus you're eating versus you're walking versus you're running, your tachograms will change. So heuristics we started feeding, and this model, when we published with the University of Copenhagen, which was published in Computer Methods and Program in Biomedicine, this was the first time the context actually came into picture, and then Apple again improved. This algorithm was better than Apple's algorithm at that time. The same concept, again, we talked about in CAT-B, which conceptualized the arrhythmia database generation. Echocardiogram, CT, MR, I've already touched upon. The wearables, your Apple Watch or your wearable watch is probably soon going to tell you your ejection fraction. It's also going to tell you your AI-powered arrhythmias. It's also going to be detecting, not with a PPG sensor, your sugars, even NT-proBNPs, troponins, and other hormones or microbiomarkers, which are otherwise difficult to measure from blood sample right now. There are a couple of companies based on IIT Mumbai that we are actually working with who are looking to measure NT-proBNP based on finger prick test. So you already have glasses, watches, clothes are also going to come in, which is going to be picking up your wearable integration with predictive analytics. It's going to count your sleep, steps, heart activity, heart rate variability, calorie you consume. It's going to give you a feedback that you ate more, walk more, you didn't sleep well, sleep more, avoid your coffee, add less sugar to your coffee. And then we also talked about how the real-time AI enhanceable wearables are going to make you actually their servant. They will not be your servant, because they are going to be dictating how you are going to be behaving. Digital twin, hence, is a model that's something that everybody probably will be looking at. So as I mentioned, your digital twin is already probably being created if you're part of ABHA card, Ayushman Bharat card, because that's where the data set is coming, and Government of India is also actually looking into train AI models based on that data set. So I'm not aware as to how much that is being trained into, but ABHA data set is going to be one of the largest data sets in the world, next to the China, of course, where they already have kiosk. If you're aware, in China, you walk into kiosk. I'm sure a lot of you guys have seen that video, where you walk into the kiosk, you put your hand into a BP cuff, there is a scanner on your face, and it tells you, these are the tests that you need. These are, so the doctor-free AI hospitals, as was propagated on social media for quite some time, was something that is something that we are foreseeing probably happening. And I'm told some such kind of kiosks are already there in some of the big communities in India as well. Noida, somewhere in Hyderabad or Cyberabad, I'm sure, would also be having some such localities where you have a kiosk which is AI integrated. It is also going to predict your sudden cardiac death. And that's when probably a lot of AI solutions will come into pick. I already told you about occlusive MI, procedure guidance, electrophysiology, heart failure, AI models, RCTs, again, will be help in designing it. There'll be expandable AI, which will be integrated into real term. The challenges would remain, but next future is about genomics, proteomics, metabolomics, and your data sets that already exist with AI integration of the same to pick up a cardiovascular disorder. So personalized medicine would next follow, because your omics are with the AI. And that's where the two will combine to look into your transcription, translation, and next thing that's happening, like the AI buzz, you had .com buzz, you had AI buzz, the next buzz is quantum computing. Quantum computing, when it combines with an AI, which probably is the next decade to come, is going to accelerate the point where you will end up with singularity. So that's what I wanted to share. The brain-computer interface, I'm sure a lot of you guys have seen that experiment. You can Google on YouTube also, where Elon Musk has implanted a Neuralink chip in a monkey, and the monkey is playing a video game. And he's always ahead of the curve. And now that Neuralink chips have already been implanted in a lot of patients who are quadriplegic, and with their eye movements, they are able to take care and type an email and write to their doctors. And that's where it's going to expand even further. I'm sure some of you saw our top-notch badminton players had their 4 temples attached with a chip when they were playing, and this was being monitored live to see. PV Sindhu was playing, and she was wearing a patch on her forehead, on Temple to pick up the brain waves while she was playing, what she goes through when she loses a point, what happens when she wins a point, how she fights back and how she wins the game. To do that and integrate that into human activity would make probably all of us superhumans as long as we can afford it. Polygenic risk scoring is again being attenuated and modified to a huge extent. The EMR is the key to develop and modify and take it to the next direction ahead. A lot of trials will probably be in that strategy. We are at an intersection where human in the loop is the first and most important thing. You need to have AI to go through a first pass, human verification, human correction, and then will come into a resident training models. This was our paper, again, in our own Indian Heart Journal, where we talked about this principle, that it's so important to keep AI in cardiology as a topic that everyone in the field in cardiology should be aware. Otherwise, we probably will be replaced like microbiologists, pathologists, dermatologists, and radiologists, where AI has already taken over your diagnostic modality to a huge extent. So with that, in the interest of time, I'll skip it. So this is where we are right now, imaging in cath lab, omics, ECG variables. But what is happening, a lot of algorithms are coming. There is early detection challenge, which is being addressed to a huge extent, bias mitigation, generative AI, quantum computing, paper writing, digital twin, federated learning, brain-computer interface, extended reality, VR headsets. You probably, the expert professor is going to be probably sitting in his chamber rather than the hospital. He'll be wearing a VR headset. The resident will be sitting outside in the cath lab, and patient would be probably being taken up. Something like this. This is again an AI-generated video, and this is probably how it's going to look like in next decade or so, at least in some part of the world, if not our part of the world. And this is some of the students were asking me, yes, the 4th edition is about to come soon, which probably you go through. Thank you very much. Thank you for the patient here.
Thank you, Dr. Kamal. Please do that. Please join here. I think if any of you have any doubts or anything you want to share, he'll be there here. If you want 1 or 2 questions, we can take on AI in cardiology. A lot of youngsters have coming up with some new ideas too. I think one of you could be imagining something new, and something new could happen. But as he said already, in the OCT field, it has already come. And it helps us a lot in better diagnosis and improving the patient outcomes. Similarly, I think a lot of new things are happening. Great predictions of future, and probably we need to learn, and if not AI directly replacing doctors, doctors who are comfortable with AI will be all better placed than the doctors who don't know about it. That's why it's better learn about it and then try to get into that field too.
Yes, sir. I often say that AI will probably not replace doctors, but doctors know AI will replace doctors who don't know AI.
Yeah, that will happen. I think, any questions? Anybody in the panel want to say anything? Otherwise,
it was a wonderful talk, eye-opener. I think we are in only the downside of AI in cardiology we need to look at.
Yeah, that's why I say human in the loop is so important. It errs a lot of times. When you train a model irregularly and you accept it, whatever it gives you, will actually create a wrong training of the model, and then the whole trend will change. That's why every validation must have first human layer, then the model, and the final adoption should again come at the human level. So there are a lot of downsides. Sometimes when you search a wrong question or a question is not typed properly, I do it in a lot of AI workshops when I do, but when you don't give a proper prompt, it will give you a wrong answer. So, and that's what our patients also do. They put the wrong prompt and come back with the wrong prompt. But I think we should learn what to adopt and what not to adopt.
It's like garbage in, garbage out.
Yeah, absolutely.
yeah. Can somebody pass on a mic there? I will start. Ready? 1 minute till. Yeah, I think,
Excuse
is
me.
it ready?
Yes. Sir, actually, the cardiac MRI will be a gold standard for ejection fraction, what we say. But what about GLS, which is replacing as EF, which will be perfect? Like, is there any studies between the cardiac MRI EF as well as the GLS EF, sir? Ejection fraction?
Ejection fraction calculation by your Apple will be like a GLS mediated or AL method, you say?
No, sir, like what we
The
do in
echo one or the variable one?
echo, sir.
Yeah, echo. So again, remember, this is a good question. Not every patient would mandate firstly right now to compulsorily do a GLS. Which are the patient you must compulsorily do? Suspected coronary artery disease, patients undergoing chemotherapy where there is a lot of evidence right now that patients do tend to have GLS reduction much ahead of worsening of ejection fraction. Patients with bundle branch block, patients with pacemakers, patients with associated valvular heart disease, aortic stenosis, mitral stenosis, pulmonary hypertension, pulmonary embolism. These are the patients where EF will not change first. Secondly, patients with suspected diastolic dysfunction despite good systolic function. Because remember, GLS is a better predictor of combined performance of the heart rather than just systolic function. Third, the methodology by which the AI is measuring both of them, actually both have been validated. Both ejection fraction is being measured accurately by volumetric assessments and the Simpson's method. And also the GLS measurement is anyway automated in now most of the modules, whether it be GE or even Philips. GE already has launched AI-enabled echocardiographic machines, that their top-end model, where everything is automated. The technician just takes 3 views: the parasternal long axis, the short axis, and the 4-chamber view. He just has to take good these 3 images, and the rest the machine will auto-calculate, including the dimensions, M mode, ejection fraction, tissue Doppler measurements, everything is automated. But even in the machines, you may say, sir, I don't have that 1 crore ka machine in my hospital. No problem. Your machine at least has GLS. Go to GLS. Most of the GLS algorithms are AI driven. Even the Vivid 8, 9 series are also AI driven. So even they have at least some methodology, the GLS being validated by AI models, and it's more accurate.
What about coronary artery disease? Like coronary artery
We'll carry on later. Ramakrishna is waiting. And the another thing which you started from last year is introduction of these questions, ASCII type of patterns, where it's become very important for all of you to learn and get through the exams. I think Ramakrishna is professor in All India Institute, has a lot of experience in it. It's very good collection, so we requested him to share his questions, and some of them could come to you people also in your exams. So please be careful and be attentive, and request him to go through his presentation.
Thank Hello. Thank you very much, sir, for taking us through this AI technology in cardiology. So now next session, let's welcome Dr. S. Ramakrishnan. Dr. S. Ramakrishnan, he is a professor, Department of Cardiology, AIIMS, New Delhi. 20 plus years of experience in clinical and interventional cardiology, leads measures cardiovascular research and STEMI care initiatives across India. Author of over 350 publications and author of multiple book chapters and editor of cardiology textbook. Featured among Stanford University top 2% scientists worldwide. A former editor-in-chief Annals of Pediatric Cardiology, editor in Cardiology Clinical Methods, contributor to leading cardiology textbook and academic publications. Recipients of many awards, Limca Book of Records holder for BP screening of 1.8 lakhs people in a day, and has multiple young intervention and many awards in his kitty. Without taking much time, over to you, sir.
Thank you. Thank you. At the outset, I would like to thank Dr. Srinivas Kumar and others to get me here. I think let us have mics in each of the tables. Like, can you have the hand mics there? So we'll start from can you have my slides? Yeah. So we'll start from that table. So what is happening? What are the manuals that can make it happen? Can you have a mic there? So it's going to be predominantly intervention, non-intervention mixed bag. So what is happening first of all? So the first and foremost thing that all of you have to get trained is whatever it is there, you cannot just blank screen is not allowed, like what is happening here. So can you start like what is happening? You can discuss among yourselves and then somebody can talk. Yeah.
Intermittent pre-excitation.
So it's an intermittent pre-excitation. So what are the maneuvers that can bring it out? So that's very good. Give him a big hand. It's an intermittent pre-excitation that is happening. What are the maneuvers or what are the drugs that can be used to bring it out?
1 minute, Ramkrishna. Actually, this is creating some trouble.
So you can
They
have
will
it,
sit there in the front.
I think I will request all the faculty to participate also, like
Thank
the
you.
discussions. So what are the maneuvers? Anybody wants to say?
Sir, AV nodal blocking agents can be
Adenosine,
used.
carotid sinus massage, and so on and so forth can bring it out. Okay, good. So the next goes to the next this thing. Can pass on the mic. This was a patient referred for PTMC. Should we do PTMC or not? The next table. Just keep on passing the mic. What is this? The patient was actually referred for a balloon metal valvotomy. So let us be anybody wants to take it up? Obviously, when such a question is asked, the answer is we should not do. Why we should not do? What is happening? Anybody? No severe subvalvular deformity. Anybody? Any raise of hands? Devendra, use your mic. Take your mic.
Sir, looks like congenital MS, single papillary muscle is there.
What is it? What is congenital?
Congenital MS, like single papillary muscle is there, sir.
No, this is not a single papillary muscle. You can see here, it's a classical supramitral ring. This is how supramitral ring looks like. So you can see this is the kind of can't see my. You can see this is a rich kind of a structure that is seen. That is where the gradient is coming. This is classical supramitral ring. You can see this. So this is how actually it looks like. So this is, sorry. Yeah. So even though we call it like this is how the ring looks like, but we are cutting it in echocardiogram. So that's why it looks like a ridge. But actually it's a ring in a three-dimensional echo. So we go to the next one. This is going to be a question which you have to answer by voting. All of you take out your mobile phone and be ready. So this is the ECG. And the question is going to be which supraventricular tachycardia is ruled out. So these are the options. You can see, have a look at the ECG for say a few seconds. Okay, I'm going to go to the poll. So you can start, scan the QR code and start answering. Okay, I think we got around 100 responses. That's very good. But the issue is that I think it was a pretty bad question, I think. Because you may not know the P waves, or P waves are not clearly seen, maybe you can see, but what is being shown here? The purpose of showing this is like, what is happening? A 2:1 tachycardia has become 1:1. So So that may happen in MAT also. A 2:1 tachycardia is becoming 1:1. So what does it rule out? It rules out AVRT. A 2:1 tachycardia converts into 1:1. So that practically rules out AVRT. So that is the question like. Others can actually have a block changing and then the tachycardia going on. Understand? Any confusion? Any questions you can ask me? So we go to the next one. We'll skip this and we'll go to this one. A 6-year-old with recurrent syncope, diagnosis and management, this table. Can you pass on the mic here? So what is this? You can see ST elevation, 6-year-old child. So what is the diagnosis? Yeah, you just commit, no problem. Everybody will be wrong. Like even if I'm sitting there and somebody else is showing, I may make mistakes. It's not a problem. Please come out.
ERS type 2.
Yeah, that is the right answer. Give them a big hand. It's a malignant form of ERS. Early repolarization syndrome, malignant form. What is the malignant and benign form of ERS like? Anybody wants to say what is the malignant and what is malignant form of ERS? What is benign form of ERS?
Type 1 is benign and type 3 is malignant.
Who is answering? I can't see. Yeah, go on.
Type 1 is benign and type 3 is malignant, where inferior and ST elevations is in all the leads,
Okay.
whereas it is seen
So
in only
what
inferior.
is the drug of choice? The patient was started on quinidine and the patient is doing very well. The syncopes have stopped.
Yes.
We were initially were planning to put an ICD, but then things settled. So this is simple one. Next table. That table. Patient with HPF on multiple medication. This is the ECG with which they come. Simple. That is the right answer. Give them a big hand. Hyperkalemia. Why are you saying that? Can you have mic there? Why are you saying this is hyperkalemia? Mic.
So there is widening of QRS complexes and we can see tall tented T waves and disappearance of P wave is also present.
So next one, maybe you can take it up. What is this one? This is a simpler one.
Amyloidosis.
I think we are going by table like. So this table says amyloidosis. Who said that? Why amyloidosis? What is the sign known as? Cherry on top. So what is this one known as? Blueberry on top. So what is the diagnosis? Apical HCM. So this is the typical blueberry on top due to apical HCM. So can the other table take it up? What is happening? Chalo, one clue. Just focus on the ST segment. ST T wave. Focus on ST and T waves. Let them answer like. Please take it up like. See, in exam, I think everybody has to answer like. Pass? Don't want to answer? So what is the Q wave interval, the QT interval like?
Long QT.
It's very prolonged. What is happening to this? So, long QT syndrome with classical T wave alternance. It's a long QT syndrome with T wave alternance. You can see the T wave. Alternative T waves are up and down, all leads. So this is classical long QT syndrome with T wave alternance. So next question to the next. Mike.
Scimitar sign, supracardiac TAPVC.
Why scimitar sign should have a supracardiac TAPVC?
Sorry, infracardiac.
Infracardiac PAPVC.
PAPVC.
So the clues here are, the clues here are like a severe right side right lung hypoplasia. So severe right lung hypoplasia, you can see this is the scimitar sword that is going down. So this is again going to be a pole. So what is the diagnosis? Is it supravalvular AS, valvular AS, subaortic membrane or HOCM? We are going to go to pole. Okay, ready? Have you all seen that? You want more time? So we go to pole now. So the answer here is, what is the answer like? So like whenever this question is asked, there is always confusion. So not even one guy should answer this is supravalvular AS. So what is supposed to look at? You look at what is the pattern like. So what is the pattern? This is a ventricular type of trace. You have a tall peak and a low ED. Same thing, this is also another ventricular type of trace. And this is an arterial type of trace. The gradient is happening between two ventricular type of trace. So that means this has to be subvalvular pathology. So now the question is whether it is subaortic membrane or HOCM. How do you make out this is HOCM? Spike and dome pattern, that's excellent. So you have to pick it up as a spike and dome pattern. That is why this is HOCM. Understood? So suppose had it been supravalvular AS, this trace will be the same, but this trace will be an aortic trace, which will have the same systolic pressure, and the gradient will be happening between two aortic traces. So always identify the pattern first. So ventricle, aorta, or great artery. So that means the gradient is happening between two ventricular traces. That means it has to be subvalvular pathology. Clear? So next table. Next table, like, can you take it up? So the other next one. These are all classical ASCIIs kept in your exams also. So anybody who answers, you get a pen.
Square root sign, sir? Square root sign?
No, it's not square root sign. So like, let's have a simple understanding first. Like one is a LV trace and an aortic trace. There has to be. So there is a gradient first of all. So what is happening afterwards? So the pen is for me now. So this is Caraballo sign. What is Caraballo sign? So you see here, the LV, aorta is here. Immediately the catheter is pulled out from the LV, the aortic pressure has increased. The FA pressure has increased. That means the catheter is producing further reduction in cardiac output. So that generally indicates almost 95% sensitivity and specificity for 0.7 valve area. If a simple catheter is able to reduce cardiac output, that is what it means. That is known as Caraballo sign. So this is a saline contrast echocardiogram. So what is the diagnosis? So it's actually, you can see now, this is the pulmonary artery, RV and pulmonary artery. Then it is going here.
AP window.
So that is the right answer. Give him a big hand and possibly a pen. He has answered, I think, 2, 3 once. Maybe Kamal Sharma sir can give him the pen. So this is an AP window. You can see the short axis. This is the RVOT, the pulmonary artery. You can see the aorta, and the contrast, the saline bubble is entering into the aorta. This is a simpler one for the next table, like.
Coronary cameral fistula.
Who is answering? Yeah.
Coronary cameral fistula.
Coronary cameral fistula, both from LAD and from RCA. So I think he also deserves a pen. He has answered, I think, 2, 3 once. Can pass it on. So coronary cameral fistula can be congenital or can be acquired. So most of them are congenital and rarely it can be acquired. Acquired things, they open up after a coronary artery occlusion. So you can have both of them. So identify this patient has undergone a device closure, but identify the defect. I think our table-wise system is failing. Like this table, want to answer this?
Aortic regurgitation.
Anybody volunteering? No, it's not MR.
Aortic
so look at both the angios. Both the angios, this is a RAO view that is given and this is a LAO view that is given. I'm sorry, why it stopped? It stopped. It's playing here in my laptop.
Direct Gerwood. Direct Gerwood. Direct Gerwood.
So that Gerbo defect, direct Gerbo defect. How many in the audience think that is the right answer? You have only 4 people supporting you. Thoda support badao. That is in fact the right answer. So it's a direct Gerbo defect. How do you know? Like it's simple, so simple. You see this is, so you are injecting into LV. So one of the atria is filling. One of the atria is filling. You look at here, this atria is not filling. So this is not LA. So RAO cannot make out whether it is an LA or RA. RAO can make out whether this is ventricular atria. LAO is kind of makes you clear LA, RA, left versus right is very well made out in LAO view. So you combine both the views, you are making an injection into the ventricle. There is an atria that is filling very nicely even before the right ventricle is filling. So you look at here, this LA is not filling at all, absolutely no filling of LA. So then this has to be RA filling. So LV to RA filling, that is a direct gerboard defect which was device closed. So this was closed with the device and very good results in follow-up also. Anybody from pediatric cardiology, anybody with, from Jayadeva, who are from Jayadeva? They should crack it. Now they are not raising their hand. So anybody from institutions, like they should be able to crack it. So this is post-surgery. What is happening? No, it's not just an aneurysm. So where is the catheter coming from? It's a post-surgical patient. Catheter is coming from the top. You are showing pulmonary artery. How it's possible? Sir, post-Fontana, post-Glenn. Oh, we are not seeing the lower circuit, so it's going to be post-Glenn. So what is being shown here? Sir, pulmonary AV malformation after Glenn. So large pulmonary AV malformation after Glenn. Why do they develop? Because when the antegrade flow is cut off, the hepatic factor doesn't reach the lung. That hepatic factor is needed to prevent the formation of pulmonary AV malformation. That is why people started doing antegrade flow were kept. You understood? Previously, I will just go back. This was the device closure of the same patient. So this was a So the same thing now, it's been device closed. The pulmonary AV malformation, 2 of them have been closed now. This is one, after one closure, you see another one going. So both of them were closed. So this is a simple PDA device closure. What is unusual about PDA device closure? I think PDA every one of you will be doing. What is unusual about this PDA device closure? Why the device closure is done in this fashion? यार ये भी didactic lecture हो गया ये तो. Nobody is opening up. So what is unusual about this? Somebody has, it's not released yet. The cable is attached from the aortic end. We don't commonly do that. We commonly keep the cable attached from the pulmonary artery end. Why somebody closed it like this? What is being shown here? Where is this injection? What is happening here? It's a simple, straightforward PDA. You could have easily gone in the usual way, you could have closed. What is happening here? So whoever answers this will get a pen. Yeah. Interrupted IVC. That is the right answer. Some of the faculty can use. So give me a big hand. It's an interrupted IVC. You can see this is azygous continuation. This is an injection made into the IVC. You can go, azygous is continuing and then entering into RA. So what are the ways to do device closure in this? So you can come from jugular. Very rarely for large, if the adult patient, you could have come from here and then taken the curve and put a device also. But it's easier done from the arterial end. So what is the device used? What are the devices that can be screwed from either end? So you have to think like that. So that is vascular plugs, and this is a conar MF device. The patient needed a simple pacemaker. Why the leads were placed like this? No. So pacemaker lead, the atrial lead is the usual lead. Why the ventricular lead is placed like this?
Sir, metallic tricuspid valve.
So that is the right answer. Give me a big hand. So it's a triple valve replacement. You can see 3 valves are here. The patient has undergone a metallic tracheostomy valve replacement. So you cannot put it into RV. So people have put it into the left ventricle. The simple CRT lead is placed in, and actually it's placed like a DDR pacemaker. Like. Got it? Like there's a 3 valves here. This is the tricuspid, this is mitral, this is aortic. So this is the one that we just discussed about. But so can you identify the device and the reason for such a positioning? What is the device? And why the loop is positioned like this? Anybody who wants to use a mic, wants to answer, you please use a mic.
ICD.
Mic. Can somebody give me mic? ICD device, right? You are right. So because
A growing child, sir.
So this is like a LSVC into, this is LSVC into CS.
Yes, sir.
That is why the lead is placed like this. So what is the device like? What is the type of ICD? What does these 2 dots indicate? It's not a simple ICD cable. Like what does this 2 dot indicate? This is a BDD system. So this is the whole thing. So you can see, this is an LSVC into CS. So and we ended up putting a VDD6 system. So what is this OCT?
Stent edge dissection.
What stent?
Stent edge
Coronary
dissection.
No, it's going to be coronary stent. What type of coronary stent? Can we see? Yeah. So they are no longer used now. You can see the edge dissection that came up. Why it's not like a sharp line? It's like a dabba, small. I'm not touching. You can see this. The stent studs are very different. This is BVS, biovascular scaffold. So this is a difficult one, but anybody picks it up, you will get a pen. So patient was actually having some MR with ASD, a small kid like 8-year-old. We did the angiogram. This angiogram is classical, like we rarely diagnose this by angiogram. Patient had some MR, that's why we did an angiogram. And this showed something very new disease, like it's a relatively new disease, recently described. Patient's reason for MR was MBPS. इससे ज़्यादा क्लू नहीं दे सकते हैं. इसके बाद I have to tell the diagnosis. Patient is ASD, MBPS with MR. So what is being shown here? Yeah.
Mitral annular disjunction, MAD.
So that is the right answer. Give him a big hand. It's mitral annular disjunction. Sir. So what is mitral annular disjunction? Like you can see here, you can see this is the disjunction. Like the part of the, why it's running fast, I don't know. But this is the disjunction part. So what happens is the myocardium ends abruptly and the mitral valve, there is a big gap between the mitral valve and the this thing. So this is the same patient's echo, simple ASD, not much MR, but you can see the clear mitral annular disjunction. You can see the disjunctional part. So this is now emerging as an important entity. So this is now recognized as the most important reason for malignant MVP syndrome. That is the malignant MVP syndrome. So you all know that 1% of MVPs can have syncope and sudden death. And now this is the surrogate end marker for structural marker for that. So what is being recognized is that opposite end of the LV septum gets a lot of scarring and they get into trouble. So that is what is happening there. This is a simple one. Anybody from the back benches?
HCM.
Anybody?
Apical balloon.
Sir, ASH type of HCL? ASH type of HCM?
Apical HCM, that's the right answer. Why are you saying so? There is a large aneurysm that you can see. The typical spade appearance is seen. So this is a very difficult one. If somebody picks it up, again gets a pen. Again, not usually diagnosed with coronary angiogram. The coronaries were incidentally done, but we picked it up. I'm really sorry. Is anybody? Normally we don't pick it up with coronary, but this was incidentally before surgery, coronary was done. And you can find it like patient had edema, patient had swelling. Anybody? Again, another pen for me then. So this is classical septal bounce documented on coronary angiogram. You can see now it's a patient of CCP. Just before surgery, we wanted to get a coronary angiogram since the patient was an elderly. So you can see a classical. You can see now very nice septal blushes there, and you can see the whole septal blushes. Respiratory variation of the septal blush. So can somebody tell me what is the sequence to diagnose cardiac involvement in a patient from hematology? Patient diagnosed with RCM having a hematological problem. What is the sequence that is to be done? T2 star. What for?
Hemochromatosis.
Hemochromatosis. So that is this is what is the typical T2 scar appearance of a patient with hemochromatosis and HCM. So what is this one? So what is it first of all? It's not a usual echo. What echo is this? Fetal echo. So what is being shown? You have a clue here. What is it? Fetal echo with 55 heart rate, what is going to be? CHB. How do you diagnose CHB in a fetus? atria, A waves and B waves are differently contracting. You can see the A wave and B wave are going differently. So this is how you diagnose fetal CHB. So this is a patient with fetal CHB. So you can see the ventricular rate and the atrial rates are very different. So what is being done and what is happening? What is being done? In which condition you do a balloon injection and then do a coronary simultaneously and check? Patient is undergoing some major structural intervention. Before that this was done, what is happening?
TAVI, sir. TAVI.
TAVI?
Yes. Yes,
No.
sir. TAVI.
You said TAVI, na?
Yes, sir.
No.
Mitral valve.
No, we don't do a coronary simultaneously and do a balloon occlusion and see what is happening to the coronary. You are right. You do it in
Yeah.
low-lying coronaries also,
Yes,
but this is not that one.
Oh.
You can see they are in different planes. You can see they are not in the same one. Like the balloon is somewhere else. Mike, can't hear anything.
For doing RAS operation, do you think you do it? No.
Anybody can get me what he is saying?
Before RAS operation, switching the pulmonary valve to outtake.
So this was actually before a TPVI, that is pulmonary valve implantation. So before a pulmonary valve implantation, you do a balloon occlusion and then document there is no coronary occlusion. So you can see clearly the whole LAD is getting cut off. You can see now this LAD, the whole artery is gone. The whole artery is gone. Very rare documentation of RVOT balloon dilatation ending up with an LAD occlusion.
Interatrial course of LED. Interatrial course of LED.
So it's an anomalous origin of LAD. We don't know the course from this, but it's an anomalous origin of LAD. From the right side it is coming. So there the chances of occlusion is far higher. So this is a patient who is planned for a pulmonary valve implantation. You do a balloon occlusion and then document whether that is occluded or not. So this again another question. It's a pulmonary artery angiogram. So what is the possibility? It's going to be answer, like it's going to be on the vote. Then start voting. लगता है लुपिन वालों को पैसे वोट के लिए पैसे देना पड़ेगा अब वोट नंबर कम हो गया Okay, so what is this form of pulmonary AV malformation? You are right, this is the pulmonary AV malformation. How do you diagnose it and what is this form? So this is known as the diffuse form of pulmonary AV malformation, which can actually be missed by your CT also. So this can only be diagnosed by your saline contrast echocardiogram, and this is classical diffuse pulmonary AVM, that multiple dots which immediately fill the LA. So this is diffuse form. Suppose this patient was cured by doing something, what that something will be. Some intervention was done and the patient was cured. What that something will be. Such diffuse pulmonary AV malformation can be because of that all of you should take home. PAH and all adolescent, you should look for this. I'm sorry, this is not playing. So this was actually an Abernethy malformation. This is actually an Abernethy malformation which you put in a device and then we went ahead. So anybody who answers, like, anybody wants to answer this? Patient has renal artery disease, why? Patient came with some ACS, hypertension.
Fibromuscular dysplasia, SCAD.
What is being shown here?
SCAD.
No, not builder appearance. We are not showing builder appearance here.
SCAD, sir.
Spontaneous coronary artery dissection.
Yes, sir.
This is spontaneous coronary artery dissection in multiple coronary artery systems, both in right as well as left. You can see the SCAD. You can see nicely. Okay. So this is well known to be associated with SCAD, is well known to be associated with fibromuscular dysplasia. I will end up with one or two coronaries. So what is this one? This is simple one.
L kappa. Sir, L kappa.
So what is being shown? What is happening to the RCA? RCA from the left sinus with the intraarterial course that we have to pick it up. What is this one? Now, this is post-operative patient. What is being shown? Nowadays, nobody is doing it, so you may not know now, but some of the older surgeons used to do this. Right gastroepiploic artery placed into RCA. So, the right gastroepiploic artery graft. So, you tell me some diagnosis, I will show the angiogram. Exam mein hota hai na, you tell a wrong answer, then we'll ask you the right question for that answer. So, what is this one? This is R kappa. This is R kappa. R kappa means anomalous RCA from the pulmonary artery. So anybody diagnoses this will get a pen. It's a simple one, routine one, you should all pick it up. It's a simple one. I will end with this. Anybody raise your hand if you want to answer, yeah. Mike.
Sir, LM exoma, tumor flesh is there.
No, it's not a LM exoma.
Sir, stent abscess is there.
See more. It's not matter, LM exoma.
Sir, stent abscess.
No. You see that you have picked up some calcification. Where is the calcification? What is happening? Who is answering? Mike.
Calcified LV aneurysm.
That is the right answer. It's a calcified LV aneurysm. You can see a large, big aneurysm from the start, like it's a large, big aneurysm in the LV apex, like the septum, the whole apex is aneurysmal, and then our LAD is occluded. Post stent, there is a stent, LAD is occluded, there is a big aneurysm. You can see the aneurysm here. Maybe you can pass on the. So I have more. So I think I will end here. Hope you all enjoyed them. Thank you.
Thank you very much, sir. In spite of having a very short duration of time, a lot of questions and a lot of interactive session has been done. I request Mr. Somen Datta to please. Yeah. I request Dr. Srinivas sir as well as Mr. Somen Datta to please felicitate sir for this wonderful session. I also request Dr. Kamal Sharma to please come on the stage. Dr. Kamal also want to catch the flight, so that's why we are felicitating him early. After this, there will be session of thrombotic guidelines. Dr. K. A. Sambasivam. I request to place introduction slide. Dr. K. A. Sambasivam. Dr. K. A. Sambasivam. Introduction slide, please. Can you have this introduction PPT on the main screen? The screen is getting off, so I request to play this on the yeah. So Dr. Sambasivam, he's a chairman cardiology and a senior interventional cardiologist, GKNM Hospital, Coimbatore. He's a recipient of Distinguished Service of Community Award by IMA Coimbatore chapter and Indian Association of Clinical Cardiology Tamil Nadu chapter. Principal investigator in several multi-central clinical trials involving nicorandil, then retablaps, abixamab, then ticagrelor and STEMI management. Has authored numerous publications and scientific papers in leading cardiology journals and has presented extensively at national conferences, including multiple CSI annual conferences. International faculty and speaker for major cardiovascular meetings in Japan, Malaysia, Italy, India and the USA, with expertise in complex coronary intervention, CTO, PCI, and structural heart disease, recognized for his contribution to interventional cardiology, cardiovascular research, medical education, and advancing cardiac care in South India. Yes, sir, over to you.
thank Lupin for having me here. The topic that is given to me is anti-thrombotic guidelines, update 2026. It's a very vast topic. And before we go into this, we'll play a few questions and responses, and then after that I will take. This is what I am presenting, the questions. Can you play the questions there? Yeah.
Yeah, I think
Yes.
friends, just
Hello.
to make it
Hello.
more interesting, we wanted to introduce this concept of Kahoot quiz and answers and response. If you just scan that QR code there, you'll all go into that, and then probably you can start interacting and playing. It displays who has done what. If your phone is on your name, the names also will come up there, and finally, whoever has done maximum, I think Lupin wants to give you some prize. So this is just to make it more interesting and interactive. So please scan that and enter. All of you should participate. Thank you.
Yeah, can you just move on? So before I give my presentation, let's have the Kahoot questions. Can we have the first one? Yeah. What are the major classes of anti-thrombotic agents recommended in current CVD guidelines? What's the time given? Is it, can we have the display of the response? So can you have the responses displayed? So we'll move on to the next. I think at the end we'll have the response, or is it that way or what? I'm not seeing the answers being displayed. Yeah. So now we got which antithrombotic class is primarily used to dissolve established thrombus when rapid reperfusion is required. Antiplatelet, thrombolytics, anticoagulants and VKA. Yeah. This is the next question. Which of the following lytic agent used to dissolve established thrombus? Yeah. So we will have it discussion at the end. The questions can probably be displayed again and we'll have it. So let's move on to the presentation. It's a very vast topic, I said in the beginning. Each category, like for example, ACS, pulmonary embolism, heart valves, DVT, devices, by itself each one is a topic, will take a lot of time in antithrombotic strategies, but I will give a bird's eye view. Can you just play this thing? Okay, it's fine, yeah. No, it's okay, this is okay. So what has changed according to the guidelines? So who needs what, which category of patients needs what, and when to de-escalate, how to manage bleeding? The flow of the talk is going to be in ACS and CCS, in atrial fibrillation, in pulmonary embolism and venous thromboembolism, mechanical heart valves and devices, and then we'll have a summary. Antithrombotic strategies in ACS and CCS, I told you the very large group, but I'll try to summarize. We all know this. CVD is one of the important contributing factors to the mortality, and antithrombotic agents, we can say antiplatelets, anticoagulants, and fibrinolytics. Three groups acting different levels, which when used prevent atherosclerotic thrombotic event, both primary and secondary prevention. But then the downside of them is one has to be careful because there is an excess bleeding risk. So the bottom line is you have to see the bleeding risk versus thrombotic or ischemic risk before we choose which strategy and how to go on. That's what we are going to have in the next few minutes. We all know in patients with ACS, loading dose aspirin followed by maintenance dose of 75 milligrams to 100 milligrams indefinitely is the default strategy. We all have no doubt on that, and there's not been much of a change on that, except the continuing aspirin is a bit questioned. In ACS, according to the ACC 2025 guidelines, in several scenarios, we have scenarios like ACS with STEMI, ACS with NSTEMI, ACS with STEMI going for a primary PCI, NSTEMI going for a PCI, or patients on medical management. We need different strategies. Supposing patients with STEMI or NSTEMI going for a primary PCI or a PCI, the strategy now is P2Y12 inhibitor, the stronger one, that is ticagrelor or prasugrel. If ticagrelor or prasugrel is not available or is not contraindicated, then you need to choose clopidogrel. And patients going for CABG again, aspirin to be continued and restart with the P2Y12 inhibitor post-surgery to be continued for 1 year. No planned revascularization, ticagrelor still has a role. It's better than clopidogrel as evidenced from Plateau, which I will come to. Patients who are given fibrinolytic therapy, yes, in certain scenarios, most of the times it's clopidogrel. In some scenarios, you can probably still choose a stronger P2Y12 inhibitor. So I'll give a few case examples. A patient with STEMI, say a 58-year-old, and who goes for a primary PCA and had a 3.515 stent to the LAD. He has no high bleeding risk. So what's the strategy? The strategy will be DAPT, which consists of aspirin and ticagrelor or prasugrel, and usually for 1 year. The strategy to be changed, reassessed depending on the bleeding risk in the following months. And then after that, transition to a single SAPT. Patients with ACS going for a PCI, but has got a CKD, stage 3, and a hemoglobin of 9, and past history of GI bleed is not same as what we saw in the previous slide. This patient has got a CKD, a hemoglobin 9, and a past history of bleeding. So he is at a high bleeding risk. We define high bleeding risk based on this ARC definition. So this patient needs abbreviated DAPT regimen, maybe 1 month followed by SAPT, which could be ticagrelor, or 3 months DAPT followed by ticagrelor. So strategy is based on the bleeding risk, which is very important, and studies have shown that they still have a good effect. Patients with NSTEMI, atrial fibrillation requiring oral anticoagulation and going for a PCI. So what do? Triple antiplatelet for a very short period which you can individualize, after which you can choose a P2 vital inhibitor and an OAC. And after 1 year, you can, depending on the risk involved, just confine to OAC alone. The evidence comes from these studies, Augustus, Redual, PCI, Pioneer, and then OAC after 1 year is from these data, meta-analysis of these data. What about a female NSTEMI medical management? Again, P2 vital inhibitor, and here I was mentioning you, ticagrelor is better as per the plateau. So you can continue P2 vital inhibitor in ACS for default 1 year, and the choice could be ticagrelor, which scores over clopidogrel. Clopidogrel is given if ticagrelor is not available or is contraindicated. A patient, 70-year-old female, known diabetic, past history of MI, undergoes a left main bifurcation PCI after calcium modification. No high bleeding risk, high ischemic and thrombotic risk. So this patient will definitely require a high-end P2 vital inhibitor along with aspirin, and for 1 year at least, and after which you can still consider continuing them based on the level of ischemic risk. One of the talks which we had, Kamal Sharma was giving about the AA. Once you put these data into the AA, probably it will give you what kind of calcium modification do, what kind of antiplatelets you can give, and how long you can give. All this can be done, probably we will be seeing in coming years. What about chronic coronary syndrome? Run-of-the-mill PCI, chronic coronary syndrome, no high bleeding risk. DAPT is a strategy for 6 months. High bleeding risk, abbreviated DAPT, which can be 1 to 3 months. High ischemic risk, you can consider extending beyond 6 months. So that's an algorithm for patients who are going for CABG and who does not require an anticoagulation. So before deciding on DAPT, look at the ischemic risk. Like for example, ACS as a presentation, prior MI, stent thrombosis, patients with diabetes, multivessel disease, multiple bleeding risk based on the ARC definition which I mentioned, clinical presentation, is it ACS or CCS, and procedural result, is it multiple stents, how is the outcome, and what is the site. So all these things have to be taken into account before you decide on the type of DAPT and the duration. So who are the candidates who may not be ideal for a very short DAPT? Previous stent thrombosis, as I mentioned, left main bifurcation PCI, multiple stents, and high thrombotic risk, technically complex PCI. These usually require prolonged DAPT. Short duration of DAPT, the strategies can be switch over to an inferior P2 vital inhibitor or change to a SAPT. These are some of the evidences. Master DAPT leaders and Tycho and Twilight has helped us to come to this diagnosis, and that's why the guideline recommendation now says you can do abbreviated DAPT followed by SAPT. What about parenteral anticoagulation? Unfractionated heparin, time-tested one, is given as per the weight-based in all patients with ACS. When do you give low molecular heparin? Yes, you could substitute low molecular heparin instead of unfractionated heparin in most of the scenarios, even in patients going for a PCI. But in the fondaparinux, give only in patients who are going for a medical management, because one study has shown that there is a catheter thrombosis risk is very high. So medically managed, you can give any one of them. Going for PCI, unfractionated heparin, how long you will give? Give till you revascularize, or at least for a period of 1 week of ACS. Fibrinolytic therapy, we all know that patients presenting with STEMI, continuing symptoms of up to 12 hours, or there is a delay in transferring the patient to a primary PCI center, and there is no contraindication, you can give fibrinolytic therapy, fibrin specific or otherwise, depending on the scenario. It should be administered, definitely reduce the MACE. And all these patients subsequently should be on parenteral anticoagulation. Next, moving on to atrial fibrillation. I mentioned in one of the cases, patients with atrial fibrillation, where there's an indication for OAC. So you have to have an abbreviated triple antiplatelet therapy followed by OAC with P2 vital inhibitor. So you need to look at the thrombotic and bleeding risk. We all know that the CHATS-VASc is the one which is used to find out the risk and then prescribe the patient's anticoagulation. The current ESC has taken the CHATS-VASc, the female gender, out of the use, basically because they didn't find a big difference, even though the ACC continues to have it. So which anticoagulation? Is it VKA or DOAC? Studies have shown that DOACs definitely are better, safer, and can be chosen over and above VKA. No aspirin role in these patients. Of course, you need to look at the renal function, the weight, age, and then adherence and dosing criteria before you go on continuing the NOAC. So these are the things which I mentioned. One has to take into account before you continue to prescribe NOAC in this group of patients. Patients with AF with chronic coronary syndrome, once their ischemic risk is out, just NOAC is enough. Continue. Coming to venous thromboembolism and pulmonary embolism, the latest ACC has given categories based on the hemodynamic situations, which is very important, even though we all know anticoagulation is the fundamental in all these patients. But based on the category, you can escalate to reperfusion strategies apart from anticoagulation. Like, for example, patients with categories D and E, where there is a hemodynamic compromise, where there is evidence requiring reperfusion, one has to adapt to reperfusion. Clinical decision making is very important. And continuing anticoagulation, NOAC, or low molecular weight heparin in certain categories, especially with malignancy-associated venous thromboembolism. Unfractionated heparin in scenarios where it's flexible, where suddenly you assess the patient and patient is requiring reperfusion, unfractionated heparin, otherwise low molecular weight heparin followed by NOAC. Patients with intermediate risk PE, not all PE should be reperfused or use fibrinolytic therapy. Watch them, assess them, monitor them, look at the biomarkers, look at the RV function, and then decide. So this is where you need involvement of emergency response team. This I already alluded to, systemic lysis wherein you want to give, which can be systemic or a catheter-based or mechanical thrombectomy or surgical embolectomy. When the patient has got a provoking factor, you can confine your duration for a short period of 3 to 6 months. Reassess the patient. What are the chances of him having a recurrence? If there is no definite provoking factor, desire to continue to extend for a longer period, which can be sometimes indefinite, especially in patients who are oncology-associated situations. DOACs can be definitely prescribed or low molecular heparin in these group of patients. One has to watch out for the GI bleed, severe thrombocytopenia, drug interactions, and urgent invasive procedures. All these have to be taken into account when you prescribe on an extended period. Mechanical heart valves, fundamental lifelong VKA for mechanical heart valves. DOACs are no as of now, and the targeted INR based on the valve type, the position is very important. Bridging is not always, one has to be individualized. Depending on the type of the procedure, one has to decide whether bridging is required or not. Bioprosthesis, yes, most of the times it is antiplatelets, where individuals requiring anticoagulations, one has to decide on NOAC along with. So basically, antiplatelets are sufficient. Coming to structural interventions, the central principle is there an indication for OAC? What is the device or procedure that you are doing? Is the patient having an ACS or not? What is the bleeding risk? All these have to be taken into account and then decide on what kind of strategy one has to adapt. For patient with TAVR, no OAC indication, just give aspirin for about an year. After that, you can reconsider and decide continuing it. If the patient has an AF or another indication for OAC, you can probably substitute OAC and take off the aspirin. Don't give all patients with TAVR an OAC or a DAPT. TMVR is a different ball game. These patients are at a higher risk for thrombosis, so you need to anticoagulate him at least for 6 months. And then based on the risk, you choose to continue or not. TAVR and TMVR are different ball games, so don't extrapolate TAVR recommendation to TMVR. Mitral clip, no OAC indicated, just continue antiplatelet. If there is an indication for OAC like AF, then you can continue them. Avoid unnecessary combination of OAC with antiplatelets. If there is a need for a antiplatelet like PCI or ACS, you can probably combine them for a short period. Device closure, PFO or ASD device closure, again, you can give aspirin and clopidogrel for a month, and then just a single antiplatelet for 6 months, and long-term therapy based on their stroke risk. Appendage occlusion, like Watchman, you decide on need for anticoagulation, and based on that, you devise the strategy and duration. And follow-up TE or CT is very important because device-related thrombus management strategy differs. So at a glance, in structural interventions, for TAVR, SAPT aspirin is enough unless you have an indication for OAC. TMVR, yes, usually OAC for a period of 3 to 6 months. Consider long-term OAC if there is an indication. Mitral clip, antiplatelets alone is enough. PFO closure, antiplatelets. ASD closure, APT for several months. Appendage closure based on the scenario. Peri-procedural anticoagulation, I mentioned what kind of a procedure patient is going to undergo. Based on that, you decide about bridging. Warfarin bridging is reserved only for highly thrombotic risk patients, not a default strategy. Special populations, CKD, depending on the stage, elderly, frail patients, and pregnant patients, one has to be choosy in terms of your antithrombotic strategies. There are newer antithrombotic agents in the pipeline, investigational, not yet coming to the guidelines. Subcutaneous P2 vital inhibitors, those acting on the glycoprotein 6, and PPAR4 antagonists and factor 11A inhibitors. So the points to ponder: indefinite aspirin as expired, the role we don't consider now. Do not give underdosed NOAC. Underdosed NOAC are associated with increased thrombotic events. Prolonged triple therapy, do not advocate. Make it very abbreviated. Bridging, choose, be choosy. In mechanical valve, no role for DOAC. Routine thrombolysis not indicated in intermediate PE. Reassess the patients, this is very, very important. The take-home message: after ACS PCI, personalized DAPT, AA algorithm will probably help in that. AF PCI, yes, confined to OAC after 1 year where the ischemic risk goes off. Keep combination as short as possible. Prefer NOAC in patients with AF or VTE. PE guidelines require reassessment and involvement of PRC team deciding on the perfusion strategy. After TAVR, only antiplatelets, no need for OAC unless it's indicated. Thank you for your attention. So do we have the questions now? The quad response?
Can you connect that laptop, and sir wants to see those responses? If not the typed ones, maybe many of them might not have typed. At least the direct answer responses of ABCD 1, 2, 3, 4 can be shown. I think this is the first time we played Kahoot. They are finding it some challenge. We'll further take it once Kahoot comes in further lectures.
Sure.
Is that okay? No? Any questions you want? Anybody wants to ask, sir? Actually, very practical things which has come recently in the guidelines. That's why I incorporated. Tomorrow, the antiplatelet guidelines also, Dr. Taram Kambani is the author of both guidelines. He'll be also there to discuss antiplatelets. Any questions?
Sir, what about the role of antiplatelets after PDA device closure?
Sorry?
After PDA device closure, how do we have to give SCPT, DAPT?
I'm not able to.
Sir, after PDA device closure. PDA device closure.
I couldn't.
Device antiplatelets, normally after VSD closure and ASD closure we give. PDA, if it's sitting inside like a cork, nothing is required. But some projections are there sometimes, especially in adults, we might give for 6 months. But otherwise, for PDA closure, it's like a cork closure. Generally, it's not recommended. It gets closed.
You're talking about device closure, PDA. Oh, okay.
Yeah, that's what.
Yeah.
Unless there is some particular indication where some projection
not required,
or something was required, and otherwise it's not required. That's a closure where it causes like a cork, like you have seen the milk bottles which we used to have in childhood. If that goes, that's the best procedure possible in interventional cardiology. They feel immediately it gets closed off and child is cured of these things. The reverse of PDA closure, do you know any procedure? Actually, Rama has finished that. We have actually closed one of the surgeries with that. Myself and Nageshwara, when we were together in care, we used to practice that. The reverse of ductal closure is ductal stenting in highly cyanotic duct-dependent circulations. We put a coronary stent in the device and the duct, and child becomes very pink, and that's how BT shunts are gone out of vogue once the ductal stenting started. Okay. Think any questions on this antithrombotics? Otherwise, we'll break for 10 minutes briefly, stretch your legs and then come back and reassemble. Then we will have another few interesting talks coming up on basics maybe, now angiography, angioplasty, cath lab toolkits, and then OCT, IVUS to come. In the end, we'll have a complication session before we close. I think so request all of you to have a brief break and come back and join in 10 minutes. Thank you. There's one announcement for people who want credit hours. The people have to click pictures and the geotagging will be done. Then only credit hours will be issued, I was told. So 2 credit hours for today and 2 for tomorrow. So the organizers are making arrangements to take your pics there. And you have supposed to take your pictures, then only you'll get your credit hours. Please do that if somebody is interested. Thank you. Kahoot is there. नहीं Kahoot की जरूरत नहीं. चलो कितना देर बात करें. Dr. Deepak? Deepak, we'll start. Come. Request all of you to reassemble back in the hall. We'll start post tea sessions and we have interesting talks to come. Request Deepak to introduce.
I request all doctors to please come into the hall so that we can initiate or we can start the session on time. After this, we can start with cath lab toolkit for PCI guide catheter, wires, balloons, stents. So for this, Dr. Mahendra Prasad Samal, he will take us through this session. I request all the doctors to please come inside and settle down fast. Session of that is Dr. Kajal Ganguly sir. Basics of angioplasty, selection of guide wires, balloons, and stents. I request our senior faculty to please sit onto the chairs which are placed over in the front of stage. Can we have introduction slide of Dr. Mahendra Prasad Samal? I request all the doctors again to please come inside. So next session is cath lab toolkit for PCI, guide catheter, wires, balloons, stents. For this, we are having with us Dr. Mahendra Prasad Samal. Dr. Mahendra Prasad Samal, he is a senior interventional cardiologist, Apollo Hospital, Bilaspur. He is having 18 plus years of experience in cardiology with expertise in interventional, structural, and non-invasive cardiovascular care. Performed more than 3,000 angioplasties, 10,000 plus cardiac catheterization, 500 plus congenital devices closures, and 1,000 plus pacemakers, all these things. I request doctors to please come on the stage. Yes, sir, over to you.
Good evening to all of you. Thank you, Dr. Srinivas sir, for giving me opportunity. So I'll be just talking few words about the cath lab toolkits. I think all of us, while working in the cath lab, lot of things present in the legs, but we should know which things should be required at what time and what things should be required during your procedure. You may have a IBS and OCT in your desk, but you may not be using both. So you should know what to use, what device, and what where, what to time, and what guiding which time. So the PCI toolkit regarding the guiding, selection, catheters, guide wires, balloon lesion preparation, corner stents, complex PCI kit, and bailout and final optimum and summary. So these are all, I think, the kits which present in day-to-day cath lab for during the procedure. So starting from the Sullivan needle to your venous access, arterial access, sheaths, wires, and stents, balloons, then IVUS, OCT, rota, and all these things. So how to puncture and what the, as from our student life we know, we normally puncture the femoral artery above the bifurcation over the head of the femur, and you should know how to puncture, not to do the multiple punctures, so that you should properly press the puncture sites. So either you do blindly, or you can go for a ultrasound guided the puncture, or you can go through micropuncture set, which is available now. After puncturing the 4 French sheath, then you can confirm it, then you can put it your normal sheath. Same thing what I told you, if you do the ultrasound guided puncture, you should find out how to practice it by which is the common femoral artery, which is the bifurcation point, which is the femoral vein, and accordingly you puncture so that there should be no hematoma or multiple punctures. So next comes to the guiding and diagnostic catheters. All of us know that diagnostic catheters, these are less thicker in size in compared to the guide catheter. Guide catheter has a luminal diameter is more than the diagnostic catheter. So even if it is 5 French, you see that 5 French diagnostic catheter has a less lumen diameter in compared to the guide catheter. Guide catheter always have a more infiltrator construction, 3 layers. Of course, diagnostic also have a 3 layers, and every even diagnostic has a 5 French, 6 French, and 7 French, and guide catheter also 5 French, 6 French, and 7 French, 8 French, and for other procedure you can get a bigger size 9 French, 10 French also. So various guide and diagnostic catheters are available. The standard is Judkins and Ampliger, and nowadays extra backup catheters are available. You can say Judkins right, Judkins left, Ampliger, and for the carotids, you can say the Siemens catheter, which is for better for the carotid procedures. So this is about, when you plan for diagnostic procedure, you can take 6 French diagnostic catheter, but whenever you preparing for therapeutic procedure, you should know, if you are doing complex procedure, you should select the guide sheath accordingly, sheath and guide. Suppose if you doing a complex procedure like bifurcation setting, left main stenting, or wants to use IVOS, rota, you should always hands-on go through with 8 French, not less than that. So these are all same thing, guiding catheters. These are Siemens catheter, which is used for the carotid interventions. So next come is guide extension. What is guide extension? This is nothing but a mother and child technique. These are catheters introduced through the guiding catheter. It can take over for easy placement of the stent. It can go inside your catheters and beyond the artery lumen, and it goes inside the artery. So it can easily give you hands to place the stents, distal lesion, and you can, suppose if you want to aspirate the thrombus also, you can easily aspirate the thrombus from the distal belt. So there are various guideliner available. I think the commonly we use Guidezilla and Guideliner. Others company like Telescopic and other companies are also available now. So next is PTCA guide wires. PTCA guide wire is really the, you can say the main thing where if the guide wire cross, then everything is, I think you take a really breath that yes, I can do the procedure. If your guide wire do not cross, then you are really get panic. So what are the components of guide wire? The guide wire has a 3 component. One is core, which is made up of either steel or nitinol or hybrid metal, and then the tip has a load type like 1 gram, 2 gram, 5 gram, 10 gram, and outer to the tip there are some coils which gives a better penetration and tracking to the tissue. So there are a lot of wires available in the market. We tell the wires can be divided into 2 types. One is workhorse, which is commonly used, and which is floppy type of wire. Another is CTO wire, which is hard wire, piercing wire. These wires can penetrate the calcified lesions. So these are all available wires like workhorse wires like Pilot, BMW, Run Through, Whisper, and the hard wires like that Gaia and Filter XT, Filter X, these are all hard wires for the CTO lesions to cross the hard lesions. So how to choose the guide wire? I think the next speaker will tell how to choose the guide wires. He will tell better because I don't want to go through. So next comes the catheters. So catheters which are used in the intervention, we have two types of catheter. One is monorail, another is over the wire. What is monorail? Monorail is there are two lumen. One lumen you pass the guide wire and out, and other lumen is for your inflating the balloon so that you can get inflation of the balloon. Whereas the OTD over the wire balloon, which it has a single lumen, you pass the wire in the same lumen and to try to cross the, it helps in crossing the lesions. So next is other balloons like plug modification balloons, which is called cutting balloons. These are our Wolverine balloons, cutting balloon, or scoring balloons. These are balloons with blade in the balloon, so that whenever you want to cut the fibrotic tissue or calcified tissue, you implant it, it will cut the calcified tissue or fibrous tissue. So similarly, for plug modification also, we have another device which is called Shockwave that I think we will talk to the other later part. So other device which used for in the cath lab for plug modification is the atherectomy devices, which is ROTA or IVL. And ROTA, I think ROTA and IVL already discussed in the Dr. Sharma has widely told how the ROTA has been helpful and how the IVL is helpful. IVL basically cracks the calcium inside the lumen in the media also, whereas ROTA only helps in entering to the vessel. It never debulk the calcium. It only gives a passage to the artery so that you can easily pass the balloon. After crushing the wire, you can pass the balloon, but it never debulks the calcium. Rather, the IVL balloon that debulk the calcium, then orbital atherectomy debulk the calcium, so that you can use bigger balloon to prepare the bed. So this is the new ROTA machine, I think Abelu ROTA Pro. So next is orbital atherectomy, as already told by the previous speaker. Orbital atherectomy is same, it spins, it scoops up more calcium from the artery rather than give a passage. So ROTA gives a better passage, whereas the orbital atherectomy scoops out calcium throughout the lumen, so that it will give a better bed rather than the ROTA. So next is laser. Laser also used for preparation of the bed, or you can say that preparing the fibrocalcific lesion. So you can laser will be best helpful. So, but it is too costly. Very few centers have a laser, but it will be helpful in a calcific lesion. Even the old pacemaker lead which has been calcified, fibrosed and calcified, you can take out by the laser. So next is drug-coated balloon. These are the balloon which has been used for the small vessel angioplasty. As you know that small vessel angioplasty never gives good result in the stenting. So these are used for small vessel angioplasty. Drugs are coated over the balloon, either paclitaxel or sirolimus. So once it is inflated, the drug will be eluted to the vessel wall. So now next comes the stent. Stent, I think, is the major things which should be discussed in the stent. Stent, as you should know that how the stent is prepared. Stent is prepared by a laser beam from a metal slot. The beams are, the holes are made with from a solid tube to making a laser holes. They prepare the stents. So stents can be a open cell or closed cell according to the links which is provided in between the cells. So what are the best stents? Stents should be deliverable better. It should be side branch access, should be safe, and it should be a freedom of resistance. So these are the best quality of the stents. So stents, as I told you, better visibility. If you take a cobalt chromium stent, this is better visible rather than stainless steel. And the trackability and the pushability is better with the cobalt chromium rather than the stainless steel. So as a whole, if you think the stent should be a better deliverability, trackability, and good stunt apposition. If the stent is not properly apposed to the endothelium, then definitely there will be a prolapse of the endothelial tissue and there is a chance of acute occlusion or stenosis later. So it should be a better radio opaque also, so that when you deploy the stent, you should know the proximal margin, distal margin, middle margin, and how it touches to the endothelium, the vessel. So, and the better stent, it contours the vessel, just like, you know, the device which is in ASD and BSD, it is a self device. It should be a better, takes the better contour of the lumen, so that it sits to the lumen. And should be minimum overlapping. As I told you, the closed cell and open cell, these are closed cell and open cell. The links which are present all in the closed cell, you see all the 4 cells side is closed, whereas the open side is the only 1 or 2 sides. So the same thing, open end cell I told you. So next is imaging. I think lot of things has been told by the imaging. Why imaging is required? Imaging is required because you know which stent you want to take, whether the stent is opened properly or not, whether there is a edge dissection or that, whether fibrosis tissue or that, whether new endothelial has happened. So that all things will require. Suppose you have put a stent. Now the edge you get a fibrosis or new atherosclerosis. If new atherosclerosis is there, you have to put a new stent. But if there is fibrosis is there, so you have to do a drug-eluting balloon or something like that. You need not to put a stent again. So definitely, therapeutic point of view, imaging is much more important when you do a bifurcation lesion, when arterial lesion, when too much of calcium lesion. So you should know what type of tissue you are dealing. So tissue delineation is better, the margin delineation is better, so that you can ideally put the stent in exact location. So precise decision, precise deployment of the stent is also required. So for imaging, we have 3 intravascular ultrasound, then OCT, then NITS. The difference between IVUS and OCT is clear cut. Only hardly ever the IVUS has a good penetrating power. It not only say you what is inside the lumen, but it goes beyond the lumen, media, and medial calcification is better because it has a penetration power is more. However, the OCT has a better, will tell you what is inside the lumen, whether the luminal new atherosclerosis is there, because the tissue penetration is not as like as IVUS. So if you want to know what is happened inside the lumen better, then you should prefer the OCT. If you want to know total vessel, then you should go for the IVUS.
Doctor, I think IVUS and OCT will be covered by the next speaker. We can proceed. IVUS and OCT, we have next set of talk. We can count.
So I think that class IVUS and OCT, that class will be covered better. So these are all IVUS lesions and OCT lesions. So you should know how the IVUS lesions look like in real study and how OCT look like in real study. So because it will give you a practice, then only you know how it goes to. Then other things in the cath lab, as you know, that IABP, which is mechanical circulatory device, which will give some rest. You can to heart because it opens, give a coronary perfusion in diastole, so that myocardial perfusion may better. So other balloons like we use in, like BMB balloon, INO and Acura, and peripheral balloons like Atlas. These balloons are used for heart, the aortic balloon plasty or pulmonary balloon plasty. So on cover stents, as you know that we have a Grapmaster and other things, PPK and Backrad. So these are all should be in the lab. And BMB, I think you should have the broken needle and BMB sheath, and the Mullen sheath should be in your lab. How to puncture the intraoral septum, what are the landmarks, you should know all this. At the last, you should have a snare in your lab, which is a life-saving to whatever displays like coronary stents are displays, you can pull out. If you do not have a snare in lab, join the 2 PTCA wires in the floppy end, put it inside the RCA catheter, take it outside and pull it. That will also behave as a snare if you do not have a snares. And some gels are available if artery is going, peripheral artery is rupture and you can put some F gel, just like bronchial artery embolization. If a patient is recurrent hemoptysis, you just put F gel to the artery will close. So some microcoils also you should be there, so that if you get a embolization to the bleeding artery, you can close it, and at last you should have a cover stent. Thank you.
Thank you, Dr. Mahendra. You can come and join us here. I think we'll hear more about which guides, which wires, and which type of angioplasties from senior doctor. We are fortunate to have Dr. Kajal Ganguly, sir, for this topic. We'd like to hear, and then we can have some discussion on this cath lab material and type of wires, balloons, in which session, and we would be happy to clear some of your doubts too. Then after that, we can have IVAS and OCT talk. But before that, we'll hear from Dr. Kajal Ganguly. Over to you, sir. You can introduce.
Before that, let's go for felicitation. I request Dr. Srinivas Kumar to please come on the stage to felicitate Dr. Mahendra Prasad Samal for this wonderful talk. Thank you, sir, for taking the time and taking us through. Let's move to the next talk, that is the basics of angioplasty, selection of guide wires, balloons and stents by Dr. Kajal Ganguly. Dr. Kajal Ganguly, he is a senior consultant interventional cardiologist, Manipal Hospitals, Broadway, Kolkata. He is having 35 plus years of experience, interventional cardiology, academic in leadership and cardiovascular healthcare, past National Vice President of Cardiological Society of India, and former President of General Secretary of the CSI West Bengal branch. He is also principal investigator for many landmark trials, has lot of publications and lot of awards also in his kitty. He is recognized for his outstanding contribution to interventional cardiology, cardiovascular research, clinical excellence and medical education. Over to you, sir.
Thank you, Dr. Srinivas and Lupin Industries for a beautiful session, for a beautiful organization, for the understanding of this interventional cardiology. So my topic, is basics of angioplasty, selection of guide wires, balloons and stents. At the very onset, let me tell you, when 30 years back, when we started our journey in interventional cardiology, there were very few teachers. We learned by our mistakes. Now we have so many teachers and we can show you how you proceed. So basics of this intervention is to assess the lesion, plan your strategy and apprehend the complications from the very onset so that you can smoothly do your work. So a patient has a severely calcified tortuous coronary artery lesion requiring PCI. How would you select the guide wire and balloon strategy for lesions crossing this preparation? Right? You have got patient's pool. So which of the following is the most appropriate approach for selecting a coronary guide wire for a complex tortuous calcific lesion? Always use a softest and most flexible workhorse wire. Select the wire characteristics according to the lesion complexity with escalation to support or tip load required. Use a high tip load wire routinely for all coronary arteries. Select the guide wire primarily based on your radio opacity. Which one will you do? Obviously, select the characteristics according to the lesion complexity, as I have said, with escalation of support or tip load as required. So let me go. During PCI, a stent is deployed but shows inadequate expansion despite apparently appropriate sizing. Which of the following is the most appropriate next step? Immediate implant another stent without further assessment. Perform high pressure post dilatation with an appropriately sized non-compliant balloon with intravascular imaging when appropriate. Deflate the balloon and terminate the procedure. Replace the guide wire and a software workhorse. So obviously, we will perform a high pressure balloon dilatation with an appropriate size non-compliant balloon. I shall come to it, how you do it with intravascular imaging when appropriate, if you can do it. So my topic will be on introduction, guide wires, balloons, cardiac stents, and practical approaches. So overview of percutaneous coronary intervention. PCI is indicated in ACS and selected patients with symptomatic stenosis or an objective stenosis. Guide wire crosses the target lesion and provides the pathway for device delivery. The balloon dilates and prepares the lesion while the stent maintains the vessel's patency. Device selection depends on the lesion anatomy, vessel size, lesion characteristics, procedural needs, and patient factors. So basics coronary anatomy related to PCI. Reference coronary artery originates from the right coronary artery originates from the right coronary sinus. You know it. Divides into several branches. The left coronary artery lemma divides into 2 branches, and you determine the dominance of the artery according to the PDA, and 1 left ventricular branch which the artery gives, that is the dominant artery. So pre-PCI lesion assessment, as I have said, assess the lesion length, vessel diameter, morphology, and stenosis severity to guide the device sizing and procedural preparation. Very important. Evaluate the calcification, thrombus, ulceration, tortuosity to anticipate lesion crossing difficulty and need for modification. Third is the assess bifurcation and side branch anatomy to determine appropriate stent strategy. Determine the baseline TIMI flow, 0 to 3 by coronary angiography. Evaluate the distal vessel quality, landing zone, and use intravascular imaging when indicated to optimize procedural planning. So guide wires. So principles. Number 1 is the core, distal tip, cover, and coating collectively determine the guide wire performance. The core provides support, pushability, and torque transmitted, while the cover and the coating influence the flexibility, lubricity, trackability. Flexibility and the tip load determines the distal tip stiffness and penetration. Lower tip loads provide softer and more atraumatic navigation. Flexibility and trackability enable smooth navigation through the tortuous vessels, while torque response provides controlled distal rotation. So these are the types of catheters we use commonly. General purpose wires, balancing, pushability, flexibility, as I have said. Then this becomes, and it depends on the what type of wire you are using. It is workhorse wire, we shall come to it, what are those. Hydrophilic wires that become very slippery when wet, allowing easy passage through the tight and blocked areas, but require careful control where it produces perforation very frequently. Hydrophobic wires provide greater tactile feedback and control with coating that reduces friction and the sticking. Specificity is designed for specific challenging situations, including wires that provide extra support, and this CTO-specific design chronic total occlusions with specialized tip stiffness and shapes that crosses resistant lesions. So important wire characteristics. The load determines the force needed to bend the wire tip, with lower loads being safer for the fragile vessels, higher loads for helping tight lesions. Flexibility allows smooth navigation through the tortuous vessels, while trackability enables the precise control. Trackability allows the wire to follow the pathway of curved vessels easily and support and penetrate and provide strength to advanced device in resistant vessels. So workhorse guide wires. The versatile wire used for most routine PCS, balancing a soft tip, pushability, flexibility, 1:1 torque and control, and for safer coronary navigation. 0.6 to 1 gram tip load, dual coat design provide stability, pushability, distal flexibility, and precise steering. The common guide wires, common workhorse guide wires we use nowadays are BMW guide wires run through intermediate Sion blue. Sion blue has the special characteristic because it can be used several times. So hydrophobic and hydrophilic guide wires, as I have said. So specific guide wires, the CTO wires, that is a stiff tapered tip designed to penetrate and cross chronic total occlusions. Polymer jacketed guide wire, low friction coating provides tracking through microchannels and distal difficult anatomy. Extra support wires. Stiff wires provide The stable for rail, provides the rail for balloon and microcatheter delivery. High tip load wires for provides a strong penetration in resistant lesions. Torsual and calcific lesions, flexible steerable guide wires we use. So starting from our basic guide wires, that is the workhorse guide wires, if there is any tortuous lesions, we use extra support guide wire like Iron Man. And if we need this hydrophilic wires, we use Filter XT, or nowadays there is the whisper wire, which is a hydrophilic wire which penetrates through which goes through the micro channels. And stiffer wires, where we use in subtotal occlusion or total on CTO. These are mainly the pilot group, these and others. Mainly we use nowadays the Gaia series 2 and 3. And Shinobi wire is also available, which has got a tip load of 13 grams. So guide wire selection principle is a practical approach. Assessing the vessel involves evaluating the lesion calcification, the vessel bends, and distal vessel quality. Choosing the flexibility means starting with a soft polymer jacketed wire or workhorse wire for routine. Assess tortuosity, require this hydrophilic coated wire, as I have said. Escalate wire support for stiffer, heavy tip or tapered wire according to the calcific lesions or CTOs. You can verify the position of the guide wires, very important, and its tip with a true lumen in the single vessel by contralateral injections in CTO or multiple projections in the angiogram. So that is how you select your guide wire, starting from the worst core guide wire and escalating to the stiffer guide wires or these hydrophilic guide wires according to the lesions characteristics. Now coming to the balloon catheters. Role of balloon in angioplasty. Angioplasty is truly a lesion preparation, stent delivery, and optimization for final PCI. The balloon inflation provides vessel wall stretching, plaque fracture, and controlled dissection, resulting in acute luminal enlargement. Pre-dilatation facilitates lesion preparation and stent delivery. Post-dilatation with appropriately sized balloon, I shall come to it, improves stent expansion and apposition. Appropriate stent selection and control inflation optimize luminal gain while minimizing vessel injury and complications. So balloon catheter components and characteristics, diameter, that is the, I shall come to it, and its length, burst pressure you must know, and also the material and the mechanical platform, how it is made of. Types of coronary balloon, we have the compliant balloon, which if you inflate, it expands not more than 20%. So if you get a 3 millimeter balloon, it will expand up to 3.5. Semi-compliant balloon, it will expand less than 10%. And the non-compliant balloon, it will not expand more than its pre-measured diameter. Cutting balloon, appropriate microsurgical blades that create controlled incision in the resistant plaque during inflation. Useful in fibrotic lesions, calcified lesions, and in-stent restenosis. Scoring balloons similarly incorporate external scoring elements that concentrate dilating force and reduce the balloon slippage. So semi-compliant balloon versus non-compliant balloon. As I have said, semi-compliant balloon dilates less than 10% of the cases. Non-compliant balloon maintain near constant diameter with increasing pressure, provide uniform, predictable expansion, and focused radial force used for high pressure lesion preparation and stent position, post-stent dilatation. Preferred for resistant calcific lesion and stent under expansion. Enable controlled expansion for lesion preparation and stent optimization. For post-dilatation, we use this non-compliant balloon, post-dilatation. So balloon sizing and selection. Measure reference vessel diameter using healthy and proximal and distal vessel segments. Aim 0.9 to 1:1 balloon to artery ratio. But this is, I tell you, very difficult sometimes in ACS. You don't know, due to spasm, the distal vessel may appear narrow, but they have to assess it and give adequate doses of nitro or nicoran so that the vessel grows and gives the better understanding of the distal vessel and can make your sizing the stent easier. Select balloon length that covers the entire lesion with healthy to healthy margin. Avoid oversizing to reduce the risk of dissection, perforation, and of the vessel. So, when you select balloon, we have got nowadays balloon size from 0.75 millimeter in severely stenotic lesion, and upsize is according to the need and give the maximum dilatation so that your device, that the stent, can cross easily. Lesion preparation, pre-dilatation may be considered for tight fibrotic or calcific lesion to facilitate crossing, delivery, and stent expansion. There is balloon selection should match the lesion morphology. Calcification, as I have said, non-compliant or specially selected balloons may be used for resistant lesions. Scoring or cutting balloon provide focused plaque modification and control calcium or plaque fracture. Adequate lesion expansion before stenting ensures full stent expansion. 1:1 balloon assessment may confirm adequacy. IVAS or OCT assessment of the calcium characteristics guides modification and confirm calcium fracture and stent expansion. So balloon-related complications are severe. That is, the balloon selection should be based on target vessel diameter, lesion length of the reference vessel, assessed by angiography, CT, or IVAS. Select a balloon longer than the lesion to ensure adequate coverage and reduce dissection. Avoid excessive balloon sizing relative to the target vessel to minimize vessel injury and dissection. 1:1 balloon artery ratio provides adequate expansion while minimizing vessel trauma. IVAS or OCT you use for getting the characteristic of the lesion length, as well as the type of lesion and the diameter of the diameter of the vessel you are going to stent. The coronary stents. Coronary stents, the expandable metal mesh that keeps the artery open and restores blood vessels. So other characteristics has already been discussed, so I am going to the detail evolution of the stent. Nowadays we use the current generation, newer days, that is the thinner struts, improved alloys, polymers, and the drug enhanced safety and healing. That is, current generation stents are, there is ultra thin stents as low as 50 microns, and biodegradable polymer is used. Also, no polymer stents are also available to improve the healing and reduce the long-term complications. So nowadays we use mostly the second generation stents, and characteristics are almost more or less same in all the stents. Few things are, you must remember that we use mostly the open cell design that gives better trackability, pushability to through the lesion, and also it gives very good access to the side branch. So, and also you remember it's closed cell stent we try to use in the osteal lesions. It gives better radial strength. Now, some of this you should know that the stent and balloon, there is a difference of almost 0.25 millimeter. So we must remember how to place the stent. Some of the stents have got marker to marker stent design that gives very good use in these osteal lesions, where you can place it very suitably, like giant stents and also other newer stents. Types of coronary stents I have said. So we shall leave it to the I have sent the polymer coating pharmacological agents we have discussed. Important stent characteristics, that is the radial strength, open cell, closed cell. Stent sizing is important. So stent should cover from the 2 millimeter proximal to the lesion up to the distant end of the shoulder. You should not cross more than that, because of the longer stents will produce the myonecrosis, more incidence of stenosis. Stent deployment and optimization. Accurate deployment ensures proper sizing and placement, minimizing geographical miss and recoil. High pressure non-compliant balloon optimization provides stent expansion and reduces under expansion. POT improves stent apposition and provides side branch access in bifurcation lesions. IVAS or OCT confirmation verifies stent expansion and is associated with improved cardiovascular outcome. So we usually now deploy the stents at about 11 to 12 atmospheric pressure, post-dilate it up to 18 atmospheric pressure, and which gives the better stent apposition to the vessel wall. So practical application, device selection as step by step, confirm stent expansion at the appropriate imaging, post-dilatation when indicated, evaluate lesion location as I have said, choose guide wire characteristics, stent size is important, type of balloon as we have discussed, common errors and complications and troubleshooting. That is, excessive side, the wire manipulation may cause coronary dissection or perforation, excessive balloon pressure or forceful manipulation may cause balloon rupture or entrapment, complications like stent underexpansion or edge dissection or geographical miss may result in suboptimal stent deployment, stent thrombosis or in-stent restenosis may occur due to mechanical problems such as underexpansion, edge dissection and geographical miss. Troubleshooting use angiography and ultravascular imaging to identify the underlying cause of stent failure. Correct the identified problem with balloon optimization, post-dilatation or in edge dissection. Sometimes we use smaller stents to the distal end and future intervention when indicated. So in summary, access lesion and vessel anatomy including lesion morphology, vessel size, calcification, tortuosity, and bifurcation involvement. Select the appropriate guide wire based on the lesion complexity as I have discussed, balancing flexibility, torqueability, trackability, and support. Choose and size the balloon appropriately for effective lesion preparation and controlled dilatation. Select and optimize the stent according to the vessel diameter, lesion length, morphology, and landing zone. Match all the devices to the procedural objective while minimizing complications and achieving an optimal final PCI result. So, the optimal PCI result we mean less than 10% residual stenosis, TIMI-3 flow, no edge dissection, optimal dilatation of the stent. At least if we cannot do IVAS or OCT, we can verify it by stent boost. Thank you.
Any questions?
Okay, we'll proceed to the next.
Any question?
End of the session, we'll have some discussion. You can proceed.
If there is none, I shall understand you have understood all or you have not understood nothing. Okay. Thank you.
Thank you very much, sir, for taking us through this wonderful session. I request Dr. P.L.N. Kapardi to please felicitate Dr. Ganguly for this wonderful session. Thank you very much, sir. Center. After this, next session is IVUS versus OCT, which one to prefer and when. For this, I would like to request call upon stage Dr. Manjappa M. Can I have introduction PPT of Dr. Manjappa? Yeah. So Dr. Manjappa, he is a professor department of cardiology, JSS Medical College Hospital and JSS HAR Mysuru. He has 25 years of experience and special interest including interventional cardiology, heart failure, coronary artery disease and cardiac device therapy. Principal investigator and co-investigator in several national and international cardiovascular research projects. Author of 50+ scientific publications in reputed national and international journals. a recipient of Best Complex Case Award at the Cleveland Clinic Advanced Certificate course in Cardiology, a regular faculty and speaker at major cardiology conferences including ESC, EuroPCR, Asia PCR, and TCT India, and recognized for his contribution to cardiovascular research, interventional cardiology, medical education, and advancement of evidence-based cardiac care. Yes, sir, over to you.
Yeah, thank you, Dr. Pundalik. At the outset, I would like to thank the organizer for giving this opportunity. I think many of my previous speakers have already alluded upon in their, during their presentation about OCT and IVUS and their importance. So now, my job for another 15 minutes or so is to make you understand where are you going to use OCT and IVUS. I mean, what is the current role of these two imaging modalities, especially in current day complex, PCI scenario. So my topic is OCT versus IVUS, which one to prefer, and if at all you are preferring, when you are going to prefer which one. I have nothing to disclose. So some of the questions that I would like you to ponder over for another 20 minutes or so. Does routine IVUS intravascular imaging guided PCI improve hard clinical outcomes? Think about this. And is the evidence for IVUS or OCT equally strong? That is another point that I would like you people to think over it. And in patients with ambiguous left main and bifurcation lesion, which one would you like to choose? And the fourth point would be what intravascular imaging finding, that is minimum stent area, edge dissection, tissue protrusion, maloposition, etc. Among them, which one strongly predicts stent failure whenever you miss them? So background for this particular talk is why we look beyond angiogram. We all know that angiogram is a two-dimensional luminogram. It picks up a lot of things and it also misses several things. What does it pick up? It picks up lumen, chill out, approximate lesion severity, vessel anatomy, flow, bifurcation anatomy, no doubt with that. But what do we miss? We often miss, plaque burden, positive and negative remodeling, calcium distribution, thrombus, reference vessel size, landing zones, stent under expansion, maloposition, edge dissection, geographic miss. These are the facts which actually, paved the way for imaging modalities. Nearly 50% of the angiographically normal segments that you see in your day-to-day practice will have some kind of, plaque or intravascular, some kind of abnormality on intravascular imaging. If you use intravascular imaging during your PCI, nearly 20 to 25% MACE reduction will be there. That is fantastic. And now angiography tells you where is the problem, but imaging tells you why that problem is there and have you rectified it after attending to it. That is the beauty of these things. And now, again with the background, when should you think about intracoronary imaging? So particularly useful, especially when you are dealing with critical lesions such as left main disease, long lesions, bifurcation lesions, chronic total occlusions, which is also a nightmare often for youngsters, and AV calcium, small vessel and diffuse disease, osteal lesions, ambiguous angiographic stenosis, stent failure, in-stent restenosis, stent thrombosis, ACS with uncertain culprit lesion, and complex PCI. These are some of the important indications where do you use imaging. According to ESC 2024 recommendation, chronic coronary syndrome guidelines, it emphasizes that use of imaging guided PCI significantly brings down MACE and target lesion revascularization. Now coming to what are the major intravascular imaging modalities which are currently available. We have IVUS, we have OCT. Both of these you have heard of, and let us look into these things, in little detail. Angioscopy is there, and NIRS is also there, which of course I am not going to talk today. So intravascular ultrasound, how does it work? Basically, if you all learned during your undergraduation as well as during your early days of DM, that ultrasound probe, the Doppler effect and other things. Basically, this intravascular ultrasound is nothing but based on ultrasound principle. A miniaturized transducer on the catheter tip emits high frequency sounds at 40 to 60 megahertz and reconstitute the vessel wall from their echoes, the same physics as that of ultrasound probe. Now, what are the advantages of this particular modality? One is deep tissue penetration. Whenever you are thinking about IVUS, you remember that you are seeing the whole vessel. All three, intima, media, and adventitia can be visualized. This is one such thing which has got such a beautiful penetration that will give you beautiful, picture of your vessel. But there are some caveats to that I am going to mention later. Does not require any blood clearance. For example, if you want to do an OCT, you have to clear the blood so that, the infrared, light cannot penetrate through the blood. You have to clear the blood. You use either, a non-osmolar contrast agent or dextran, and then take the imaging. So, and no iodinated contrast media is required for additional image acquisition in case of IVUS, which is true for OCT. And lower axial resolution, this is the problem. So axial resolution 100 to 150, whereas for OCT is around 10 to 15 micron. So that means the lesions which are less than 100 microns, you are not going to visualize on IVUS. This is the problem. So what three things I want you to remember? One is axial resolution 100 to 150 microns. That is, it means it is low. Penetration depth is beautiful, good, very good, 5 to 10 millimeter. Vessel layers visualized full. These are the advantages with IVUS. Because of these characteristics, what are you going to estimate, assess? External elastic lamina, plaque burden, vessel size, remodeling, to an extent calcium and also stent expansion can be easily delineated using IVUS. Now, intravascular ultrasound, equipment and principle, I told you it is based on the ultrasound principle, and there are two basic, mechanical, rotational and solid state based imaging modalities are available. One is, for example, your OptiCross IVUS catheter, where, it is marketed by Boston Scientific, consists of a single transducer element located at the tip of the flexible drive cable, which is run by an external motor. On the other hand, you have got a phased array or a solid state catheter, which has got, 64 transducer elements are mounted circumferentially over the catheter tip, and here the transducer elements are sequentially activated so that, the vessel wall is imaged. Now, with the first one, the frequency emitted is around 40 to 60 megahertz, which is also compatible with 5F as well as 6F. With the second one, you are emitting the ultrasound waves at around 20 megahertz. Both are 5F and 6F compatible. So coming to optical coherence tomography, the principle is near infrared light source measures the time delay that light is reflected off the tissue. This is called as low coherence interferometry. So as light travels much faster than ultrasound or sound waves, the resolution will be 10 times more than IVUS, ultrasound. So what are the advantages? Very high resolution, near histologic details when you are doing OCT, and requires a brief contrast. So that means the blood should be cleared off. Low molecular weight dextran or, flush with, low molecular weight, contrast agent to clear off the blood so that it is not going to refract the light waves. This one. And shallow penetration, that is the disadvantage with OCT. Penetration is hardly 1 to 2 millimeter, unlike IVUS, which is around 10 to 12 millimeter. So, and the fast automated pullback, this is, unlike IVUS is mostly manually pulled back. So here in OCT, it is fast automated pullback is available. Now, what are the three important things that I want you to remember? Axial resolution is 10 to 15 micron. That means it is very good. Even the lesion, which is as, big as around 10 micron meter, you can visualize on OCT. And penetration depth is, this is the problem, 1 to 2 millimeter, unlike in IVUS, which is around 10 to 12 millimeter. And surface detail, best for details. So whenever you are thinking about details, you think about OCT and not IVUS. Whenever you are thinking about full vessel, you think about IVUS, not OCT. So excellent visualization of stent struts, maloposition, edge dissection, thrombus, plaque morphology, wire position. These things can be ascertained by OCT. Now, optical coherence tomography, OCT is near infrared light to produce the high resolution cross-sectional images. The very high frequency of the light provides around 10 to 15 millimeters. As I told you, this is the resolution. I'm not going into the physical or technical details of these devices, which is not necessary for us. Now, let us understand what is the head-to-head technical comparison. If you, tabulate them between two, so axial resolution is better with OCT, I mentioned earlier, 10 to 15 micron. Penetration depth better with IVUS. Blood clearance is required for OCT, but not for IVUS. Contrast load will be more with OCT, but not for IVUS. full vessel wall is visualized on IVUS, but not on OCT. Calcium assessment can be complete if the calcium thickness is low with OCT. However, if the calcium thickness is too much, maybe IVUS will also help you to an extent, and best for large vessels, because in large vessels you will not be able to clear the complete blood, so OCT may not be good for large vessels such as left main vessels, where IVUS plays a pivotal role. And pullback acquisition speed is more with OCT because it is automated pullback, whereas IVUS it is manual pullback. What are the other advantages and disadvantages? Other advantages and disadvantages are completely based on whatever the facts, physical facts that I mentioned earlier, based on that one. Apart from that, with the data available, advantages with IVUS is extensive clinical experience, more than 3 decades of experience. Pre-intervention imaging is possible with IVUS because you don't have to dilate the blood vessels, and penetration to the adventitia allows, proper sizing, and then extensive research regarding the impact of IVUS guidance over the angiographically mediated, PCI, and better guidance for CTO techniques, which is not possible with OCT. Disadvantages, I told you earlier, images can be difficult to interpret, tissue characterization is limited unlike OCT, and thrombus detection and other, edge dissection, etc., will be difficult with IVUS rather than OCT. Coming to advantages of OCT, so 10 times higher resolution. This is the single most factor, and because of this high resolution, you have got better tissue characterization, better suited for thrombus detection, better for edge dissection, etc., and images are very, very clear. And OCT predicts restenosis and stent thrombosis are very well established even now. Of course, the data for IVUS is much more compared to OCT because the OCT is hardly 1 to 1.5 decade old. And disadvantages, again, it is purely because of the physics, lower penetration, etc. So additional contrast is required. That is another problem. Flushing is necessary, to visualize the blood vessel, and limited penetration on OCT. So these are some of the disadvantages that we have already mentioned. Now coming to the plaque characterization, who sees what best, whether it is IVUS or OCT. IVUS excels at total plaque burden, positive negative remodeling, external elastic lamina, that will give you appropriate stent size or vessel size also. Deep calcium and calcium arc behind the dense shadowing, which is also very, very important factor, because if the calcium thickness is too much, your OCT may not be able to pick up. And left main and large vessel plaque acquisition is fantastic with OCT. IVUS. And coming to OCT, which excels in fibrous cap thickness, identifying thin cap fibroathyroma, macrophage accumulation and microvascular, macrovessels within the plaque, discriminating plaque rupture versus erosion versus calcified nodule, superficial calcium thickness and fracture conformation, layered lipid-rich plaque, and red versus white thrombus. All these things can be very well established or very well delineated by using OCT. Now coming to lipidic and calcified plaque and OCT IVUS appearance, because whatever I have mentioned from the last couple of slides, you are now aware that lipidic plaque can be better visualized by OCT rather than IVUS. And similarly, calcified plaque, if it is thin, it can be best visualized by your infrared light, that is OCT, because infrared light penetrates through the calcium, unlike your ultrasound waves. So where OCT scores over. If the calcium thickness is too much, then your OCT may not be helpful because it does not go beyond certain penetration. Then probably your IVUS will also play a role. Now coming to lipidic and calcified plaque by OCT and IVUS, this imaging, if you look at the first image, the lipidic plaque, the OCT will give you clearer this one, whereas on the right side, you have got IVUS imaging, which may be often difficult to predict because there is, what you call, sound wave lucency. That means, there is a black arc which is not going to tell you anything about what is lying behind. And for this one also, see, for example, the second one also, that calcium, because there is a thick, dense calcium, the IVUS is, giving a acoustic shadow, whereas your OCT can give you full thickness calcium nodule, which can be easily detected over there. So coming to lumen measurement, OCT and IVUS both are helpful, but IVUS gives you a little bigger, vessel size, whereas the tendency of OCT is to give you a smaller lumen area, because in the IVUS you are going to measure the lumen to lumen this one, whereas in the IVUS, sorry, OCT, in the IVUS you are going to measure from external elastic lamina to external elastic lamina. So that means IVUS is going to obviously give you a little bigger vessel size compared to OCT. But however, in a given patient, do not combine both the modalities. You do IVUS, OCT run, and don't, escalate, the stent or vessel size, lumen size to IVUS this one, because though each are determined by different algorithms, you have to use the same algorithm for the estimation of vessel size or lumen size in a given individual whenever you are using either OCT or IVUS. Now coming to differences in lumen and stent measurements between OCT and IVUS, so that I told you earlier, OCT underestimates the vessel size, IVUS overestimates the vessel size. But however, so especially in a pre-stented, this one, IVUS may be better. In a post-stented vessel, maybe, your OCT will be better. So now coming to stent visualization and measurement. So this is very, very important. When it comes to strut visualization, malposition detection, neo-intimal or tissue coverage, the gold standard is OCT because it delineates surface very well. Whereas IVUS, struts blur together, there is a blooming, artifact, under detects small and focal malposition, cannot reliably resolve thin coverage. And so minimum stent area, which is one of the most important predictors of repeat revascularization and target visual revascularization. So reads smaller in case of OCT, reads larger in case of IVUS, I told you earlier. And typical DES minimum stent area cutoff is around 4.5 to 5 with OCT, whereas 5.5 to 6 with IVUS. Now coming to stent sizing and optimization. So for reference lumen, IVUS may be better. So OCT will give you precise lumen measurement. I mentioned earlier. When it comes to expansion, both can be used. Once the stent is expanded, your IVUS as well as OCT can both give you appropriate lumen size. But in an under or understented area, IVUS will be better. And apposition and edges, detecting malapposition will be better with OCT, which is gold standard because the resolution is better. Stent sizing by IVUS, I think representative case from this, IVUS guided stenting, this I have already mentioned, I can skip this slide. Stent sizing by OCT, this also I have mentioned, I think we can skip this slide also. Stent edge dissection, malapposition, tissue protrusion, all of them can be better delineated, better predicted by OCT rather than IVUS. And at the same time, stent fracture and neoatherosclerosis, again both OCT and IVUS, both can be much more valuable. However, OCT score, IVUS scores over because beyond certain level, if the intima is too thick, your OCT may not be able to penetrate. Now coming to IVUS and OCT detected morphological parameters, I just want to quickly run through this one. Among the many clinical trials, one of the most important factors which is going to establish, which is going to predict whether the patient is going to have repeat target visual revascularization is minimum stent area. This is first 4 trials have documented minimal stent area. Apart from that, the only other component is edge disease or edge dissection. So there are later trials, for example, et al., MGH, OCT, clip opic, etc. So again, minimum stent area, along with the tissue protrusion, large tissue protrusion, if it is unattended, or for example, edge dissection or edge disease can also this one. But overall, it is minimum stent area and edge dissection and edge disease which is going to predict. So now, when to prefer IVUS? Renal impairment, so left main and ostial lesions, large caliber vessels, heavily calcified vessels, diffuse disease and vessel sizing is required, CTO poor or distal flow if you want to know, then you prefer IVUS. On the other hand, if you are preferring to evaluate stent thrombosis, restenosis workup, post-stent optimization, MINOCA, that is myocardial infarction in non-obstructive coronary arteries, and plaque erosion, rupture, thrombus, culprit lesion, superficial calcium assessment, small medium vessels, for all these things you use OCT. Now, IVUS versus OCT guidelines, OCT guided PCI improves outcomes versus angio guided PCI. There is absolutely no doubt with that. IVUS guided PCI improves versus, routine PCI, angio guided PCI, absolutely no doubt with that. OCT versus IVUS, whether OCT is better than IVUS? No. As of now, OCT is non-inferior to IVUS. Maybe in certain scenario, it may be superior based on whatever the factors that I mentioned in my earlier slides that you are all aware of. So for example, this one publication from Circulation, cardiovascular intervention, optical coherence tomography versus intravascular ultrasound, what it told was it is non-inferior to IVAS. Now coming to another original article, optical coherence intravascular ultrasound guided percutaneous coronary intervention, Octavius randomized clinical trials, this also suggested that OCT guided PCI was non-inferior to IVAS. As of now, OCT is not superior to IVAS, it is non-inferior to IVAS. IVAS versus OCT real-time update network meta-analysis also suggested the same thing. This has got multiple, more than 20 trials, among them OCT versus angio, OCT versus IVAS, IVAS versus angio. All of them have suggested that OCT and IVAS are both are valuable tools, but OCT may be better in some patients, but IVAS is also better in certain other patients. So conclusions, again, compared to OCT, intravascular imaging guided PCI, OCT versus IVAS reduces TLF, that is target lesion failure by 31%. Again, 52% stent thrombosis, MI 18%, all-cause death by 25% is reduced. Outcomes were similar to both OCT as well as IVAS-guided PCI. So what are the evidence shows, in summary, these are latest trials, Ultimate and IVAS XPL trial, they have suggested that definitely that, IVAS-guided PCI is better than is angio-guided PCI, and Lumion 4 and Octavius trial have suggested that OCT-guided PCI is better than angiogram-guided PCI. Contemporary clinical recommendation as of now, remember, most of the guidelines suggest 2A recommendation for both IVAS as well as OCT. Maybe, level of recommendation is around B. So now coming to, image guiding modality choice according to specific clinical lesion I don't want to go into the details of these things. I have already covered, in my earlier slides, and a practical decision framework at the end to summarize my talk. In renal function impaired, if the renal function impaired, or is this an ostial or left main lesion, go for IVAS. Is this a workup for stent thrombosis, restenosis, suspected plaque erosion, rupture, or soft plaque, go for OCT. Is meticulous strut level, apposition, edge dissection, etc. is a priority, go for OCT. Routine PCI guidance with adequate renal function and vessel size, you can go for either OCT or IVAS. There is not much of difference. Now, friends, take-home message would be both beat angiogram alone, absolutely no doubt. IVAS, think depth and flow independence. You are not going to use any more additional contrast. You can do wonderful job with IVAS in certain scenario, but in certain scenario, OCT, when the resolution is more important, think about OCT. The tools are complementary rather than competing with one another. I think let's revisit our questions earlier. Does routine IVI guided PCI improve odd clinical outcomes? 100%, absolutely. Is the evidence for IVAS and OCT equally strong? Yes, but IVAS carries more data. In patients with ambiguous left main and bifurcation lesion, which one would you choose? It is definitely IVAS. With image-guided findings, MSCI, edge dissection, tissue protrusion, malapposition, which is the best predictor? It is MSCI and edge disease. I think that concludes my talk. Thank you very much. Yeah, if there are any questions, I will be happy to answer you.
Thank you, sir, for an emphatic talk and clarifying a lot of things. And many of you could have doubts on IVAS versus OCT, which one to use. I think he has clarified most of it. Other important decision-making factor is the clinical situation in the presentation of the patient also. The patient is very sick, LV dysfunction, hemodynamically unstable. Don't make him more unstable with OCT. Probably you use imaging with IVAS there. If the patient is stable, then probably long, thin vessels, calcific disease. Those are things probably you prefer OCT. Sir has elegantly covered most of the things. Any doubts or questions? Many of you must have been exposed to IVAS. How many sitting here are already in the cath labs where the IVAS or OCTs are there already? Can you raise your hands? It's very good actually. Very heartening to note that most of the labs now have. Even the NIC data shows more than half of the labs we have it. But only thing is we need to use it and act accordingly according to what it shows. So that's how the decisions matter. I think, thank you, sir, for elegant coverage. I think if there are any questions on this further, please ask.
Hello.
So can we use saline plus instead of contrast plus for OCT? Like in our center we use saline plus instead of contrast plus for the OCT.
Generally, what we use is low molecular weight, what is hydrogenated
Dextran.
contrast media or dextran. Okay, so saline, I don't know. Sir should be able to tell.
No, actually, saline contrast is just coming up, I would say.
That
But
should
the
be enough.
latest Ultron 2 type, Ultron 3 has a modality to image with saline itself. Saline is okay to do for right coronary artery imaging where there are no branches. But the left coronary artery where the large amount of saline is required, there are some challenges. But if you want to do it, you can do with saline also. But I feel there's no prestige in doing OCT only with saline. Suppose patient is too sick, CKD, they can't tolerate contrast, do IVUS. So if you don't have, that is a different modality. But IVUS saline guided OCT is also coming up. For right coronary artery is almost established. For left one, still there are some challenges. And the imaging post-stent is slightly, could be better again with the contrast, like clarity is better. May not be same with saline, but you can try if you don't have it. The Ultron 3 has a separate settings for saline itself.
I'm sorry, lot of echo here. You know, we cannot
Good
hear
evening,
your
sir.
questions actually.
Yeah.
Good evening, sir.
Yeah.
Sometime during on angiography, we get diffusely diseased vessel. So when we perform OCT in that vessel, we cannot find the healthy reference segment. So in that case, how will we decide the stent size?
Decision of sizing of stent is, as you want to answer? Sizing of stent, when you are doing with IVUS versus OCT, how you decide?
If the vessel is diffusely diseased and we are not able to find the healthy reference
I
segment.
understand. I got your point. You know, see, that's why I mentioned if the vessel, the lesion is very diffusely long segment lesion, very diffuse disease, it is IVUS which is going to give you a better, you know, stent size determination rather than OCT. And I also mentioned in an unstented area, you are going to only measure the lumen to lumen area. So your OCT may not be a good guide to determine the stent size because beyond that it is not going to penetrate. So then it is IVUS, it's better. So that's why if it's a diffuse disease, long segment disease where you don't have, you know, proper, you know, landing area for stent placement and other things, then probably, you know, IVUS may be better this one. So otherwise, you know, you have to just go by your routine, you know, quantitative angiograph or your by experience, you have to stent size it.
Generally, if you see IVUS estimation of sizes slightly come bigger because we select from EL to EL, whereas OCT we select from intima to intima, sometimes EL may not be seen. That's why it's that sizing by general OCT is slightly less compared to IVUS. But again, don't be very aggressive with the sizing, with saying the IVUS, because sometimes you end up with dissections and problems too. So to balance it out as a broad guideline, what we make is what is shown by IVUS, probably you can take a quarter size less. What is shown by OCT, you can take a quarter size more in the diameters, I'm saying. Length always, I think OCT gives millimeter to millimeter precision. Now the competition is made IVUS also to improve. Now you have similar longitudinal reconstruction with IVUS also to get into millimeter by millimeter precision in length. The lengths are perfect. If you have angio-co-registration, all the more easy. You can point to 2 points and take exactly the length. Diameters, keep what I should told in mind in getting the selection size for diameter of stents. But always err towards taking a quarter size less, because later generation stents are always compliant. You can always expand them if it is looking less. But if you put a bigger size stent, you end up with rupture. That's a problem for youngsters. But by and large, sizing of the stents is one which has improved significantly with the usage of imaging compared to angiogram alone. One other thing which is greatly, actually if you keep thinking after we use it, understands is, angiographically it looks the same vessel. But once you do post-dilatation, if you understand the areas again, the round area of MSA minimal stent area improves significantly. Means angiographically you may not find the difference, but circular area wise again you find lot of improvement with post-dilatations. That's how the minimal stent, sir has projected that also. Minimal stent area, what you get afterwards matters a lot. So if it is less, please work on it. You do post-dilatations, improve the minimal stent area. then the patients will have good long-term outcome. If you see two angiograms side by side, it may not be different. But if you do imaging-wise, the areas improve significantly after post-dilatations. That's how we came to know. Other thing which is mainly we learn anatomy better is by doing imaging versus angiogram is sometimes in angiogram, sometimes in one view looks more stenosis, other views look less stenosis. That's where once you do imaging, you know that the lumens will be oval shaped there. So in the direction in which it is a long segment is seen, it looks less. The short segment is seen, it looks very narrow. But once you do imaging, your idea of interpretation of angiogram also improves. So you can predict exactly what will the shape of the lumen inside after once you see the angiogram followed by imaging. So some of the lot of advantages of interpretation of angiograms also improved a lot after imaging. I think if somebody has to ask you which are the definite, sir mentioned class 2A, now I think it's become a class 1 indication. After the latest guidelines, after the modification, imaging has become class 1 indication because we are waiting for that class 1 indication. It has become now class 1 indication, and especially the top 3, if somebody has to identify places for definite imaging where it's almost reached a stage where you can't do PCI in those settings without imaging. Can anybody volunteer to tell what are they? Somebody from the places? Without imaging, you're not supposed to do these lesions. Anything like that? Most of the 80%, 90% are done without imaging, especially in tier 2, tier 3 cities. Young cardiologists are very dynamic, do everything very correctly. But suppose if you do not have imaging, you're not supposed to touch these lesions. Anything? Somebody who can volunteer, what are they?
Left main and bifurcation.
Yeah, left main is correct. Left main, especially left main bifurcation, because angiogram wise, I said it looks like a small 3 mm diameter, but if we do imaging, it could be 4.55. So we've seen practically like that. So it is mandatory because otherwise you end up putting a smaller stent where the stents around you have a lot of free space and stents thrombose or patients come back with restenosis. This particularly happens. So please don't attempt doing intervention of main without imaging. That's mandatory. Because many of the times we practically think angiography showed good result and patient will come back. And the bifurcation of left main, especially again further very important because LCX osteal disease there or not is the main thing by which you decide what type of technique you follow with left main stenting. Single stent or technique or two stent technique will decide by actually seeing the imaging. And other thing is whether you have to end the stent in the shaft or come up to the ostium. All such decisions can happen only after the imaging of the left main. So left main intervention, please be mindful. Please don't attempt to do it unless it is an emergency. That's a different scenario. Patient is presented with acute MI shock, where it's to life-saving thing, it's different. But elective PCIs of left main, always you prefer to do with imaging. And sometimes diagnostic dilemmas also, especially when you're doing radials, that goes a long way. Again, osteal stenosis, it appears there or not because of streaming. Again, there's nothing like doing IVUS imaging there. And if the area comes more than how much? The guidelines say area is of more than 5.9. Generally, doesn't need any warrant any intervention. If it is borderline, again, you might take the help of FFR to distinguish, decide further. But by and large, always helps in diagnosis of decision making for left main. 1, imaging. Now, D criteria. The definite indication is left main. 1. 2, second one, something you said. What is the other major Achilles heel for us in interventional cardiology now to tackle, where we are stuck still? Stents have revolutionized, but after you put stent, you had some trouble. What is it? ISRs. If a patient has instant restenosis or ISR, again, it's mandatory for us to do imaging because that's where you know what is the exact cause of stent failure. Suppose stent is underexpanded, area is very less the first time itself, just to post-dilate aggressively with a high pressure balloon, and probably if you need to do a deb, that's fair enough. That's the end of story. You need not do a second stent inside because unless it is mandatory, you're trying to avoid a second stent in the first stent. Okay? Or else, if you have a heavy neoatheroma inside, atherosclerosis in the stent, that's where I think you again dilate, cutting balloon you use. Again, we might use a second stent within the first stent. That is where the studies show that a lot of atheroma burden is remaining within the stent. You are supposed to use a second stent of a different make if possible. Previously, paclitaxel and the limus we used to exchange. Now, most of it are same, so at least different make you can use it. But that's another decision-making factor to tackle ISR for the imaging. And there's a lot of calcium, other things are there where stents didn't expand, and where you use depth, there are other indications are coming up with ISR with the, again, help of imaging. Second definite role is ISR. Anything else you would want to say? Third?
Good evening, sir.
Sir,
Sir, I would like to know your experience of IVAS versus OCT in a single case, that both IVAS and OCT, whether you have used in a single case or for pre-OCT, pre-PCA IVAS and post-PCA.
I'm sorry, doctor, I'm not able to hear anything.
He's asking,
lot of echo.
you can take it, otherwise I will answer you.
Yeah, yeah.
He's asking.
I'm not able to hear.
Yeah,
because
I know, I'm SVG interventions, what is your modality of imaging choice, he says?
See, in SVG, I mean, my modality of choice would be OCT in SVG intervention, okay? Because now the surface anatomy and other things, the details are more important than the depth of penetration and other things, You don't find so much of calcium and other things in SVG. However, if sir differs anything, and maybe you can contribute, sir.
Just a clarification, sir. I'm asking whether you have used or IVAS pre-PCA and after PCA, OCT or IVAS. In a single case, I am asking, sir.
Actually, that's a good one. Huh? He's telling he always feels likes to use IVAS pre-PCI and OCT post-PCI.
In a single case.
Okay. I think you are a very rich cardiologist as well as your patients are.
No, we wish actually. Really, what he says is correct. I also feel sometimes like that. Because pre-PCI, you could get better understanding of the whole burden of atheroma, and then probably assess better area before. But post again, sometimes the stent anatomy, the three-dimensional structure, bifurcation, all that is perfectly very well seen post OCT. If you are rich, you want to use both, you can use it.
No problem. Yeah, I also agree. Pre-procedure, IVAS may be giving you a lot of information. Post-procedure, definitely it will save you as well as the patient if you use OCT.
Yeah, that's what I also, sir is also telling the same. We agree with you. We wish we are too rich. Our patients are rich to use both. But at least you have to always balance our scenario and try to use what is best. But if you can use both, there's nothing like it.
And one more thing, sir.
Yeah, that day is likely to come where one catheter has incorporation of both IVAS and OCT. So that is one of the companies already launched it. It is just coming to our country also. But it will be very expensive unnecessarily, even if it is there. I don't want that type of thing. What users want is, we want more trackable catheters, more easy catheters where it has to go to the lesion. Now the problem in imaging most of the time is, where it is needed most, the catheters doesn't go there. That is a challenge. We are not bothered whether it is IVAS OCT because of tight nature, calcium there, it's very difficult to take the catheter there. That's why some of the tips and tricks of imaging, you would like to tell them for something?
Yeah. Yeah, definitely. That is very, very important aspect. See, everywhere you should not get into that rage kind of behavior. See, for example, one time, you have done wonderful job. There are no complications. There is a proximal lesion, a borderline lesion, proximal calcification. You are unlikely to pass the catheter. Leave it alone. If the patient, is doing stable and your angiographical result is good and other things. In non-left main and non-bifurcation lesions, okay, you don't have to go for this. Otherwise, what will happen? You would have done wonderful job. Approximately around 20%, 30% lesion is there. In the quest to push the catheter, you dissect the proximal segment and then end up with a lot of other complications. These are things, these things, you, over a period of time, you learn, when to use, when to you aggressively proceed further. Just because you have imaging, just because you have to complete the procedure with only imaging guidance, don't do that. So only when it is required, generally, so it is always ideal. It is the best case scenario if you have imaging to use it. However, not every lesion will be requiring, the hard pushing of hardwares and catheters and other things, ending up with complications. That's my take on that.
That is good. What sir said is, if there's a problem post-imaging, if you can't take it, don't produce new complications while pushing the catheters, that's what. But before the catheters are not going, you can use a body wire technique, you can use a guideliner, you can predilate the lesion and take the catheters there. So most of the times you'll be able to do it. But still, if it's a very challenging, then so probably you have to accept dilating it with a bigger balloon, then take the image. What you feel is the real seeing the calcific nature or eccentric ulceration, all that you may miss, but you have no choice sometimes if it's not going. So, but by and large, at least a 2 mm minimal balloon dilatation helps. One more problem of taking imaging catheter without pre-dilatation is you won't realize it. Patients will become ischemic. The catheter blocks the tight lesion. That you should keep that in also in mind. Because OCT you may not get picture at all, but I was without realizing when you put it, you're coolly watching and wasting time, patients' STDs changes and hemodynamics fall. You need to keep that in mind. So always pre-dilatation little will help to avoid such complications also. And air embolism is a big problem with imaging. Please be mindful of it. Prepare the catheter well outside. Your assistant or sister, another junior cardiologist should be very carefully avoiding injection of air in it, because once you inject air, then patient will develop a lot of trouble during a catheter in imaging during the, I think complication sessions will cover that too. I think if there's any further questions on this?
One more thing, sir.
I'm the only speaker left out. I didn't speak, man. The first talk, at least allow me some time to speak. Otherwise, it will be 7:15. Next speaker will come. He has to go. He will speak.
Thank you, sir.
Yeah. Anything else? Okay, I will take, I think 7:15 is the last time where we need to move to next session. So I will cover my talk, which was supposed to be first. And I'll promise you I'll finish by 7:15 by the next speaker comes.
Okay,
you want
sir.
to felicitate, sir? He has to leave, I think. Yeah? Deepak?
Thank you very much.
Now it's time to felicitation. I request Dr. A.G. Narayan Swami to please come on the stage so that you can felicitate Dr. Manjappa. I request Dr. Srinivas also to please felicitate Dr. Manjappa for this wonderful talk. Thank you, sir, for delivering wonderful talk and interactive session as well. Dr. Srinivas Kumar to please take us through the art of optimal angiogram, technique, views, tips and tricks, and after that continuation of complication prevention and management in cath lab. Yes, sir, over to you.
I think it is one of the most important sessions, I think. Dr. Srinivas Kumar, we are eagerly awaiting your talk.
That is a front we have to face we are organizing, sir, because you have to adjust according to others' requests. Obviously, they have to leave, so I have to say okay. But I wish the format which you set goes in some order, but I can't help it, it got changed. That's why we kept it like imaging, basics of angiogram, then lab toolkit, angioplasty, then we went on to imaging. Like that, we prepared the agenda. But anyway, in your brain, you can reassemble things, and come front to back, you can adjust. I think all of you know what we talk, but sometimes when you show, you think it has really happened to us, and then you went. What is the problem? So much technology, all things is not required. One laptop, one projection would be enough, but actually they won't listen. So many things are projected. How many of you sitting here are in final year DM, DNBs? Okay. How many are second year? Oh, great. I think predominance is of second year, then final years maybe are studying, and then first years won't be allowed to go. That's what I remember my 3 decades old training in SGPJ. That was like that also. But nowadays, intelligent kids are very fast and very intelligent. And but thing is, type of attitude towards cases, patients is slightly changing. All of you are very sharp, intelligent, but you will do things only according to your choice. Just because your boss said, professor said, you won't stick to thing, and many of the independence type of things are coming up, but younger generation is totally different, very intelligent and fast learners, but at the same time do things as per their choice. So this also doesn't want me to
So,
deliver.
Dr. Srinivas, still they are getting ready. Can
Sir.
you tell us what are the basic things which we require in the cath lab for an emergency?
Sure.
For an emergency, what all we require to keep?
Hello, Rishi. That's what I think a cath lab toolkit that is prepared to cover those things. He has covered it, but you close it and open it again. You want me to put my laptop? Basically, sir, as you were saying, catheters, guide wires, and balloons, all that is fine. But for the sake of youngsters, I would like to mention, all that emergency toolkit is fine, what is projected. But I take this opportunity to guide the youngsters to things which are to be kept absolutely in lab, at least in my opinion. Rishi could have someone, each of us could have some favorites. But as a broad guideline, what I would like to mention is, the catheters, the regular OptiTarc wire catheters has become universal. There's not much of competition also. The diagnostic catheters, JL, JR, that is again there. Pigtail usage is becoming less. But most important, coming to angioplasties, is basically when you're going through calcified lesions, tortuous lesions, and what type of difficult to track balloons, which one is your favorite? Many things people would ask like that. So basically, whenever you find a tortuous calcific lesions, and either in the periphery or inside. In the peripheral, again, sometimes you are challenged. I have seen thermo wires being available is very important. Some regular J wires may not go. Thermo wire usage is increasing in tortuosities and peripherally taking inside. In the PGCA wires, if you have to see, regular workhorse wire for us is a run-through wire. For many of them could be BMW wire or whatever All-Star wire, whatever is the wire of your choice. But I feel run-through wire is a reasonably good wire which has a balance of everything. But again, word of caution, all of you should have a in-shelf whisper wire or a Fielder XT type of wire, because it's always a savior. When there's a tortuosities, when the regular wire, the dark horse wire doesn't go, you need to have the softer wire, otherwise you might fail up. Other thing, the opposite of it is when there's a calcified tortuous lesions where the regular wires are not giving support, having a Grand Slam or Ironman type of wire is again mandatory. So, and then coming to balloons, we are big fans of Termo rail balloon, but each of you could have something. The lowest profile balloon of Termo, 1 mm to 0.5 or 5 mm width is the best. If it doesn't cross, you have to cross-check yourself whether your wire has gone through a false channel or something like that, or sometimes extreme tortuosities, lack of guide support, it may not go. But other types of smaller wire balloons have come, which more strength, but I feel the more best trackable. If that is not working, we generally decide to go for atherectomy, be it be like rotablation or orbital atherectomy. And one more thing we need to keep in your mind is, what is the problem by which the balloon is not tracking? If it is a support problem, changing to better guide support could help. From the regular JLs are actually very outdated in the sense that very less support. That's why most of us have shifted to XB3 type of catheters which have better support. But if you need to, sometimes we might use Amplatzer guides, and that becomes very challenging because Amplatzer guides tends to injure and damage the ostium of the vessels, especially both on the left and right. And how to handle that is again different technique. If time permits, we'll show some of the things, or some of the complications, one of our speakers can show that. So these are some of the things I want to mention. Stents, many of you ask what is your stent of your choice, and to share our thoughts, each of you could have your own experiences, but the stent which is maximum used and tested in our country is Xine's platforms, because it's going on since years. They didn't change a platform, a lot of modifications happened. That's why performance-wise, I feel it is doing good. But if you have fancy of any other particular stent you are comfortable with, you can continue to use it. There's not much of difference. Most of the times, most of them are interchangeable. But when there is a challenge of very tortuosities, calcium, where you worried that Xines may not go, those are the things in which you can prefer onyx stent, which is a little more trackable. But again, it comes with a compromise of radial strength, I feel, is a little less. Optimal strength, optimal thing, everything is for the Xines platform. And when you're placing in the osteal lesions, again, Xine stent has a marker, stent starts with that. Again, that is preferable for youngsters. And then if you're sizing to, one more thing which you need to keep in mind regarding the sizing of stents is, basically nowadays you do crossover stenting, nowadays you do bifurcation stents. So what is the proximally you take a bigger balloon and dilate compared to distal? The expansion limits of the stent is written on the stent. You should keep it in mind. Suppose 2.5 stent, you take a 4 mm balloon and dilate, the anatomy could distort. So 2.5 can maximum expand to 3, 3.5 depending upon the make. You have to see that what is written the maximum expansion diameter of the stent. So otherwise, in today's era, most of the stents are expand well, but you can't damage the endothelium and produce trouble if you are not within the expansion limit. And whatever bigger diameter you may do it, still it will not expand beyond that expansion capacity of the stent. Please keep that in mind. And then if you have a side branch access, the open cell designs are preferred. Generally, we might prefer onyx there compared to other platforms. And the most difficult to track when there's a difficult lesion, calcium, and nothing is going. People say they have tried various other types of stents. I think Biotronics type of stents are sometimes they're going, that's what they feel. But we most of the time succeeded using onyx stents in such platforms. And Rishi, as you there, you want to just educate them. What is your difficult times? What is the best stent which saved you?
I mean, from a delivery point of view, Orsiro from Biotronics is something
that's what I was not getting it. Yeah. That's people say that Orsiro sometimes saves in the difficult times. But again, the radio opacity and sometimes could be challenging. You need to have a good lab to see Orsiro because the radio opacity is slightly less. But in the crossovers, when you are doing again, the Megatron, that type of stent which comes from Boston Scientific, is supposed to be having some advantages in the expansion limits. And then probably when there's a hinge point of crossover at LCX, that's another point where I prefer that. So don't get biased towards any company or any make. You use it according to the anatomy of the patient. That's what is most important. You might have a general routine, the run-of-the-mill stent, anything you may prefer, you may use it. But when this particular subsets where I mentioned, please keep this in mind. And nowadays, so many stents come. I call it stent pharmacology almost like tablets. The stents are also coming. But be comfortable with the type of 1 or 2 stents and then probably use them. And drug-eluting stents are established themselves now. The routine BMS is no longer there, I think. In the SVG grafts again, previous the concepts was the bigger the better, and probably if you dilate it very aggressively, restenosis could happen more. That's why cycle is coming back to use optimal size even there also. These are some of my thoughts I thought I would share before. Now I think this is working. If there are any questions on thought process, I'll just take it. I'll finish this talk and then you can ask. Is it okay? Can I proceed? So why is it important to cover the basics of angiogram is, that is the essence of everything. The lesion, the decision what to do, what not to do, everything becomes on angiogram. But many of the times we see angiograms are done very shabbily and you don't even know exact assessment and patients are written CABG. So it is atrocious to do that. No, you wouldn't even know the anatomy and patients are sent for CABG just because you need not deal with it. Such sort of things do happen. Not that everywhere it happens. Good, bad is there everywhere. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across and trying to get the data. But the problem is we all don't come together. If all the Apollos come together also, you have a 1 lakh plus data procedures of things done. And it becomes, if 4 or 5 important groups in the country come together, KGMC and Apollos and KIMS of fear, then our data becomes more than BICS data. That is our British society, which comes with so much papers, has 3 lakhs data, that's all. So, but the problem and challenges is institutes don't contribute and lot of issues, but suffice to say that together we can always do a great job. This I wish always to project, my alma mater, Usmania, and then probably somebody was asking, this is my alma mater of cardiology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, where you have very fond experiences. What I would like to briefly take you through in the coming 15 minutes is basically tell you the principles of angiogram and what is the importance of each angiogram view, and what is a good and bad angiogram I will try to show, and the stenosis assessments, I think how to do it when there's a difference in different views, I will try to take you. And access, I think, is already covered. I think we will cover that because of sake of time in tomorrow's my talk on TAVI. And then probably these lower things is already covered, and this work-life balance and all things we can have it in discussion. It's very important to say this because you need to keep radiation also in mind. When you don't see radiation, you continuously put your fluoro on, so you don't you expose yourself because you don't see the radiation. You need to limit yourself. And then you see, imagine everything heart in the coronaries itself. So it's a 3-dimensional structure by which you are taking 2-dimensional views and then probably imagining everything. Then visualize the heart inside the coronary angiogram. And generally RAO views separate atria from the ventricle. LO views separate both atria, both ventricles. This is a conceptual thing which you need to understand. That's why in the RAO views, when the LCX comes behind, the AV groups comes behind, in between, the above ones will be atria, below ones will be ventricle. I will take you through some of this. And concept of distance and parallax and importance of 2 orthogonal views, we will take you through some of the things. Basics of good angiography is, if a good angiogram, you need to interpret each vessel millimeter by millimeter, and then you will be able to assess the lesion correctly. And then it is not a snapshot, but a series of images kept side by side. You understand how and the flow of it, how it is happening, also helps us to know the severity of lesion. Sometimes excluding the bar slow flow type of phenomena, the lesion is borderline, but the flow pattern is very slow, critical. That means the lesion could be more important. So seeing the step-by-step things also gives us an idea. So again, sometimes the areas are blank in one of the places, like somewhere there's nothing is coming there. That means one of the artery could be occluded there. So carefully search for it. It will be forming through collaterals like bridging collaterals or OM. Those are the things, some of the things, I'll show you some examples. Then if you see the angiographic views, basically why is that views created? Because each of them, you see a particular portion of the heart, the vessels well, right? So RAO views, LAO views are self-explanatory there, cranial caudals are self-explanatory, but by and large, you remember the cranial views, where it is going there, this is where the X-ray comes. It is coming closer to you. So it's more of radiation to you. So if it is required, you take it. But again, LAO views, again this X-ray emitter comes towards you, the more of radiation. Keep that in mind. So that's how I think RAOs and RAO caudal views, you get less radiation compared to LAO and LAO cranial views. Then many of you have the habits of doing RAOs, LAOs first, whatever each your boss taught us, you do it. So what is the first view which you people do in angiogram? Many of you can say, what is the view which you follow in your institutes, or what is the, how many of you do RAO caudal or AP caudal first? How many of you do LAO cranial first? So I think there are equal raise of hands, but idea is to get a view which does the maximum benefit and the maximum information has to be done first. In the sense that you take only chance to have only one view and the patient suddenly gets into trouble, still you get into the maximum information, number one. Number two, the point of maximum interest should be seen first. In the coronary anatomy, what is the thing which is most important? Left main. So left main is basically a vessel in which you need to see it first. If you have to see, then probably left elevocranial view is the one which shows the left main ostium the best. And then LAD coming anteriorly, LCX going posteriorly, you also see it better in the elevocranial view. That's why universally, in Peter Brandt's article, originally when it was there, elevocranial views are described first. But later on, a lot of modifications happen. Many of the places I see RAO caudals also being done because, again, counter parallel views you have to take. What you say elevocranial is equal to RAO caudal. So that's why the next probably is again taken view is RAO caudal, then cranial and epicranial and epicaudal. So if you have to see all the three views, probably these three would be enough, elevocranial, RAO caudal and epicranial. If you want more information, the only problem with angiogram is not that it is difficult to do an angiogram, but you need to understand by the time the patient is shifted, entire information of the artery, every branch, you need to have it on table. You can't get the patient back and recheck again. It looks so stupid. That's why unless you are clear about each vessel, each part of the vessel, don't take the patient out. And then if you got already information, it's not a synchronon rule that you have to use 8 views, 10 views. Those days are gone. When we were students, more number of views used to be done. Now I change 4 or 5 left side views and only 2 right side views are more than enough by and large. The contrast limitations also have though improved now, but still we don't use that many views unless you get a view. Sometimes you might take an extra view like lateral view where something is not clear, but by and large these are not regularly done. These are some left coronary views. If you have to see the mid and distal LAD, again you might take the help of lateral view, and then the bifurcation view, sometimes depending upon how is the course of the artery, we might change the views. That is important for us to mentally think which portion you have seen. If something is not seen, you again change the views and keep exploring sometimes and do the pictures. I will show you one. I said left elevocranial view, how it is important. You see this. I hope this place. See this elevocranial view. The first view sometimes is only very tight lesion. In the other view, it is totally missed. Sometimes you could develop the catheter damping, otherwise sometimes not. So it's very, very important to see this correctly, and that's how we recommend doing that view first. So if something happens, if you dissect it, suddenly patient lands in trouble. So that is the importance of elevocranial view compared to RAO caudal views. Then if you see, then epicranial view further, you see the mid and distal LAD is seen very well. Again, epicranial view again shows the ostium of the left main well. So if you're doing left main stenting, that is why obviously it becomes a views of choice, elevocranial and epicranial, where you need to see how much stent is projecting into the aortic sinus and appropriately position the stents. This helps in planning your intervention also. So this is elevocaudal, sometimes you may not see it. Don't become too much blind, but it helps you to distinguish the distal extent of it and till what level you're going. See these non-selective angiograms. Sometimes if the catheter is not coaxial to the artery, you don't get good pictures. This and this are taken, you don't know what is the lesion in it, and see this when it's done selectively, how it is seen well. The ambiguous nature of it is totally gone. And then you get into good pictures and clarity is there. So nowadays it's also important to see LV function as well as carotid artery disease presence or not, because it helps in decision making regarding CABG versus stenting. So it is a lot more important than before. Because most of the times you have multivessel disease, LV dysfunction, carotid disease, where surgeons are worried, we have come to the stage where we save patients with procedures. 20% of our referrals come from CABG surgeons where they are not able to do it. So this is another that's about left. Right, basically views, standard elevo views and RAO views. Optional views are elevocranial views. This cartoon here shows the pictures how they come from RAO, elevo, and sometimes the torquing of the catheters. I think I have a picture of that to show that how the optimal proper torquing helps. I've shown it already. The regular selective views improve the clarifications. And when you have to see the distal bifurcation, that's where you take a little more elevocranial projections and see it. In the mid-RCA, again, you might see it better with the RAO view. The story of missing vessels, I heard it, I took it from my teacher, Dr. Goel, is basically when the vessel is 100% blocked, you see an area which is vacant. So that's where we need to see if something is wrong, we need to see and which myocardial territory is not filling, and we have to identify what is the reason for block. It could happen, sometimes you could miss a major OM, things like that. With surgeon, unless you told, you might miss and it may not be grafting. That's important. The handling of the catheter damping is very important. Many of the times I see some doctors don't even check pressures and inject it. That's very wrong way to do it. And if you don't check pressure and inject it during the damped catheter, it could lead to dissection. Please avoid that. Always practice of getting some flow back, and that I will avoid the air also, and then probably try to see why is it damping. If it's going too deep, or it is because of touching and a slight tilt of clockwise, anti-clockwise turns will make the pressure better sometimes. So, but never ever inject too much when the catheter is damping. This is what I'm saying. If it's not coaxial, you won't get it well. Coaxiality is like this. You see it better. So this sort of mild torques, sometimes clockwise, sometimes anti-clockwise, could help you and you to do a better angiogram. Now I'll tell you that how to do correctly. I will show you one example. This is a real world example. I don't want to say from which institute it has come, how not to do an angiogram. See this. So again, many of the times with anxiety, I keep my fellows tell them that injection also is an art. So once you start, you're starting from the ending, you have to see how the contrast has gone. Don't start injecting and by the time your fluoro starts, half of the contrast is already here. That's also not right. Other way is non-selective injection. This is a different thing what I'm talking. So it also tells you how much flowly is coming. Sometimes you might miss out some things. So please avoid it. See this. What is that injection? You injected somewhere, something is filling. See that it sometimes goes to LV, and these are fortunately not in our place, but I've got this. And then after these shots, I'm not exaggerating. This is another shot which is taken. Okay? And patient is sent for surgery. Then surgeon says, what is this? I'm not able to see anything. Please do something. Then probably, if there is a problem, there could be real problem. Please analyze again. Don't again ill-treat your colleagues who's coming from there. There could be real problem. Plan your angiogram well when you're coming across such angios when you're repeating. Probably you should keep a guide catheter available, or you should keep a bigger curve available, or you should plan something what is wrong, because they also must be reasonably experienced person who's doing it. If something like this is happening, there could be some reason. So please plan yourself well. Sometimes the worry is they get the catheter out. Maybe it is damping and some worry could be there, but sometimes it is pulled off very fast also. These are some of the ways in which it should not be done. So when such things are seen, you can't make out anything, and please don't advise patient surgery if you're not able to make out the lesions correctly. Then once a selective thing comes, then finally in this patient is advised CABG, then that's how it's a poorly performed angiogram is the often a source for committed mistakes. Nowadays, many of the times, we can do most of the things can be taken up by percutaneous procedures, and if you interpret the vessels well. Another place where it is very important for interpretation is totally occluded vessels. If there's faint track we can make out, you're successful. The CTO won't be CTO, you can cross it by filter XT type wire. Anatomy-wise, interpretation becomes very important. What are the steps? Identify the anatomy. Just don't write TVD, do 2VD, one vessel disease. You also see where is the block, because anatomy, stenosis distally in the vessel is different connotation compared to the proximal vessels. And how much big is that vessel? What is the myocardial value also becomes very important. Some small distal OM also is considered as TVD, which is hardly any value. The stenosis analysis again becomes very important. That's what I'm saying. So it is TVD, DVD, don't go by that mnemonics, but try to see how much myocardial vessel is at compromise. And that's how we make a final recommendation. And lesion assessment principles, I would briefly talk about a minute about it. So basically, after imaging has come, there's become less important. But this analysis, I think, is standard Grossman's picture. How many of you are aware the diameters and area relations? Previously, I used to get confused. What is diameter? What is area? If you see this, you'll get it, understand it very clearly. The diameter here, it is 2/3, means it is 90%. It is 1/3, it is 50%. Because when the diameter becomes pi r square, that's how it is. So if the lesions are more than 70% in diameter, more than 90%, that is supposed to be severe significant vessels. So the lesion enhancement principles, how to look at it is also, you always see life as a positive thing. When artery is filled up, you see it, and then When it is normal segment versus that filled up segment, if you put how many besides each other, it is becoming one normal segment. If you see it, you will understand it is 50%, 70%. I think each of you could have your own methods, but always you can check, cross-check with QCA, but QCA is again manipulative. Your technician wants to be very nice with you, he can make it very 80%. Otherwise, which frame you are measuring, that's how the QCA decides. But generally, you can take input, but decide on what your gut feeling finally is. So, and why this principal analysis came, I can't explain more because of lack of time, but basically 70%, 90% concepts came because the physiological basis of flow, where suddenly the flow becomes important, even at rest patient starts ischemic, that's how it's important. The prognostic indication again is important, depends upon the proximal left main or left main, LAD becomes prognostically important. That's why it's important for us to see how much risk and syntax score that patient is having. The standard ACC-AHL lesion classification is becoming less and less important because we hardly see any type A lesions coming to us, especially in the periphery where a lot of youngsters do the portions. The type B, C type of lesions, most horrible lesions come to peripheries and central places for referral, but still I think you need to do a good job. So finally in the angiogram, what you need to comment is the patient is going for surgery. Nowadays you don't bother TVD, you write it and just send the patient to surgeon, but it's also important to see what is the distal nature of the vessel, whether graftable or not. Quality of distal vessel becomes very important because many of the times we send patient for CABG, surgeon doesn't find anything, he comes grafting only OM, it's useless. So again, type of stenosis and the type of distal vessel becomes important. LV function and carotid stenosis assessment becomes important for surgery. For angioplasty again, you need to be carefully analyzing the proximal course, anatomy and branching pattern because each of it could have connotations on your planning of stenting. Exact location and type of stenosis and distal vessel, again perfusion is important even here. LV function and background idea of renal function is very important. I think with this I would stop. Syntax score has its own limitations, we can have some discussion on it. Graft angioplasty and other techniques and vascular access I would stop because again Rishi and others have come already and then we will take questions later. Axis side I would cover up in tomorrow's talk and things, and then this per close mechanism also I will show you. But don't be, again, one word I would like to tell about axis is don't be very dogmatic. There's nothing like radialism, femoralism, and if you are comfortable in both is always better. Nowadays I see fellows are not comfortable with femoral punctures, they are very comfortable with radial punctures. But you need to learn both because sometimes it helps. Finally, what is good for the patient we need to practice. Some of the things we'll discuss more about axis, the videos, other things, how to do it, I have it, and we'll discuss more about it if you have time in discussion. I think with this I'll close. Some of the newer catheters, railway catheters, other things were also there, and radiation protection. I think I'll stop here for the sake of time, and if you want to ask any questions in what I've covered, what I thought is okay to cover, I told, but it's endless. We can have lots of discussion on angiogram, how to do it itself, but I tried to restrict it to 15, 16 minutes of time. Thank you. Any doubt on what I spoke or whatever you want? At least from now on, we'll try to make it a little more interactive because there is no rush. All the speakers are staying here, no problem. And any questions or comments? Anybody? Okay, otherwise we'll go to the next session. Deepak, where is he? He wants me to continue the next term. You want to do Rishi first or? Where is he gone? Registration. Registration मेरे क्या करना है?
Can we have introduction slide for Dr. Rishi Sethi? So thank you very much, sir, for a wonderful session. Now let's move to the next part. So for this, Dr. Rishi Sethi is with us. Dr. Rishi Sethi, he is a professor and HOD of cardiology, executive director of SIB, Shine, and Dean Innovations at KGMC, Lucknow. Dr. Rishi Sethi, he is an eminent interventional cardiologist, academic leader, innovator, and researcher with extensive expertise in cardiovascular medicine, intervention, healthcare innovation, and medical education. Currently serving as author of 120 plus scientific publications with 3,000 plus citations. Recipient of multiple national awards, including Professor Devendra Kumar Young Investigator Gold Medal, A.V. Gandhi Award for Excellence in Cardiology, and ACP Distinguished Teacher Award 2023. He is a national leader in cardiology research, innovation, heart failure, preventive cardiology, and interventional cardiology as well. 120 plus peer-reviewed publications in leading journals, including JAMA, Lancet, JAMA Cardiology, European Heart Journal, Indian Heart Journal, and others. Research focus is specifically interventional cardiology, heart failure, preventive cardiology, lipid management, structural heart disease, AI in cardiology, and cardiovascular innovation. So with this, I would like to hand over the mic to Dr. Rishi Sethi. Yes, sir, over to you.
Thank you so much. Thank you so much for the kind introduction, and thank you, Dr. Srinivas, for inviting me here. How many of you are awake? Raise your hands. Oh, you all are awake. Can we have a couple of guys come forward and sit and have a mic, because I want it to be a little bit interactive session. See, the cases we are going to show you in terms of how do we manage embolized devices, always look very easy in retrospect, but mind you, we all struggled for hours in our lab in each of these cases. So if you want to take back something home, it's actually the final frontier of interventional cardiology training. I am not sure if you all are ready for it, but you will get trapped into these situations time and again, and if it happens, it is a very, very, you feel very, very helpless as a young interventional cardiologist. And we have experiences that people in the city, young guys who are doing cases, the devices embolize, the devices break, and then they send the patients to us, and that whole journey, we had a couple of cases just, last month. It's very, very frustrating for the young interventional cardiologist. So I want you to pay attention, but I want you to be a little more interactive, because there are no hard and fast rules or guidelines in which how to do these things. These are basically common sense and philosophy, and trying to understand three-dimensionally what is happening, trying to know your hardwares better. So can we have a couple of more people in front? So, or does everyone has a mic? Does every table has a mic? Yeah, so, a couple of more people can come in front, and maybe it will be nice if we can set up some interactive discussion, because probably I'll be asking what's going wrong, or how would you manage this case. So I remember that one of the leading interventional cardiologists, very senior person, boasted in academic meeting that in one day in his cath lab, he retrieved 6 different devices, and that spoke volume about how good an operator he was. But it also begs the question, what were we doing in our cath labs to embolize 6 devices in one day? So the point is that accidents are avoidable, and many times we realize that it's only our rashness and are not able to understand the anatomy better leads us into these complications. So these are avoidable, and these embolized devices, and let's take the prototype of embolizing stents and embolized and broken balloons as a prototype, because if you know how to handle embolized stents and broken balloons, then everything else can be managed. The common predispositions for stent embolizations are very important. They are underprepared lesion, number 1. So prepare your lesion well before you take your balloon. Remember, many a times as young people, we feel that, we have underprepared the lesion, we will stent it and then we'll post-dilate it. What cannot be pre-dilated also cannot be post-dilated. So everything needs to be done, the lesion preparation needs to be done before you stent, Post-dilatation is for just adequate expansion and to prevent malapposition. Don't try to shortcut your pre-dilatation by thinking that you will post-dilate the stent and achieve the same result, because underprepared lesion are #1 cause of stents getting embolized. The other is calcium. Many a times we underestimate calcium, so if you anticipate severe calcification, do an intravascular imaging, IVUS or OCT. Suppose you don't have it, then the balloon, how easily the balloon is crossing and how easily the balloon is inflating also give you some idea about the amount of calcification. So calcification should be respected, but especially notorious are calcified spurs, because these spurs can hang on, latch on to the side of the metal of the stent and can prevent its forward or backward movement. This is something that you should be remembering. Of course, then there are angulations and tortuosity, notorious being circumflex artery, because it takes a 90 degrees bend and then you have to take a OM. Many a times negotiating the stent, especially long stents in circumflex, can be a problem. So angulation and tortuosity need to be respected from before. Suppose you have a very angulated and tortuous and almost a backward looking ostium of the circumflex, Z shape, no point taking a 48 stent. You can always take 2 small stents, take the use of guide liner and help the delivery of the stent. No point trying to be, a Superman and trying to cross this long stents, non-malleable stents into complex tortuosities. The fourth most common reason is long and difficult to deliver stents. Many stent platforms are not, now we are getting most of the stent platforms which are ultra thin stent platforms, but many a times older stent platforms were thicker in nature, and long stents, especially, as Sir was saying, there is little to choose in terms of efficacy from one stent to another, but it also means that many a times if you have a poorly, developed stent and not a very, very standard company, then these companies probably, their stents probably tend to embolize much more than the FDA approved or the good Indian company approved. So the choice of stent in terms of its length, the thickness of struts, and the company matters in terms of its probability of embolization. And the last one is very important, is that whenever for any reason you are not able to deliver a stent and you are pulling the stent back, the non-coaxial nature of guiding catheter to the ostium and the proximal artery is very, very notorious for stent embolizations. And no matter what these causes are, there are only 2 final pathologies why the stents will embolize. The stents can be stripped from the stent balloon, and it can happen by 2 ways. The stent gets stuck in a lesion, and you are not able to push it back or push it forward or pull it back, and in your effort to pull it back, the stent remains stuck to the calcium spur, but the balloon is pulled out. The second stripping can happen at the time when you are pulling the stent back into the guiding catheter. At that point of time, if your guiding catheter is non-coaxial, if it is angulating, then the edge of the guiding catheter would interfere with the edge of the stent, and the stent can get stripped off the balloon. So these are the 2 places where the stent gets stripped off from its balloon. The second final pattern is the stent is not stripped up, but somehow, because of you have been too rash in manipulating the stent, pulling it back, the proximal stent of the proximal edge of the stent gets distorted and the metal's flared up, and then now you can't take it forward, and when you try to pull it back in the guiding, this flared stent is sometimes not allows stent to come inside the guides, and it can strip. So this is the final pattern. Now come back to the predisposing causes. If you have already thought of the predisposing causes when you are placing a stent, probably you will avoid all of these. So this is the final pattern. Now management strategies, you don't have to remember it. It's all very common sense, and I'll keep on asking you and prompting you to answer these questions as we move forward. There are only 2, at some point of time you will have to innovate when you have to extract these stents out, but at the same point of time there should be some flowcharts also running in your mind so that the decision making is quick and you just, there's not too much hit and try. So 2 things which are very, very important in terms of whenever your stent is embolized or there is a broken balloon out there, is that number one, is the wire still in the stent balloon? Is the wire still secured there, or is the wire out? That's the one thing that's very, very important whenever you are dealing with an embolized device. And the second is, what is the location? Within the coronary artery or outside? And within the coronary artery, is it in the left main? Is it hanging in the left main broken piece, or is it in the proximal artery beyond the left main? In RCA, it doesn't really matter too much. So based upon all these findings, all these things, you strive suppose your wire position is lost and your stent is free floating in the coronary arteries. There's no way, I mean, there is virtually impossible, probably in the last 20 years. There's one case I remember which I was able to thread the wire back through the stent to stent in an embolized stent, but otherwise it just doesn't happen. The wire would go here and there, but it is very difficult that a stent that has been stripped of the metal and lying in the coronary artery, especially if it's a long stent, you can again rewire it end to end. So if the wire has been pulled out, you are left with either snaring the stent out of the system, or taking 2 or 3 wires and entangling the stent in that wire and then pulling the whole thing back, or simply crushing that embolized stent with another stent so that you have 3 layers of metal on one side and 1 layer of metal on the other side. If the wire is intact, then it's a little simple thing, and you have more options in order to handle it. So let's come to scenario number 1, and please see what's going on. You have a totally occluded distal circumflex or second OM, whatever you may call it. You balloon dilated it, and then you tried to cross the stent. But of course, you balloon dilated it only to a 1.5 millimeter balloon. So the balloon preparation of that lesion was not well. So you were anticipating that probably it's a acute MI, you will probably do a small gentle balloon dilatation and the stent will go through. The stent did not. And what did you try to do? You tried to pull the stent back into the guiding catheter. What happened? The guy in black? What happened? Take a mic. I mean, just float a couple of mics around so that we waste less time.
Balloon came back. Hello?
Balloon came back. Where's the metal?
Inside the coronary.
Can you appreciate the metal here? When the balloon is pulled back, you still have a metal here. Now what can you do about it? Speak loudly in the mic, please. Anyone, simple. What can you do about it? The wire position is still there.
We try to reinsert with a smaller balloon
And inflate it there? So what was the second thing one was the wire position. What was the second thing? The position. Is it in the left main or is it in the circumflex? The stent is hanging in the left main. At this point of time, it's very, very difficult to inflate it here, and because the stent size, here you would have chosen like a 2.0 or a 2.25 stent, and you can't do that, you can't inflate it. So you somehow have to push this stent forward so that it comes in the circumflex. You don't need to take it across the lesion itself, just get it in the main artery and deploy it, even if it's a normal artery, deploy it so that you have at least an access to take the second stent down. And that is what we did. We took a small balloon and we tried to push the stent forward, and actually we were ultimately able to push the stent forward from the left main to the circumflex, and then you inflated it by serial balloon dilatations. You see, you have inflated the stent here away from the left main, and you still have access to here. You can take a second stent down after balloon dilatation. And you can complete the procedure. Well, this was scenario number 1. Okay, so we'll move to which table now? That table, can you give the mic to that table, please? Scenario number 2. This is very interesting. Very, very interesting. And every case that you see here, in this particular case, I think it took us not less than 2 to 2.5 hours to get the stent out. And it was a big, big learning that we have to face. This was presented in the PCR, and it was appreciated widely. So again, you see the similar case. There is a OM2 or the distal circumflex, whatever you may call it, is 100% blocked. There's a small, mild sort of a lesion here, which we thought is not important, and we went ahead, balloon dilated, sorry. We balloon dilated this lesion, and then we tried to take the stent in. But the stent will not cross the first lesion because we have underestimated the first lesion. We have not prepared the first lesion. The stent will not cross there. And we tried many things. We tried, more balloon dilatation. There was a calcium spur. And we tried guide liner. We tried buddy wire. But the stent was not able to cross. In that process, we took the stent out 2 or 3 times. But it was fine. Nothing happened. Ultimately, we balloon dilated it. And ultimately, we took the stent crossed. But in the meanwhile, we had taken in and put the same stent back 2 or 3 times. But it was good. There was no flaring, nothing. It was a good stent. And then we tried to inflate the stent. And you see, no matter how much pressure we put on the gun, the stent would not inflate. And you can see it in the magnified film. This is brilliant. Someone has to answer from that table, please. This is the picture that we saw. What's going on? Why we could not inflate the stent? We are just putting the pressure up and up. The stent is not inflating. I mean, mic means you have to on the mic also, yeah? I request, please just throw in a couple of mics so that we waste little time in discussion. It's very frustrating.
Balloon has ruptured.
Huh?
Stent balloon has ruptured.
Stent?
Stent balloon has
Stent balloon has ruptured.
that is why when inflation we can see the OM.
Any evidence that you get the stent balloon has ruptured? It's a very good answer actually. Because you see there's some contrast that is flowing in here. And because of this rupture of the stent balloon, what has happened is the proximal edge of the stent has flared up, but the distal stent does not open up. So now you have a partially expanded stent proximally. The distal stent is still stuck to the balloon and it's ruptured. It's not going to open up. So what are you going to do? You're probably going to strip the balloon again and try to take a second balloon probably and try to open it up. So when we tried to strip the balloon intentionally, the balloon was so well stuck with the stent, the entire assembly came back, and there is a flaring here, and this flaring will not allow the stent to come back inside the guiding catheter. Now you are stuck. Now you can't strip the balloon. Now balloon, stent, and wire are one assembly. You can't strip it. If you had stripped the balloon here, you could have taken a second balloon and inflated it, but that option is gone now. What do?
Take a second guide.
Huh?
Take a second guide, try to snare the system.
Loudly, please.
Take a second guide and snare the system out.
Take a second guide, and what do we do with this stent? Okay. So we thought that there's no way. We'll have to snare the stent somehow because the stent would, so we took it out from the left main and somewhere in the aorta and the subclavian, the brachiocephalic, the stent is lying here. And we took a snare from the femoral and we caught onto this wire, and on the stent wire we pushed the snare sheet. We anchored this wire in the snare and we pushed the snare sheet right up to the stent. So again, you are answering well. Can you snare it now?
Until the stent is into the system, we should not give any pressure.
Please speak loudly. I think I'm hard of hearing now.
Stent completely should be into the snare system. Then only we should start giving the pressure and pull it out.
What is he trying to say? What are you trying to say? Yeah, the point is if you can take the snare up. You see what you did. You take the snare up, but if you snare it in this position, you would snare the stent metal, you will snare the stent balloon, and you will snare the wire. So there's no way you can take it out. You just created this whole loop. There's nothing you can do about it. So what the trick here is, you take the snare up right up to the stent, and then when you are sure that your snare is all across that stent, you intentionally strip the balloon. You strip the balloon. Now it's only the wire left. Now you close this loop as close to it as possible so that there's no chance of your stent getting dislodged now. And when you are secure that your stent is now firmly in place, then you also strip out the wire, so that now it's a free stent and you can take this free stent out. So this is very, very important. Snaring can only be done if it's lying free around. If it's still caught to a balloon and wire, snaring is will not serve any purpose. So this is the trick, but you have to be very, very sure that you have caught the metal before you finally take the wire and the balloon out of the proximal stent. Are you all understanding what we are, or is it? Okay, so now you can take this thing out, and this is what we got outside. And then, of course, you have to come back and complete your procedure. Scenario 3, there was no flaring, but the operator thought that you can pull the entire stent back. This was difficult to deliver stent. It was difficult to take in the guide, but they thought that probably they will take in the radial sheet, but they could not. The stent just got stuck here in the brachial artery, and it would not move forward or not move backward. And all these things, the snares and all that you were talking about, should always be done in large bore arteries. So if you have to snare, it's not possible to snare it in this radial and ulnar combined. It's not possible to snare it here. So what you did is probably, you went again from the femoral side, you caught the wire in the snare, you actually trapped the wire in the balloon from the femoral, and you pulled the whole assembly back into the aorta, and then repeated the same steps that we repeated, to take the stent out. Oh, this is very interesting, and this happened just 1 month back, and so this is very, very interesting case. So this young chap was doing an angioplasty in one of the hospitals in Lucknow, and we got a phone call in our cath lab that the stent balloon has broken, and it's lying across the left main, and there's no way he can take it out. And we said, okay, send it over. Little did we realize that he sent the patient with the guiding, everything. It was through femoral. The patient came femoral. The guide was intact. The stent balloon was, everything was intact. The wire was in place. And we got the patient after 1 hour in this position. This guide was the original guide on which he was working. He sent the patient with the guide catheter engaged to the left main. So this is what we got. There is a stent balloon that is undeflated, that's not been deflated, lying across the left main and LAD, and the wire is still intact, but the balloon is not deflating. The stent balloon is still there. The stent has been placed, but the balloon is not deflating anyhow, and it's just across left main and LAD. What do you do now? We tried that. We tried the hard end of the wire. We tried to put, many a times, hardened the wire. Suppose there are two scenarios. This stent balloon has broken. So the other things you cannot do, but if this balloon does not deflate, be it stent balloon or any other balloon, then a couple of tricks you can do. Of course, you can try multiple times, pull back, but you can give some warm saline inside. Sometimes it's the clot and all that has got stuck in the lumen and it does not dissolve. But that thing was not possible here because the shaft had broken of the balloon. And you see, you can't see any shaft, but it's broken. So we took we try to poke it with the back end of the wire. You know what's the problem with poking with the back end of the wire? Actually, it's not radio opaque, so you really don't know where you are poking, and you can actually poke in the left main. So that's the problem with that. But we tried it, but we were not successful. We tried every possible thing. We took a couple of wires to the side branches and to the side of the stent and tried to put in another balloon and press it to deflate it. It got deflated a bit, but it did not work also. Then we tried to puncture it with harder wires, Conquest Pro and everything, so that maybe a hard wire, straight tip will puncture the balloon. You know, balloon is a very thick, sort of a thing, and the shoulders are rounded. As soon as you put a puncture, it will slip and go to the side, and probably you will puncture the artery. You understand, guy in balloons? So it's not really possible. It's not a flat surface that you can puncture. As soon as you puncture, it will slip and go to the artery. That was another risk happening. Now, this is something that we knew, but in the heat of the moment, we had forgotten. Suppose the stent balloon or any balloon has broken down. Which is the place where the balloon is most likely to break? Any guesses? Every time you are putting the balloon, sometimes you're putting Oxford balloons, there is one particular point in which the balloon is quite angulated and it's quite difficult. What's that point? This is a very important lesson for you, this case. You'll remember it someday when you get caught. Anyone?
Site where we prepare the balloon.
Side where you?
Prepare the balloon at the very end, at the proximal end.
At the very distal end, you mean?
Distal end.
No, that's not where it happened. Many a times when you are putting the balloon on the wire, you'll note there is sharp angulation at one point, a little away from the balloon. What's that point? It's a point where you have the shaft meeting the monorail, where the wire comes out. Many a times you see when the wire which is coming out and you're using Oxford balloon, it kind of is bent, it's sharply bent. And that's the point, otherwise when you are pulling the wire, pulling the balloon, that's the joint between the shaft and wherever the monorail is ending and your wire is coming out from the back. That's the point it makes. That means if the monorail was somewhere here, it implies that there would be some shaft left inside the guiding catheter, because the guiding catheter has never been taken out. Do you understand what I'm trying to say? Suppose this balloon has broken, this much shaft must be inside the catheter, but we cannot see it because it is not radio opaque. But the balloon is likely to break. We knew this fact, but we had forgotten, and that's why we struggled. All you needed to do, and this will help you sometime in future, all you needed to do is put a second wire side, put a second balloon, trap the shaft, even if you can't see it, and just pull out the whole assembly. And this is what we did. We have trapped the shaft you can't see any shaft because it's not radio opaque, but it is broken from here, so up till this end, and you just completely trapped it, and you pull the entire assembly out. So this is something that will probably save you someday. Always remember that whenever the balloon will break, it will break from the joint between the shaft and the monorail and the end of the monorail. And ultimately, you went back and completed the procedure. If nothing works, then you call your vascular surgeon and ask them, have any of you seen this happening in your lab? But having said that, you will have many stents still floating around in the radial artery without any complications. So in worst case, you, I mean, quote unquote, don't quote me anyway, but you can leave it because it get knocked off and nothing will happen. So it's there. One case probably, it's not playing on the PowerPoint, but it's probably there with me. Let's see if is it coming? Can you mirror the screen? Can you screen mirror? Very interesting, sir. I tried it twice actually. Although not recommended. Although not recommended, but twice I have taken out stents without, from the hand, without giving, a surgical incision. So the hypothesis is that the stent, if you're not able to pull in the guide, you're also sometimes not able to put in the sheath because you can't. The radial sheath is very small, and it gets stuck at the mouth of the sheath. So what I've tried is that you give a small incision in the skin so that there is little tissue between the artery and the skin. And you just pull it under fluoro, keep the stent just at the tip of the sheath and just pull the entire assembly back. Wait for a second, allow the patient to relax, and then swiftly pull the entire thing out. By the time the artery gets to close on after the sheath is out, the artery will tend to get into spasm and catch the stent. But by the time it's happened, if you do it in a fraction of a second, a couple of metal strips come out of that suture and you can simply pull it by hand. And we have done it twice and it's not happening. Yeah. It's coming. Okay. See, the same thing happening. There's no surgical scar, but I have given a small nick so that the skin is free. And you can sip. You played something from there. If you don't give the nick, the stent will get stuck somewhere between the artery and the skin. So you just give a nick so that there's no resistance between the artery and the skin. I think we'll try for 10 seconds more and then we'll quit. Close.
Thank you, Rishi. Great cases. I think a lot of learning. And nowadays, youngsters, Rishi, one more thing I learned is, one more, youngsters are exposed to these things. They come up with solutions because they have seen in their labs too.
Yeah.
So I think they're quite commendable because some of the basics, if you ask them, are fumble, but these things sometimes they're coming up. Even in that ASCII type things also, no? The latest things we ask in the interventions, they come up with answers. But if you ask something basics about tracings and all, they might fumble a little. But anyway, great cases, congratulations. And thanks for all the patients, saving all those patients. They would like to felicitate. Just a minute on the stage. And then we'll go on to the next talk of ISR. That is another big problem. I think after that, I think we'll have some discussion.
Hello. Thank you very much, sir, for taking us through these wonderful cases. Definitely, it's. I request Dr. Srinivas, sir, to please felicitate Dr. Rishi Sethi with bouquet, memento, and a shawl. Let's move to the next part. Next topic is instant thrombosis and restenosis prevention and management. For this, we are having Dr. Bishwajit Majumdar. Dr. Bishwajit Majumdar, he is a professor and HOD cardiology, RG Kar Medical College and Hospital, Kolkata, West Bengal. Dr. Bishwajit Majumdar possesses extensive expertise in interventional cardiology, clinical cardiology, cardiac electrophysiology, and cardiovascular research. University gold medalist with 5 gold medals. He is the first rank MD entrance examination, University of Calcutta. First rank in DM cardiology entrance examination 2002 and first position in DM cardiology final exam 2005 from IPGM and R Kolkata. Has authored and co-authored 170 plus scientific publications in leading national and international peer-reviewed medical journal. Actively involved in DM cardiology training, postgraduate education and academic curriculum development. A regular faculty member, keynote speaker and the panelist at major national and international cardiovascular conferences and scientific forums. Recognized for his contributions to cardiovascular research, interventional cardiology and medical education in India. Leading clinical services, intervention, cath lab procedures, academic administration and postgraduate specialty training. So with this, I would like to hand over the session to Dr. Bishwajit Majumdar. Yes, sir, over to you.
Thank you. Thank you, Dr. Srinivas and the Lupin and organizing team for inviting me. And this is the last session. I think this is a very extensive day of discussion and it will be very helpful for the students and the postgraduate, postdoctoral students also. The previous speakers have done a great job. Now my talk is on stent thrombosis and stent restenosis prevention and management. It is a relatively large topic. I try to sum up as short as possible, keeping the salient points only. Moving. This one, no? This will move in this one. This is not moving. No. So, despite the development of the interventional cardiology in the coronary part, stent thrombosis and stent restenosis is still a quite big problem. Now, this is in summary. I am not going in detail in the history of the intervention. Now, just going to what is the definition of stent thrombosis? The formation of the thrombus within a previously implanted stent or within 5 mm proximal or distal to the stent. The clinical consequences usually STEMI, NSTEMI, it may be sudden cardiac death or cardiogenic shock. And in stent restenosis definition is angiographically more than 50% diameter stenosis occurring within the stent or within 5 mm of either stent edge. These are the data of epidemiology. Obviously, with the availability of the days, both are restenosis rate is definitely going down, but still it can occur in spite of the imaging availability because we cannot do all the procedure by image guided. This is the definition of the ARC. Stent thrombosis, angiographic confirmation of the thrombus within the stent or within 5 mm of the stent, pathological confirmation of the autopsy, probable stent thrombosis, unexplained death within the 30 days after PCI, or target vessel myocardial devascularization without angiographic confirmation. Possible any unexplained death occurring more than 30 days after PCI. These are the classification according to timing. Acute stent thrombosis that occurs within 24 hours. It may be subacute, more than 24 hours to 30 days. Late, more than 30 days to 1 year. Very late, more than 1 year. The important cause of very late is now becoming important because the evaluated this. The main cause are new atherosclerosis, stent fracture, late acquired malapposition and plaque rupture. This is the pathogenesis of stent thrombosis. I think everybody knows these three towers, triad of Virchow. I am not going in detail. Now this is the important slide showing early versus late stent thrombosis. The early versus stent thrombosis mainly because of the stent under expansion, edge dissection, tissue collapse, residual thrombus, inadequate pharmacotherapy, slow flow or no reflow. And the late and very late is mainly delayed endothelialization, new atherosclerosis, late acquired malappositions, stent fracture, polymer hypersensitivity, and plaque rupture. These are the risk factors. I am not going in detail. There are some patient-related factors also, apart from the procedural factor and recent-related factor like diabetes mellitus, chronic kidney disease, ACS, reduced EF cell death. Smoking is also important. Now, prevention of stent thrombosis. Before PCI, careful patient selection, that is the most important. Adequate loading with the aspirin, and we all do. But most important during PCI, thorough recent preparation, that is the most important thing. Appropriate stent sizing, that is also very important. High pressure non-compliant balloon post-dilatation, because majority of the causes of stent inflammation is because of the technical part. And if possible, image guided when necessary, especially already we have discussed in left main bifurcation and instant stenosis. These are the case where imaging is must. And after PCI, adherence to the guideline directed DAPT therapy is also important. These are the dual interpolation therapy. I am not going, already one session was there. Now these are the clinical presentation of the stent thrombosis. Acute presentation may be sudden severe chest pain, MI, end-stage cardiogenic shock, ventricular tachycardia. There may be some ECG changes like ST elevation, new bundle branch block, ventricular arrhythmia, laboratory finding. I think these are all common factor everybody knows. Diagnosis: demonstrate internumilian thrombus, complete occlusion, TIMI flow. Mechanical abnormality, intercoronary imaging identifies the mechanism of the stent thrombosis in more than 90% of cases and should be used whatever possible. So in case of stent thrombosis, during management, imaging is very important because we have to know why stent thrombosis is occurring. Then that will guide the next time of management. Regarding OCT, IVAS, already dedicated session is done. I am not going in detail where OCT is better, where IVAS is better. But one thing is important, if patient is very ill, we should prefer IVAS. Already Dr. Srinivas sir has told. These are the comparative data. I am not going this part. The management of stent thrombosis, immediate goal restore TIMI flow, loading, wiring, thrombus aspiration, balloon angioplasty, then intercoronary imaging and try to find out the cause. Then we have to correct the mechanical abnormality, because majority of the cases there is some mechanical problem. If there is underexpanded stent, high pressure NC balloon, sometimes resistant under expansion can occur. There lies the problem. There may be some role of IVL, LCA, or a rotational atherectomy, etc. Malapposition, balloon optimization, additional stent may be required, but always we should try not to put an additional stent. Edge dissection, sometimes additional stent may be required. Residual thrombus, we have to do thrombectomy or GP2B3A inhibitor. But if there is stent fracture, repeat DACE is almost always required. And if there is new atherosclerosis, either DCB or DACE. Already I have told this slide, I am not going. These are the anticoagulation. I think these are not very important. Now coming to the instant restenosis. So almost all the part of stent thrombosis and restenosis has a similarity, but the problem lies This is a chronic presentation. Usually patient presents with angina or LV dysfunction like shots, but stent thrombosis is usually very much acute presentation. While stent thrombosis is an acute thrombotic complication, stent restenosis represent a chronic healing response characterized by progressive luminal narrowing. Angiographic definition already I have told, more than 50% or more than or equal to 50% diameter stenosis occurring within the stented segment or within the 5 mm proximal or distal to the stent. Clinically, patient presents with usually signs of ischemia, may present with angina, may require repeated revascularization. Imaging is must for management. So epidemiology, these are the data. I am not balloon angioplasty previous, I am not going in detail. This is important, Mehrans angiographic classification. Focal pattern is, one is focal ISR less than 10 mm in length, pattern 2 diffuse more than 10 mm length and confined within the stent border, pattern 3 diffuse beyond stent more than 10 mm length, and pattern 4 is complete occlusion. This is a very important classification because here we can see the mechanism also. The mechanical stent under expansion, that is called type 1, stent fracture type B. We can see the management strategy also in the right side. Type B is biologic, type 2A neointimal hyperplasia, type 2B is neoatherosclerosis, and type C is neoatherosclerosis that is calcified. And type 3 is mixed pattern, type 4 is chronic total occlusion, and type 5 more than 2 layers of stent. Now what is the pathophysiology? Falling stent implantation, inflammatory response, platelet activation, growth factor release, smooth muscle cell migration, proliferation, extracellular deposition, and neointimal hyperplasia. Late ISR usually because of neoatherosclerosis, and late complication may be because of the neoatherosclerosis. Sometimes plaque rupture can occur, and that is an important cause of late stent thrombosis also. So these are the risk factors almost like stent thrombosis, some patient-related risk factor, lesion-related risk factor, and main factor is mechanical, under-expansion, malapposition, geographical miss, age injury, inadequate lesion preparation, etc. And you have to assess by OCT or IVAS. Already this part has been taken care of. I am not going in detail. So key concept before treatment, before treating ISR, answer the question, 4 questions. Is the stent is adequately expanded? Is there is neoatherosclerosis? Is there is calcification? And how many stent layers are present? These 4 points will give how we will manage. So principles of management, primary objective for ISR treatment is to restore the maximal luminal area while minimizing recurrent stenosis, relieve the myocardial ischemia, reduce target lesion revascularization, avoid additional unnecessary metal layer. These are the various foundational therapy for successful PCI, non-compliant balloon dilatation, cutting balloon, scoring balloon. Scoring balloon clinical indication is resistant fibrotic instant restenosis, balloon resistant lesion, and under-expanded stent before DCB or DES. Drug-coated balloon mechanism, balloon inflation, drug transfer to the vessel wall, inhibition of the smooth muscle proliferation, reduce neointimal growth. Ideal indication, BMS ISR, hardly we see, DES ISR with adequate stent expansion, small vessel, multiple previous layer stents, and a patient with high bleeding leads. Limitation, required optimal lesion preparation, residual stenosis should be generally less than 30%. Drug-eluting stent for ISR, preferred situation is focal ISR, large vessel diameter, age restenosis, stent fracture, and significant residual recoil after balloon angioplasty. The limitation is additional metal layer, increased complexity of the future PCI, high risk of recurrent multi-layer ISR. Implanting a third metallic layer should generally be avoided whenever possible. There is a concept of hetero or homodes that is not very much useful, that if we use sirolimus, we can use everolimus or everolimus to other, but that has not, data has not shown that is a very useful strategy. And this is an important slide where we should choose DCB and where we choose DES. And what is the advantage? Additional metal in DCB is not required. DES, always there is additional metal. Acute lumen glare is moderate in DCB. In DES, excellent. Future PCI easier. In DES, more difficult. Restenosis slightly higher in DCB. DES lowest. Repeat TLR slightly higher. DES is lowest. DES there is acute, greater acute lumen gain, lower repeat TLR, focal and edge ISR. DCB avoid another metallic layer, comparable to long-term safety and excellent option for recurrent ISR. Sometimes rotational atherectomy is also required, especially in severe calcific under expansion, balloon uncrossable lesion and resistant ISR. Intravascular lithotripsy may be sometimes required in calcified neoatherosclerosis, undilatable ISR, and calcification mediated DES failure. Brachytherapy sometimes required, not very centers are well equipped, only use reserved for recurrent DES ISR, more than 2 metallic stent layer. Coronary bypass grafting may be required in left ment ISR, ostial LED ISR, diffuse proliferative ISR, recurrent ISR despite PCI procedure, multivessel coronary artery disease, and 3 or more metallic stents. These are the trial that shows benefit in DES ISR management. So, stent thrombosis management algorithm, under expansion, high pressure NC, maloposition, balloon optimization, edge dissection, new generation DES, residual thrombus, thrombectomy, neoatherosclerosis, DCB or DES, stent fracture, repeat DES or CABG. In-stent stenosis management, under expansion, NC balloon, stent fracture, repeat DES, malposition, balloon optimization. Biologic cause, new generation DES, diffuse ISR, DCB, DES, multiple layer preferred DCB, recurrent ISR, IVBT or CABG. Future prediction, drug already or intercoronary calcium modification, precision medicine and research priorities. So take home message, stent thrombosis is uncommon but potentially fatal. Early stent thrombosis is predominantly procedural, whereas late stent thrombosis is mainly biological. Premature discontinuation of DIPT is one of the strongest predictors of stent thrombosis. IVAS OCT identifies the underlying mechanism in most cases. Prevention through optimal PCI technique is superior to treatment. In-stent restenosis, neointimal hyperplasia predominates. Intercoronary imaging should be given to all PCI where possible. DCB and contemporary DES remains the preferred treatment, avoiding multiple metallic stent layers whatever possible. Thank you.
Thank you very much, sir, for taking us through this wonderful session. I request Dr. Srinivas Kumar to felicitate Dr. Mujumdar with memento, shawl, and bouquet. Srinivas, he will take us through some complicated cases, and after that there will be some free chat session with Dr. Srinivas Kumar, Dr. Rishi Sethi, then Dr. Narayan Swamy and Dr. Kaparadi as well. So over to you, sir.
Yeah, good evening, friends. I think I really appreciate your patience and still sitting, but I promise you this last 15-20 minutes will be very useful to you. Briefly, first 5 minutes, just for sake of completion, I will just talk for about a few slides and take you through the complications talk which I was supposed to deliver before. And then the interesting part I feel would be discussing about what is written in their, I think, career counseling and work-life balance and life counseling. There's no big counselor who's coming, but let us discuss with each other. And when I try to identify, and along with Lupin colleagues, somebody to go, it has become a big practice now, it looks like. They're charging more than a senior cardiologist for half an hour, 1 hour talks. I thought, what is so great, we can as well do it ourselves. But I'll see how to do it. Before that, I just wanted to briefly highlight, is it not coming there? Briefly highlight complications in a broad way, and how to tackle each of it locally, each speaker would speak. So basically, complications that you understand in a cath lab could be non-cardiac or cardiac. Non-cardiac, this is a vascular access complications, contrast-related problems, radiation injury, and these things, the vascular access complication, will touch upon in tomorrow's access session. And then non-coronary, this is important for us to be comfortable. I think most of you must have experienced hypotension, which happens with the first shot, or nothing is done. Patient is just taken on table, ECGs are fixed, patient went into hypotension. All of you must have faced it, no? If somebody says you have not seen it, that means you are not exposed enough. What is the reason, commonest cause for hypotension? Vasovagal reactions. Patient gets pain. The sister or somebody puts a leads or pulls it out, or you poking with without proper sedation, and puncture sites itself, patients are anxious, goes to hypotension, vasovagal. Then myocardial infarction, suddenly one contrast shot, artery gets occluded, and then he goes into MI. And arrhythmias, especially when the patient comes in first 1 hour of acute MI, be careful. It tries to develop primary VTVFs. And tamponade is another problem which inadvertently, I'll show you 1 or 2 case examples of perforation rupture. Then coronary ones, I think dissections, everybody must have seen, but most dreadful one is air embolism. I think inadvertently somebody has injected air, it produces so much havoc. I think all the presentations, many of you must have seen, and take all precautions. The most important precaution is get the catheter leak back, and always we are very obsessive about flushing it without injecting, so that saves a lot of trouble. Extra 2-3 times you check. Again, spasm, other things are there. So this is basically the perforation equipment class. I think Rishi has covered. I'll just briefly show 1 or 2 case examples of perforation if you have patients. Otherwise, we'll go on to the other important discussion. So how to prepare for complications is also important. Never get panicked. And you need to take care of your mind, knowledge and attitude. Many of you are quite knowledgeable, but suddenly something happens, your brain stops working. And this group practice and team practice and 2 seniors doing the procedure will help a long way because the person who is directly taking care of patient is under a little more stress, what I have noticed. Our colleague who is equally experienced, his mind doesn't get bothered so much when it happens. Please understand this concept if you can follow. The problem is we won't work together. That is the problem. So body, eat well. No, nowadays don't do too much exercise, and nowadays eccentric eatings. So you don't even eat well and go to labs to do night and problems. So you take care of yourself with proper discipline, and then mind, knowledge. Again, just don't see what is coming in social media and try to do it there. Become comfortable in doing a procedure, or team up with one of the senior colleagues, then only do procedure. And then mind attitude is very important. Never get bogged up with something happens, because there's always a solution. And if there's no problem means there's no life only. Generally, it comes. So whenever complication happens, immediately after managing yourself, you call for help. There's nothing ego, nothing, patient is top. So it is important not to get agitated. Do not agitate, become restless, do not out of panic, don't shout on the staff, other things, and then maintain your calm and be open to communication. Sometimes the cath lab tech itself could give some important advice. So please maintain that. That's a broad principle of whenever something is happening. And regarding this, perforations is another important thing which I think nobody spoke, and entrapment, other things are spoken. I will show a few examples of perforation and then I will stop. So perforation is basically, it could be depending upon how severe it is. I think many of you are start taking pictures. I would encourage all of you, if you're interested, to go through yourself, it is okay. But we'll provide everything. My philosophy is everything is there in our foundation, faxfoundation.in or acvs.in, all the materials, even the Lupin people who distribute. Knowledge should be free. Whatever is there, whatever my talks, whatever, everything is available free on the net, even in downloadable format. Videos are also uploaded. Anything you want to take, you can take. But please concentrate while talking, because it's important. Then mechanism, location, where the perforation has happened is very important. Compared to distal, somewhere a total perforation, it has a different connotation compared to large vessel perforation. And the type of perforation becomes important because the basic idea is how much it is leaking. That's what we want to know. Coronary perforations, depending upon that, need not worry too much about what type of it is. Supposed to know that distal perforation is type 5. Don't ignore even it is a minor distal perforation, because it keeps on accumulating with heparin and patient is going to tamponade. Be careful. Follow this. Avoid. Best way is to prevent perforation happening. How do you do that? Especially if the patient is frail, female, elderly, be more careful. Patients have acute MI, ACS, again, is slightly more prone to complications compared to calcific lesions, though whatever you are doing, still human body is great, it tolerates. But acute MI, ACS is different. Lesion factors, again, tortuosities, tapering vessels, calcific lesions, bifurcations, again, are a little more prone to problems. And I would say, nowadays, Apollo, as such as a group, we stopped using reused balloons, material reuse, unless patient is some low scheme patient, which happens in medical college. In the main hospitals, we don't reuse. Significant problems could be avoided if you avoid the reused materials. Nowadays, materials have become very cheap. We don't save too much also. In the process of reusing material, you produce more problems and more, significantly it comes down. And the balloon selection becomes very important. Never exceed the size of the balloon compared to artery. Always slightly be on the lower side. If it is 1:1, it's generally less problematic. If you go more, especially when you're taking more pressure, high pressure balloons like OP and cutting balloons, be lower on the balloon size, please. Pressure you can go up, but size you have to lesser in. But if you take a bigger size balloon and inflate it in higher pressure, that's a milieu to get into perforation. Then never remove the balloon totally before you check with a contrast puff. This is important. Immediately you can tamponade if it is happening. I think many of you have this habit. Continue to do that habit. Hydrophilic wires, though easy to cross, that's why we recommend once the stiffer wire, a hydrophilic fielder XT or whisper type of wire, once it has done the job, you exchange it to your regular workhorse wire, because of that wire, unless your assistant is holding it, it tends to go deep and perforates the distal wire perforation. So this is what I said, immediately when the perforation happens, you seal it with the balloon, then probably continue to give vasodilatory IV fluids and pericardiocentesis. You need to be comfortable, and many of us are forgetting how to do it, but in times of problems it's always better. And then always inform surgeons, not that you'll immediately ask him to take up a procedure, let him have some coffee in the console room, because sometimes it's good to treat our surgeons well. And then monitor the patient, and then how hemodynamically is behaving, that will help us to immediately act or wait. The large vessel perforation, there's no way that the patient becomes stable. And you always need to keep a covered stent on shelf, and initially balloon tamponade, then get the covered stent. Covered stents nowadays, Papyrus is a very good covered stent of Biotronics. It goes through 5 French also. Sometimes it's not available, but they want to come in a big way. In our country, Teleflex, the only condition we put in our cath lab is once you put that covered stent only, we will use the regular stents we said, then now they have made it available. But otherwise, the Abbott's vascular, the covered stent Flex Master is there. But generally, again, so the vessel is too distal vessel perforation, you can embolize it. There's nothing great about occluding the vessel. Whatever types of thing you want to push it, you can do it. I won't go into details of all this, but basically suffice to say that type 1 perforation sometimes could be sealed, and post-procedure again keep watching. And this sort of tracing coming, you be mindful of it. It could indicate future problems of pulsus paradoxes. You see that sometimes branches perforate distally also could lead to problems. This is fielder XT type of wire. That's why we recommend once it is done, remove it. So for sake of time, I can't go into details, but whatever little doubt you have, always be careful, monitor distally. Entire procedure could do well, but suddenly the wire could develop perforation there, and keep a watch, and the regular doing echocardiograms and the post-procedure is very important. See that if it develops very minimal effusion, also keep a watch, don't give heparin, and then probably pericardial trap done, and then patients improve. The little more bigger perforations, then that's where you end up putting immediate balloon inflations. I think the other method to have a second guide catheter and a covered stent goes a long way. This double guide technique, many of you must be aware. For sake of time, the one which don't lose the axis, take another guide catheter through femoral artery and then have a ping pong by technique. And the type of covered stent, which what I was mentioning, graft matter is readily available, difficult, and the papyrus is easily there. And the papyrus is a good covered stent which goes to 5 French. If available, always take it. And that's how we need to immediately apply. And then covered stent delivery also sometimes could be leading to challenge. That's where you take help of guide liner or other materials, whatever you have, telescope or whatever you have, and then do it. The perforation sometimes is such big, but patient becomes unstable ischemic wise also. You tend to even do the procedure as well during that time, and sometimes it both gets sealed off, and you could still manage both revascularization as well as such sort of perforation in the same sitting. But generally try to avoid putting a stent when the patient has developed perforation. Various types of materials are available. Whatever, if nothing is available, you can take the coiled wire out and then embolize it with fat, and that's how I think we can. The other examples are there. I won't go into details for the sake of time, but basically I've shown examples of various other types. Stent under expansions, calcium are as shown already. So what I wanted to just make it clear to all of you is never panic and call for help. And again, two people's mind working together always can avoid complications better. So that is, I think, broadly I wanted to mention about complications. I will close. And then now I'll take you to another interesting aspect which many of you wanted. I think can you close this?
Before this, I would like to request Dr. Srinivas Kumar to please felicitate Dr. Narayan Swamy for chairing the session. Please, sir. After this, there will be the live session which will cover the career and life counseling. So here, Dr. Rishi Sethi, then Dr. Narayan Swamy, and Dr. Srinivas Kumar. They will be
to wake some of you up who are sleeping, I will tell you one real anecdote in complications. Okay, please, this is real. I am not exaggerating what has happened. In acute MIs, sometimes we do emergency procedures. Sir, please 1 minute. So we do emergency procedures, and then probably next day patients' attendants come. Generally patients improve, nothing happens, they pay and go. Sometimes there's a problem, sometimes you could face payments problems. But here they were okay. But next day as one patient was improving, the attendant came and said, was it required to stent and all that, you unnecessarily stented. This has become a tamasha nowadays, no? So one of our senior colleague, I'm not naming it, he's very good in handling such things. He comes and tells, okay, you don't want stent, huh? Okay, we'll remove the stent. Come on, take it out, stent. And he told our junior cardiologist and he left. Then patients' attendants were again requesting, no, don't remove stent, sir, don't remove stent, sir. So this percutaneous stent removal, I just titled it. I had one of the cases, I'm not getting it to show, but it happened real once, in the sense that one patient was stented some time back, and there's a wire passed, again it became CTO, a second wire was passed inadvertently. The patient stent was put in again in it without removing the wire. So wire was locked in with the 2 stent layers. Please be mindful of it. Wire getting locked between the stent and the wall is different. It comes out easily. But if it is getting stuck in between 2 stent layers, the old stent 6 months back, again you put a new stent, or sometimes wires get entangled, it doesn't come easily. So somebody wanted to pull it out, with force they pulled it out. The old stent, new stent, both came back to the guide. And luckily human body is so great, some erotic, some light thrombus hanging like was there, we sealed it with another new stent, taking everything. So that we called it the percutaneous stent removal of old one. So human body is such great, it absorbs a lot of nonsense, what all we do. I think that's a greatness, but all of us should respect and try to avoid such complications. This is the real thing what has happened. Thank you.
Thank you, sir. opening the session. With bouquet and sir, please wait, sir. Thank you very much. One more actually two announcements. First one is that there are 30 plus doctors, they don't have registered themselves. So outside there are counter is there. So please register yourself. 30 plus doctors, they don't have done the registration. Then for this today's session, we are having 2 CME credit points. I also request those doctors, those means not have registered for CME points, please go and do that also. So over to you, Dr. Srinivas and Dr. Rishi Sethi for live session.
Rishi will make something interesting for
Yes,
them.
yes,
You're
yes.
too good at it. I'll also try to follow.
I'm also curious about what we are about to do.
No, because I tried to contact some people. I thought ridiculously expensive. So my idea was for the youngsters, we should advise them something in career counseling, life and all that by some so-called philosophers or experts or what do you call professional development people. I said the entire budget of the thing is different and their budget is becoming that much. I said it is ridiculous, stupid. We'll try something. Okay. So before.
But my residents are smiling because they say that we have to deal with the same thing every day in the department, and now today evening we have to deal with the same thing.
Okay.
Every single day this goes on the rounds.
Then this I'll just briefly talk before your boss talks, and then probably we'll take input from seniors like Narayan Swami, and then things like that. Can you project this, please? I always wanted to make this a point to tell to juniors somewhere regarding the work-life balance, what you call and how to divide your work and time, things like that. But there's somebody was telling there's nothing like work and life balance because life and work are same for us, and various other things, philosophies go. But basically in young careers, to improve your career building initially and to not to get into troubles, because nowadays it's become important. And our thing is basically what is becoming a problem is we are like film actors. If you are there only, everything goes around you. If you are not there, nothing happens. Neither corporate hospitals take care. So anybody, you should take care of your health well and then probably maintain yourself well. And the 5 ways of initial career is basically you need to be available always. That's what, if you are available to patients, affable, able, again, you learn the technique properly and the approachable, accountable. These are important for you to improve and progress in life. But happiness and progress is something which is philosophically different for each person. And one thing I'm for sure with experience of whatever we are telling is, money is not everything which gives happiness. And after seeing 30 years of career, the more richer, the more problems. So beyond a point, money becomes troublesome. So there's a saying in that, I don't know how many have seen that scam, Harshad Mehta in The Last Before Death, and he lies down on the chair, he says, that's what has spoiled me. So happiness is a relative thing, and people where you are associated with, and the mentors, then where your working practice, where you spend more time there, gives us more happiness than the real money. Money can give you comforts, that is different, not happiness. Please be mindful of it. And then when you do practice sincerely, I think God and everybody will cooperate with us. Unknowingly, you may do mistakes. But you remember any things happened where some misjudgment or something, but unknowingly done, God will excuse, patient will not have problem. But knowingly something is done wrong, that's where you land into troubles. Patients are not commodities, please. Don't try to experiment on patients and try to do patients like it's not a theory. Really, I feel, how do you treat our own family members, you treat it, a lot of things are taken care. At the same time, you don't get attached too much because sometimes the complications happen, suddenly you get disturbed too much. So, but initially, strategies for success I would see is avoid mortality in the first. Whatever you can do, especially on a single center owned, once you pass out, then avoid taking too much complicated cases, at least till you finish 100 cases. And this, whether to do it or not, always take the help and probably develop mentor or senior colleague. Where you have a doubt, you always take an opinion. And then do not be afraid to ask for help, that's what I said. And if you are planning something, it doesn't work out, plan B also, you can keep it in the lab. And when the cath lab is there with another help or colleagues, though it be cath lab technician sometimes, again you always take the help so as to avoid the embarrassments and problems. Then once you become comfortable with doing 100 plus procedures, automatically you get to gain some confidence. That's how I think you can gradually improve upon, take a little more complicated cases, and always be friendly with your staff. And the associated scrub nurse or brother or sister goes a long way in preventing complications, especially in times of stress. Otherwise, she'll also give you something with air, you inject, and a lot of problems. But unfortunately, situations in our hospitals are so skewed up. There's a lot of differences of payments and reimbursements to those. Compared to XYZ, whose stupid sister or brother also gets paid the same, who has a lot of challenges in our country, but we have to fight with the system. This is about working things and being available and being honest, sincere, and committed to patients. And I feel always there is somebody who's watching. And if you do with good intentions, God will take care of it. All the good things will happen. But some things, when start taking patients doing procedures wrongly and things like that, then it will come back. If you do good to patients, good things will happen to us. Work-life balance and all this is again individualized thing. And each of you have your own methods. I can't advise you on all, but one size does not fit all. Somebody works morning, somebody works late. Sometimes in cath lab, in Apollo type of hospitals, because of work schedules, somebody cath lab is given in night, morning, all that you have to adjust and leave to yourself. And the better half cooperation, especially of families, becomes extremely important. I'll tell you one joke, which I keep telling, my wife keeps telling to others. There are instances where we left them and took the car away or to do a primary PCI. Many times he has to go in autos and to go back to home. That also happens. That's why I always keep telling a lot of importance also to our better halves, and we should be thankful to our family members too. Then many of the times people ask this question, whether academic practice being in institutes like PGI is better or being like in Apollo Hospital is better. So again, that is also, there is no best thing possible. And ideally, probably you could have better of everything. That's what we want. And we try to simulate it in a group practice. There are some advantages of academic institute, some advantages of corporate hospital. I need to go into detail of all this, but you can see the slides in detail because running short of time. So what is possible in industry, always maintain good relationship with our colleagues and be nice with our industry friends too, and always maintain good relation with hospital management because a lot of things go hand in hand. So what is ideal setup? Basically combination of both. And that's how we started our group practice. We're a group of 25, 30 cardiologists. We run services in multiple hospitals. And then with each of us working as a colleague, they are networking of our own friends. The complex towers, left mains, anything like that, they all get from the smaller hospitals to bigger hospitals. Like that, they get trained. Once he gets more experience, he can take a few more hospitals. Fortunately, many of our age group doctors have started their own centers and they're requesting us to cover up hospitals. That's how the group gets expanded. But some short-sighted people who can't share resources might get separated away, don't get deterred. Nowadays, we also give a lot of financial independence to work at a networking level. So that's how I think even if you do good practice, there's a good amount of money in cardiology. And how much ever wrong things you do, you can become Ambanis in our profession. Please be mindful of it and do what do you think is right for the patient and what you feel is the optimal for work-life balance and develop it yourself. And obviously, you need to maintain the human touch with patients, be it AI, cardiology or anything, and it can't replace us. Fortunately, there's no AI which can do stenting as of now in the coming decade or coming 3 decades. I think you're fortunate. You wish you should have all this, but sometimes you may be fortunate to have it. Don't go by physical comforts. But even if we have only this, still we keep doing to our good expectations and enjoy our work and be wiseful and joyful. I think this is what I thought I would just share my thoughts, and take some inputs from Rishi also regarding what he does, some advices to youngsters, and then success mantra I'll tell in the last 4 or 5 minutes what at least I learned, and what these personality development so-called speakers are talking, that also I'll tell you once Rishi says something. Thank you again for all of you, and thank you Lupin for making this possible. And then I really love to respect all of you. Staying at 9 o'clock, still everybody is there. I really appreciate. Thank you all. Rishi, you can say a few words.
Are we taking the questions or
whatever forms?
Yeah.
What I thought is open
that's what I'm
session,
saying. I mean, if they
and
want
then
to ask something,
probably you need not go to your fellows. I will go to your fellows.
Huh?
You are worried, no, the same thing happening. You don't go to your fellows of KGMC. I will go there. You go to some other.
Anyone, if you have any question about life, non-cardiology, if you want to take some experience of some gray hairs, whatever we have got. I think one thing defines, and that is what we tell all there's no doubt that you have to learn every possible skill that is available out there. You may choose to remain in coronary, or many of you will be focusing on structural now as it is going, or many of you would like to go into pediatric or electrophysiology. Whatever substream you choose, learn every possible trick of the trade in the first 3, 4, 5 years. Just don't bother about money and all. Just find a good mentor, good hospital which gives you a lot of volume of work. Learn everything. But as Sir was saying, having a skill and using a skill recklessly are two different things altogether. A soldier is taught to fire guns, and he's told to have every training on every possible sort of gun that is supposed to be have. But if you don't fire your gun, and the soldier may never fire a gun in an actual battle all his life, but he still knows how to fire a gun. But if you have a gun and you don't know when and where to fire, and if you keep on firing it every day, then instead of soldier, you will become terrorists. And there are a lot of examples in front of us that probably we are observing, that the practice pattern is going away from patient-centric approach to the hospital and the doctor-centric approach. That is not a viable model at all. Any person in any profession, if you compromise with the core tenets of the profession, you cannot sustain growth, popularity, and fame and respect over a long period of time. So you may have gained short term, you may see people who have used unscrupulous means and got successful, but certainly, I mean, it's not a sustainable model, and certainly as youngsters, you should not try to follow those people. You should also only try to find whoever is so selecting. What I feel, sir, is that in every profession, why our country is suffering is that any profession you take, there are no role models. A politician doesn't have a role model that I want to be like that. A person of judiciary doesn't have a role model, I want to be like that judge, because that everything is going on. Similarly in medicine, if I ask you, like, tell me one cardiologist senior to you in the city that you would like to emulate, probably you'll find it very difficult to answer. I have 1 or 2 names in my mind, but these are again rare. So I think find good role models, maybe not perfect role models you will find these days, but find a role model and try to follow that role model for the first couple of years of your life. And procedures are for patients, but patients are not for procedure. Just because there is a disease in the coronary artery doesn't mean it's a God forbidden duty that you have to correct it. No. Stable angina is like diabetes, it's a very, very stable disease. You make it unstable the moment you try to mess around with it. What's the mortality of stable angina? Annual mortality. Mortality rates, population-based mortality rate.
It's less than 1%, sir.
It's less than 2%,
2%.
1.5 to 2%. What's the population-based mortality without any disease? It's again 1 to 1.5%. So there's hardly any difference. Only when you have a left main disease or a triple vessel disease with LV dysfunctions and things like that, then it's kinds of changes the situation, and that's why you need to have high risk markers in your non-invasive testing when things are going wrong. Suppose you do a pre-anesthetic checkup and the ECG is normal and the patient doesn't have any history of heart failure or MI in recent years. What is one question you will ask and just say clear? Nothing else is needed. No echo and nothing.
Symptoms?
What will you ask? How much? How much you will ask? Just say if you can climb 2 flights of stairs without, in a brisk pace without any symptoms. That corresponds to roughly 5 to 6 minutes of activities.
Yes.
And why is that? Go back again. Why is that? Why is so critical? Because you expect that a person who has a significant left main or a proximal LED or a bad TVD with LV dysfunction would not be asymptomatic at that level of activity, right? So you just have to ensure that in a surrogate manner, without doing a TMT or a stress thallium or a stress echo or a PET or whatever. So you just know that you just rule out a left main disease and anything. But suppose the disease is there, people may ask you, what are the chances? Okay, what are the chances of MI in a, let's say, a 70% disease in the circumflex, which is asymptomatic? Would you treat it or not?
No, sir.
Why?
Sir, we have stable disease. We have the trials backing up.
But the patient may say that I may have a MI later on and I have a 70% disease, you did not treat it.
Optimal medical therapy would be there.
But the patient may say I may have MI from this particular lesion.
No.
How will you counter him?
We show the data, sir.
There are more chances of having a myocardial infarction and a 30% plaque than a 70% plaque. In fact, 70% plaque is the safest because now it's the cold plaques, fibrosis, calcification. That will never cause, that will really cause MI. MIs will happen on lesions which are less than 50% because of the plaque ruptures, or they will happen on critical 90-95% because of the workhouse trial, and there's so thin lumen left that any amount of clot, much easy clot formation. So the lesions between 60 and 80% are the most stable to cause MI. So if they're not causing any symptoms, you will not treat them, with the possible exception of a left main and an ostial and a proximal LED condition. So this is the kind of patient-centric thinking that you have to develop. And until and unless you develop this thought process day in and day out and practice in each and every patient, what's going to happen is that 170% lesion, at some point of time, you'll say, I'll treat. And the other person, you'll say, I'll not treat. You will forget. Maybe you say the two things to the same person on 2 different visits. The first time you said, I will not treat. The second time he comes to the OPD, you say 70%, oh, I need to treat. The patient will catch you that you are lying because you don't have consistency in your thought process, consistency in your vision, consistency in your philosophy of cardiology. So you are not doing DM and DNB cardiology. This is the last thing, I keep on going on and on. But you are not doing DM or DNB in cardiology. That's not the degree you are aiming for. You are working for a dual degree. You're working for an M.Tech in cardiology and M.Phil in cardiology. You need to learn the tricks of the trade, how to do a TPI, how to do an echo, how to do a pericardial synthesis, angiography, angioplasty. That's the M.Tech component that you are learning. And you have to learn the M.Phil component when you should be doing it. But otherwise, every person with ejection fraction of, a little lowish ejection fraction, people are getting CRTs and CRTDs. These are gruesome procedures.
But anyway, Rishi, what I feel is, you treat patient as your own family member.
That's exactly the point.
Most of it is covered.
That is the fine.
Okay, that's how I feel. I take it. If it's our own family member, how do you treat it? Please consider them the same seriousness and try to do. And in your expertise development, try to do what you can do, slightly less than what you can do. That's what we do. And if it's a family member, you always take care of, try to have another help of senior colleague if possible. If you follow all these, the work is done. Regarding the training pattern, somebody was asking, initially don't jump into corporate or individual practice directly if possible. Try to work for 3 to 5 years in a good team, learn more techniques, because cardiology overnight, though training patterns are there for 3 years, you can't learn everything. So another 3-4 years work in a good team. And I kept there career opportunities. If somebody is interested, you can enroll there, and any opportunities will call up. And then probably once you refine little more after 4 or 5 years, and in early part, everybody will do mistakes. So one of my junior colleague was feeling so bad that he did something wrong. I reassured them, mistakes are bound to happen in the first few years, unless you don't, intentionally don't do it. Unintentionally something happens, God will cooperate, we always rectify. That's how the working like a team and the seniors come and help always will happen. That thing, I think. I think we will ask them directly something. Anything you wanted to learn from this course? Your thoughts on this? Please talk.
Good evening, sir. First of all, I have felt very much good that I am Dr. Balwinder Singh from Raipur, Ramakrishna Care, Raipur. It was very nice listening to all the lectures and all your experiences, and I think I'll try to keep that in mind. What you said, that treating patients like your own family members will go a long way. Thank you.
Thank you.
Any question, any doubts, anything that you have? Any thorn in your heart that you want to take out?
You can tell, how do you want to, what is your plan in coming 5 to 10 years for being a successful cardiologist? What do you think? Just to, to learn from juniors.
Good evening, sir. Myself, Dr. Vinesh. I'm from Vizag. So I would like to first emphasize that sir said you should treat every patient as a family member. So that is exactly right. So once the patient steps into your clinic or into your hospital, you should consider him as a family member, not a patient.
Doctor, that stage will also come for you.
Sir, yes.
But what I am asking is, Vinesh, after 10 years, how do you like to see yourself? That's what I asked.
So after 10 years, like I want to settle in, my native is from Nellore, so I want to settle in Nellore. So I want to become one of the best cardiologists in the Nellore.
Good, yeah. I appreciate that and try to work on it. I think
Yes,
everything will fall in place. Congratulations and thanks for sharing your thought. I want each of you to be brief because every day compared to yesterday to tomorrow, it should be something improvement in us. Yes. That's what you plan every day and you will become one day best cardiologist.
Thank you, sir.
Say anything, how do you want to see yourself?
Good evening, sir.
Be comfortable if you want. It's up to you.
I want to practice for, after my completion of my DM, I want to practice under my seniors. Until I get the confidence, I don't want to enter any private practice. Until then, I'll be trained under my seniors, learn from their mistakes, learn from my mistakes. Then I'll step into a private practice.
What do you feel about cardiology?
It is not ever, not any.
We love cardiology, you know, we all should love cardiology. That's why we are here. Cardiology is a beautiful specialty, I feel. You can cater according to interest and age, you can change what your place of work and equally have respect and earning. That's a greatness about cardiology. You want to be dynamic, you can be early in interventional cardiology. You want to restrict yourself to comfortable life, CT, angio, MR, that also you can do. Or if you want to be a clinical cardiologist, do that also is fine. And then later on, you want to modulate to preventive cardiology is coming up way in future. Another good option. So you can always choose love cardiology. There are challenges too. Nowadays, oncology is more respected. I feel very bad when cardiology seats are going vacant. That's a different story. But cardiology is a beautiful specialty, and many times when you save lives and the patients improve, you feel so good about it. All the adrenaline, all the bad things, efforts, what you put in, back pains, everything will go once the patient improves. And that sort of happiness is neurology. What is there? I'm not against neurology too, but they keep giving tablets and all that, nothing. So that sort of opportunity is there in cardiology. That's why I love cardiology. So you should all be proud of being a cardiologist. One more thing I would like to say is some XYZ have the habit of cribbing for everything. Like God has made you cardiologist, man. If you also crib, what is the fate of a normal person on road who doesn't have anything? So never ever crib on life. Yeah, be positive and try to help in whatever ways possible. That's how I take it. And always maintain good relationship with the doctors whom sending patients. Some cardiologists don't even talk to the patient or docs. He also would like to know what is happening. I'm not encouraging referral type of practice and all that, but keep your friends and appraise even the doctor what is happening to the patient. That will go a long way in helping and improving your practice. Right? Anybody else? Some women are dominating everywhere. Anybody from ladies would like to comment? We would like to hear from you. Before we close, what is the timeline, madam?
Last question. Last question. Last
5 minutes more, or you will kill us later if it becomes late too much.
Yeah.
But I would like to hear from any of the better
Last question from one of the ladies. Yeah.
You tell what I told regarding experience of my wife is truth, real. It happened. So, but you also must be facing trouble. Now women in interventions, now a lot of things happen. Equal amount of cooperation is required from husbands too, for females. So there should be also, for every successful woman cardiologist, there should be also a husband who is cooperating, no? So please mention that, because recently I will tell you a story, real story it has happened about 2 weeks back in our hospital. Normally women compete in everything, the women protection is gone, please. The even premenopausal women get into triple vessel disease and problems. One young lady teacher and one of our referring place came with discomfort, and somebody said it is gas, same story, but I told clearly it is angina. We did a procedure, stenting was done, lady improved dramatically. Day 2, day 3, on the table also I checked with the lady, why are you worried so much? Some husbandal, what do you call, financial stress of husband caused that and all, he was telling. Husband was also so touched up, and this is reverse what I am saying. So men are also good sometimes. So this man, the lady was about to be shifted from ICU. On day 2, this man arrested in front of ICU. Husband arrested, then our ER team came. I was doing a procedure inside. They took their massage done continuously, 10 minutes of massage. Suddenly the ECMO people come nowadays, fall on the patient that they want to put ECMO. Then I went there and just saw ECG as ST elevation huge in ECG. After it came back, shocks were given. Then once I saw that ST elevation huge, even the pressure is less, I said, just give me some time. We'll immediately take to cath lab. We opened up the vessel, finally improved, cannula we gave. That's all different story. What I would like to say is, men also are emotional sometimes. When the women got affected, this fellow also, poor chap, suffered. Normally every time we see the reverse. The husbands get admitted, women get into trouble, suddenly they fall and all that. There could be other way also. Both men and women could be different. That's what I just gave this example. And so similarly, every woman also cooperates, but I want to hear any such experiences from any lady cardiologist sitting here, or anything you want to say, madam. Please, for the sake of us, you talk. This Lupin, I should be careful in future. I'm saying nowadays in all panels, all professional things, they're making it a point that you need to give opportunities for women. So, but you didn't get too many women cardiologists here. Maybe overall numbers are less, no? Yeah. That's why I think in undergraduation it's different. 70% are girls, because of they themselves come, and then probably reservation of 30% is also there. But as later on, I think they're casually dwindling in super specialty. But still, a lot of women are doing great work in interventional cardiology too. You can introduce yourself, madam. Just talk few words for our sake, then we close.
Good evening, sir. I'm Dr. Pujita. So I'm in my second year of DM right now. As you rightly said, support of the family.
Can you put it more closer?
Mic.
As you rightly said, sir, support of the family. I'm a mother too, so I have a small kid at home, and my family is taking care of her while I work at my place. And there is a little bit of like doubt still how women perform at work. Like recently I came to know that one of my consultants is saying we were really skeptical like how you would perform initially, like being a woman, how you would do in this cardiology field and all, competing with the male colleagues. But I think we as a woman need to put in a lot more effort to make our work visible at a workplace maybe. And that gap is reducing, and I feel good about this profession. We also love this profession as equally as our colleagues do, and so I
Thank you.
take
We
this
we appreciate your feelings and hope you'll do well. And family cooperation is anyway required for both for husband and wife too. I think it's a long way process. That's what is medicine. But we should enjoy it and do it long. There's no shortcuts to that. And then other secrets of success is basically the passion of work, what you follow. And the precept and practice should go together. You do DM cardiology and you also practice that, you will do better. And then probably our continuous, incessant work is what is required. And there's no end to it. That's what you can say. But you love it and do it, that's how you accept. And then probably money is a bystander. Money will come. I'm not saying it's not important like a communist and things like that. It's important. At the same time, don't go behind it. It will also follow if you keep doing good work. I think all of you are great. Youngsters have a different approach and you're very intelligent. At the same time, attitude also matters a lot. And the attitude of what Rishi told, what we were telling towards patient is most important. And if you follow those, and all of you do well in life. And if I told something wrong, because we didn't get a good speaker on this, we try to compensate. Forgive us if there's anything wrong. But I feel all of us together, combinedly can get great thoughts. That's why I was encouraging youngsters to talk. Youngsters are nowadays great. My daughter, when I was young in first year medicine, she gave me some insights, which I can't tell for sake of time. But it is great. Combinedly, if we can all talk together, we can do much better than all those so-called personality development speakers and all. Thank you again, and thank you, Lupin.
Before going out, I would have some to make some announcements. So tomorrow morning, breakfast will be ready outside this hall, 7:30, and sharp at 9 we will start the tomorrow session. So tomorrow we are starting with Dr. Dharam Kumbani. The very interesting topic, that is antiplatelet therapy guideline 2026. Dr. Dharam Kumbani, he is from Texas, USA. You must be knowing about him. A lot of guidelines he is authored. So now dinner and bar is open for all.
I think Dharam Kambani, many of you know, is making Indians proud. He's the author for our original articles of antiplatelet therapy. He's talking. So request all of you to be in the hall by 8:45. So otherwise we'll miss his talk. Okay? Thank you.
Thank you, sir.
प्रीलोडेड गानों वाला कीपैड फोन धमाकेदार साउंड के साथ कारवा मोबाइल।